Imagine a world where billions of women worldwide suffer silently from a condition that is often misunderstood, misdiagnosed, and mistreated. This isn't just a hypothetical scenario. It's the reality for countless individuals battling with endometriosis. Formerly believed to affect around 10% of the population, recent findings indicate that endometriosis affects over 1 billion individuals globally. I am currently a fellow under the mentorship of Dr. Cameron Najat, specializing in minimally invasive and robotic surgery in gynecology and reproductive surgery with the Society of Laparoscopic and Robotic Surgeons and the American Society for Reproductive Medicine. But I am also an advocate for those whose lives are profoundly impacted by endometriosis. Despite endometriosis' prevalence globally, its significant impact on emotional and physical quality of life, its substantial economic and societal burden, there remains limitations and inconsistencies in recognizing and diagnosing the disease. Developing and supporting movements and organizations like EndoMarch and Access are the first steps in raising awareness about the necessity for endometriosis experts. Training these specialists is the next step in advocating for individuals who suffer from this condition. However, addressing this imperative comes with challenges. There's a shortage of dedicated training programs focused on endometriosis, leaving aspiring specialists with inadequate skills. Additionally, the complexity of the disease requires a comprehensive understanding of its pathophysiology and treatment modalities, which may be challenging to impart within traditional medical education frameworks. Clinical exposure to endometriosis cases during medical training is essential for developing expertise. Yet opportunities for such exposure may be limited, particularly in settings where the condition is underdiagnosed or overlooked. Furthermore, effective management of endometriosis often necessitates a multidisciplinary approach, requiring collaboration among various healthcare professionals. However, training programs may struggle to provide interdisciplinary training opportunities, resulting in gaps in patient care skills. Geographical disparities also affect access to training programs and resources for endometriosis specialists, leading to inequalities in specialized care. Since starting my fellowship with Dr. Najat, I have witnessed numerous challenging cases, some of which would challenge even seasoned gynecologists. A significant portion of our patients have endured symptoms of endometriosis, leading many to undergo repeat surgeries nationwide. It is not uncommon to hear our patients express their previous physician's hesitancy to proceed with surgery, emphasizing the necessity for physicians specializing in endometriosis management and surgeons skilled in endometriosis surgery. Despite challenges, there is hope. Efforts to develop non-invasive screening tools such as the Endometriosis Risk Advisor mobile application show promise in enhancing diagnostic capabilities and improving patient outcomes. Dr. Najat and his team discussed the Endometriosis Risk Advisor app in an article published in the Journal of Clinical Medicine last year, emphasizing its value as a non-invasive screening tool for identifying high-risk individuals. However, further training is essential to ensure healthcare providers effectively utilize such tools in clinical practice, underscoring the importance of specialized training in endometriosis management. In January of this year, our team published an article in the Journal of Clinical Medicine discussing the prevalence of endometriosis in patients with unexplained infertility, indicating a higher incidence than previously reported. Beyond pain, endometriosis is linked to elevated risks of both obstetric and non-obstetric complications. Efforts to develop dependable, non-invasive, and cost-effective screening tools can enhance diagnostic capabilities and facilitate comprehensive care for patients with endometriosis. While movements like EndoMarch and Access have begun to raise awareness, the crucial next step is to train more specialists in endometriosis. By investing in specialized training initiatives, we can strengthen our capacity to deliver high-quality care to those affected by endometriosis. This isn't just about advancing medical knowledge anymore. It's about advocating for the many who suffer from this condition, ensuring they receive the expert care and support they deserve.
So thank you again for watching. There are questions from Matteo on Facebook that says, how does the stages of endometriosis influence the treatment approach, especially in cases who are infertility or organ dysfunction concern? You know, endometriosis, our classification, the way that I look at it as endometriosis of genital and extragenital. Genital being uterus, tubes, and ovaries, and extragenital means bowel, bladder, ureter, diaphragm, appendix, other areas. And if it is mild, moderate, or severe, the approach, I individually treat the patient differently based on many factors, based on the age of the patient, her hereditary, because endometriosis about 50% of the time could be genetic, where she lives, the environment, if she is close to the power lines, fertilizers, toxic dumps, and also the diet, the influence. So many factors I consider when treating the patient when I am dealing with infertility, especially infertility, and of course also pelvic pain. So I do not use a cookie cutter technique for all of them. And depending what the patient has, I treat her differently, or treat that patient differently. And there's a question from I on TikTok that are there specific lifestyle factors or dietary consideration that, especially those who want to get pregnant or have a problem with pain or organ dysfunction? A good diet is excellent for everybody. A diet in general that less carbohydrate, if it is possible to be to a large degree gluten-free, and less red meat and less saturated fat, and a lot of the fiber fatty and fast food. If you can avoid it, is better. If you are able to have more green leafy vegetables and a white meat, and decrease or consume less red wine. If you are going to have some wine, have a little bit of more white wine might be better. But in general, if you can avoid alcohol, in my opinion, is much better in all aspects, because even alcohol could influence the level of the hormone levels in the body at different times if you are trying to get pregnant. It could increase the level of the estrogen in your body, and estrogen in general is like a fertilizer to a plant. And estrogen also is like a water to a weed. And estrogen is that water to that endometriosis, and the endometriosis grows. So a healthy diet in moderation, mainly essentially a Mediterranean diet, could be good. Thank you again for asking your question. And we will start with Beth Shipman. Beth, please go ahead and start, and you answer all the questions that it is addressed to you. Thank you.
Okay, good morning. My name's Beth Schiffman, and I have a clinic, Many Lives Chinese Medicine, in Redwood City. And I'm an acupuncturist. I've been practicing for 22 years. And like Dr. Athena's story, which was very brave and a very long journey to her fertility, our clinic specializes in fertility. We see general medicine, but a lot of the ways that we work with endometriosis, while we see endometriosis in younger women with painful periods and spotting and all of that comes with painful cycles, we also see quite a few patients who are on their journeys to conception. So there's Chinese medicine is quite effective in promoting fertility and promoting pain-free cycles. How do we do that? We treat every single patient individually. So with that, we do obviously an individual intake, and we find out most patients come to us, like I said, with pelvic pain, pain with sex, pain with bowel movements, heavy bleeding, spotting, and not very often an endometriosis diagnosis. So the beauty of Chinese medicine is that we treat the symptoms that are up front and very painful, but we also look at the constitution of each patient very deeply. And with that, we make a Chinese diagnosis, and we use acupuncture and extensive herbal medicine to help rebalance hormones. We promote blood circulation, and we reduce pain, which contributes to women actually having to have better cycles and a better chance of fertility. So acupuncture is quite effective, and when we come to the point like Dr. Athena's story where there needs to be some further investigation, then we definitely refer out, and we refer to basically Dr. Najat and work with him pre-surgically, post-surgically, to ensure a comfortable process and hopefully a better chance of conception. Chinese medicine treats a wide range of women's concerns, and endometriosis we see in our clinic tends to be, 60 to 70% of our patients. Other questions that are interesting and we get asked often are about our herbal formulas and our herbal medicine. We create very elegant formulas. We do them into, we make them into a tea, and they're individually created for this each person's case. So these formulas are often considered a little bit mysterious because you can't really get them on the open market. You can't buy them at CVS or, in a general drugstore. So basically, the art of our medicine and being herbalists to create these elegant formulas contribute to our treatment protocols for each individual case of endometriosis. Some formulas are very mild. Some formulas are very, if the patient has a strong constitution, some formulas can be very rigorous. So with the formulas, we treat every phase of the menstrual cycle. So when the menstrual cycle is optimized, then the pain tends to be really decreased and the patient is much more comfortable. So herbal formulas are used quite a bit in the mix. So we do acupuncture, we use herbal formulas, we look at diet, and we look at lifestyle combined to create a treatment plan for our patients. On the herbal side of things, a lot of patients ask about the side effects of herbs. And when a patient is seeing an herbalist, an acupuncturist in the state of California is an herbalist as well. So when the patient sees an herbalist or us, the herbal formulas that are created are safe because we are trained to create these formulas with, if there's very toxic or stringent herbs, not toxic, but if there are very stringent herbs in the formulas, we use mild other herbs to offset the balance. So the formulas tend to have 14 to 18 different Chinese herbs in them, which work synergistically to create a positive outcome. There are side effects. Sometimes patients will experience some loose stools. Maybe they have a little bit of a headache, some stomach upset. but it's not very common because we've been working with these herbs and these herbal formulas for many years. We match the herbal formula to the patient's constitution. How often, there's another question too about herbs, and we talk about dosages and how much herbs should I take. And in our clinic, when we give herbal formulas, we dispense either herbs in pill form for very busy individuals, or we make the customized teas, which give us a lot more flexibility with regard to really working on specifically the diagnosis. So it gives us a little bit more power for success when we give an herbal tea. The teas are, we give 2 teaspoons of, the teas come in sand form, so they're grains. You don't have to boil them. They come in like a sand, they look like sand. And so basically they're called grains. So we give 2 teaspoons of grains in hot water twice a day, and you mix it up and you drink it. It's not the old-fashioned way where we've been taught to actually boil the actual, dongui and baishao, all of these herbs in a pot. We don't really do that anymore because those kinds of raw herbs tend to get moldy and buggy, and that's not healthy for our patients. So the herbs that we get are now distilled down into grain form, in which we can dispense them quite easily. So for the herbal piece, there's a lot of questions about herbs out there or Chinese herbs. A lot of times I get the question of, what 4 herbs can I take to help with my pain? And the answer is that we don't often dispense herbs in single form. So we don't give 4 herbs. And you won't really find 4 herbs out at Whole Foods or at any market to take. You really want to see an herbalist to get the herbal formula that's for you, and that herbal formula can be shipped to you, or, it will always be available to you. So it's not like you go once and you get an herbal formula and then you don't get it anymore. So we are available to set that kind of system up. So for herbs, we work very, very closely with herbal formulas to support the acupuncture treatments with a diet and the lifestyle to provide a positive outcome for endometriosis. Then the biggest question I get is, what is the single most pain medication I can take that's herbal? That for us doesn't really happen. That would be an herbal formula that we are creating so you can have the outcomes of less pain. There's not one single pain herb or herbal formula out there that's going to really do the trick. You really want to come see an herbalist or a licensed practitioner to get those herbal formulas. And lastly, the very last question I get, I'm sorry I'm jumping around a little bit, but this has to do with the acupuncture treatments, which I did forget. But how long should I be seen by an acupuncturist to get any sort of results? Typically, we like to follow a woman through 3 cycles to get about 50% of the pain reduced. And then we go 3 or 6 months long to actually see full results. Do we cure endometriosis? No, we don't. We don't cure it. We help manage the pain. We help put together a diet and a lifestyle plan that will be manageable, that's the operative word, and effective. And then we work very closely with Dr. Najat, all of Dr. Najat's, to work with the highly medical side that obviously acupuncturists were not able to do. And that, if you have any questions, I'm here to answer them. So thank you.
Thank you very much, Beth, for very, very insightful description and answering, as I mentioned earlier, all the questions that have been submitted. Our panel are addressing it in one session. And if you have more questions, there are other physicians, Dr. Agrawal and Dr. Jackman online answering your questions. And if you have any specific question for the panel, please let us know. We will ask them. I have one question. How or is there a limit or any of these medications could cause or increase the bleeding time? Let me tell you why I'm asking this question. Over the years, my brothers and I and my niece, we have experienced, I remember at least in my experience, 2 cases of the patient that they were taking Chinese medicine, and one of them was a pediatrician actually, and the other one was a patient that she was from China and she was taking excessive amount of Chinese medicine. And usually before the surgery, when there are patients taking any kind of medication, aspirin, Motrin, we tell all of them to stop. But because these products have some medicinal products, we also are very careful. And we checked their bleeding time to see how much bleeding, but it was almost normal. But during surgery, they had a lot of bleeding, and they had nothing else. The only thing that we could find out is they were taking a ton of medicine. What I'm trying to ask, is there a limit to it? Do you think there is a side effects, or do you tell patient to take this much and don't go over? I appreciate if you respond.
Yes. With dispensing the herbal formulas, we also check if the patient does not come in for acupuncture, but only gets herbal formulas from us, we actually reevaluate them every 3 months. And with surgery, even with any sort of surgery, we ask them to stop any sort of herbal intake a full week prior to the surgery. So I don't know in those 2 cases if they had instructions to stop their medications before the surgery. I think you said you asked them to.
Yeah, I'm
Correct?
glad you asked. Yes. And what happened, specifically about one of them, she said, we asked everybody to stop 2 weeks. And later, when we investigated further, unfortunately, both of them, they had not stopped. And they have continued to take a lot of the herbal medicine. So you are correct.
Yes, we are quite diligent in working along with our physicians. So if there's ever if there's surgery coming, if there's any sort of procedure that's coming up, even dentistry, we always request that they stop their herbs at least a week pre-surgery. And then in the following cases of, herbs gone wild, basically, if the patient's constitution is really strong and they're taking a really big blood-breaking formula, which we do give, we can't eradicate endometriosis, but sometimes their blood stasis is their inflammation is so strong that we will give herbs to that. When we dispense those types of formulas, they are seeing us once a week. And we are monitoring their every secretion. So they are under close monitoring. While we give herbs also to maintain the cycle, maintain that the hormones are balanced and the cycles are balanced, we give those formulas for 3 to 6 months at a time. They have to come back. They have to come back and check in with us, or we do a reevaluation. Like pharma, they don't get refills automatically.
Well, thank you very much. That was very, very helpful.
Robotic-assisted laparoscopic segmental bladder resection for infiltrative endometriosis. This is a case of a 31-year-old female, G0 para0, with a history of chronic pelvic pain and dysuria. Previous cystoscopy done 1 year prior noted a mass suspicious for endometriosis. She has been on continuous oral contraceptive pills without improvement in pain, and she desired definitive treatment. On cystoscopy, the endometriotic implant can be visualized in the bladder, posteriorly, above the trigone. Bilateral uteral stents have already been placed and serve two functions. One, to visualize the distance between the endometriotic implant and the ureteral orifices, as well as during closure of the bladder, knowing how proximal we are to the ureteral orifices. The endometriotic lesion was also visible on laparoscopy. This procedure required a total of 4 ports, a 12mm umbilical port in which the camera was used, and then 2 robotic arms. On the left side you can see a 8mm forceps, grasping forceps. On the right side you see a 8mm monopolar scissors. As well, there was a 10mm suprapubic port which was used for access of the suction irrigation, as well as any grasper or any endocatch. As you can see, the endometriotic implant has gone through and through from inside the bladder that we saw in cystoscopy, and then visualized on the cirrhosis of the bladder. Using the monopolar scissors, we are excising the mass in its entirety. Now, urinary tract endometriosis accounts for about 1 to 2% of all extragenital endometriosis. 90% of these involve the urinary bladder. As was discussed with the patient preoperatively, the chance of malignancy is extremely rare. In 2002, in Fertility and Sterility, Dr. Najad and colleagues reported the laparoscopic management of 15 patients with infiltrating endometriosis of the bladder and reported 1 case of primary intravesical endometrioid adenosarcoma. We continue to dissect the endometriotic implant from the bladder. We have finally entered into the bladder cavity, and as you will shortly be able to see, the Foley catheter within the bladder. We're then going to attempt to grasp the lesion and exteriorize it, and use this now as a focal point to ensure that we excise the entire endometriotic implant. So how would these patients present in your office? Well, small lesions may be asymptomatic and diagnosed incidentally during exam for other conditions. The pain may present as cyclic or acyclic in the abdomen or pelvis, and the symptoms may be similar to acute urethral syndrome, with frequency, tenesmus, dysuria, or suprapubic discomfort. And menorrhea, which is hematuria coinciding with menstruation, may or may not be present, and if left unmanaged can lead to urinary obstruction or incontinence. Differential diagnosis includes bladder carcinoma, varices, papillomas, and angiomas. Here we are just about to have removed the entire infiltrating implant. We will then remove the specimen via a 10mm endocatch. And it is important that with any implant, whether on the bladder, bowel, on the ovary, you want to ensure that this implant does not touch the anterior abdominal wall, because you do not want to seat it within it. We will return our attention back down to the bladder. Here you can see the Foley bulb, as well as both ureteral stents which are within the bladder. The important thing is that we have such a large defect in the bladder, we have to release tension on it so that when it's reapproximated, there is the least amount of tension possible on that suture line. And you can see on the edge of the bladder defect there is still a specimen that's there, so we're just going to remove that specimen. The implant you have to remove entirely in order to prevent any recurrence, and here we will deflate the Foley bulb here, and right about now you will get a better idea of how close the bladder defect is to the ureteral orifices. And it's important that during closure of the bladder defect we don't incorporate obviously the suture into the ureters. Here we have introduced a ovicual suture on a CT1 needle through that suprapubic port. Again, it was a 10mm port that allowed access for that needle into the abdominal cavity. To reiterate, this patient wanted definitive surgical treatment. Other options would have included suppressive hormonal therapy, in which the patient had failed, oophorectomy, hysterectomy, also the possibility of shaving the bladder lesion, but in this case it was completely infiltrating from the bladder serosa all the way through to the mucosa, cystoscopic electrocoagulation, and finally like as in this case, segmental cystectomy. Now, the goal in this case of surgical management is threefold: complete elimination of visible and palpable endometriotic lesions, restoration of the anatomy, and to regain normal organ function. There are many ways that we could have closed the bladder, whether in single layer, multiple layers. In this case, we used a running stitch of the ovicle as mentioned before. Again, the depth of the invasion directs which treatment is necessary. If the lesion of the bladder was simply on the serosa or superficial, we could have gone away with hydrodissection and vaporization. But in the case when there is deep involvement within the muscularis and obviously in the mucosa, segmental cystectomy is necessary to remove the lesion. Here we are almost at the end of completely closing the bladder defect. As you can see, we're taking large bites through the peritoneum, the mucosa on both sides, and the peritoneum again. And as you are closing the defect, you want to pay close attention again where those uteral orifices are. We have the stents in place. The stents won't prevent you from going through the ureter, just that if you do, it's more easily recognizable. Now, in order for us to check for any defects in the bladder, we're going to fill the bladder retrograde. And here, on our first attempt, we do see a defect just at the middle portion of our closure. And we're going to reapproximate that defect now with a through and through stitch of the same suture of the ovicle. And once we have closed this gap, we will then retrograde fill the bladder once again to check for any defect. And as we're filling the bladder, we do not see any spill into the peritoneal cavity. Again, here on cystoscopy, final cystoscopy showing the closure of the defect and both uteral stents visible. We can see that there is no incorporation of the stents into the bladder closure. The patient was discharged home with the Foley catheter in place for 2 weeks. Post-operative retrograde cystogram noted an intact bladder, and both catheter and stents were removed. Thank you.
Good morning. My name is Marion Smith, and on behalf of the Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists, I'd like to thank Dr. Sina, who is joining us from her country of India to talk about a topic that is very important to all of us, endometriosis. Good morning. How are you doing this morning?
Good morning to you, Marion. It's so good to talk to you so early in the morning here in India.
Well, we are very grateful that you're willing to talk with us so early in the morning in India.
Not a problem. I'm an early morning person, so that was okay.
Excellent. Can you tell us a little bit about yourself and the kind of medicine that you practice?
Thank you, Marion, for this kind words. I'm Dr. Ruma Sinha. I'm a practicing gynecologist at India in a city called Hyderabad, which is in the central part of the country. Hyderabad is a big country, a very populous country too. I've been practicing gynecology for close to about 28 years. And my interest is basically in gynecological surgeries. Over the years, I have practiced laparoscopy, and for the last 11 years, I have been doing robotic surgery for women suffering with gynecological problems, of which endometriosis is very close to my heart. And over the years, I have specifically chosen to focus on this area, both as a surgeon, as a physician, as a counselor, as a confidant to these women who suffer from endometriosis probably years together, maybe sometimes lifelong.
Well,
I'm
excellent.
currently the president for the Association of Gynecological Robotic Surgeons of India. This is a new body, but we are trying to focus on training more and more young surgeons in India in the field of robotic surgery. And I feel that endometriosis is one disease where this technology will really make a difference for women undergoing surgery.
Well, I know as a woman who has suffered from severe endometriosis, I think I speak on behalf of individuals who suffer from this debilitating disease. We are truly grateful for individuals like you who have devoted so much of your time, passion, and energies to helping people remedy this terrible disease. And you mentioned about the group that you're president over. Tell us a little bit about how endometriosis awareness, how it has changed in the country of India over the past 10 years.
It's a very good question, Marian, because I remember maybe about 20 years back, there wasn't much endometriosis awareness. And when I mean awareness, it wasn't much either in the women themselves or even in overall gynecologists, I would say, and the regular physicians. Now, let me just elaborate. The women didn't understand that the pelvic pain or the dysmenorrhea that they are suffering could be because of an underlying disease. And giving you a perspective, in India, women get married a little early, and they would have children early. So I also believe that because of this, the endometriosis really did not present so much earlier. All right. So it was a grandma's advice in India, if a young girl was suffering from pain during periods, she would be told, okay, get married, you have children, and all will settle. And we do know that pregnancy can suppress an early endometriosis because of its, the hormone that is secreted in pregnancy, as well as amenorrhea for 9 months. Then they would lactate for another 9 months. So literally 2 years, they would be amenorrheic and a lot of lesions would disappear. But the scenario in the last 10 years has changed because women are now working. They don't want to get married so early. So they kind of present to us more. Having said that, we as gynecologists have become more aware to diagnose it. We have better imaging. We are doing more laparoscopy or robotic surgery, or we think more. We are more aware to, like what I would say is our antennas are more up if a patient clinically presents with these symptoms to think that she may be endometriosis. And probably that helps us to start a treatment earlier. I would also say that the other departments or my colleagues in, say, in gastro department or, like physicians or general practitioners are also slowly getting sensitized to that if a young girl or a woman is suffering from pelvic pain, and especially if it is cyclical, ask them to see a gynecologist and don't just keep treating that it is in your mind when they can't diagnose anything. So I think that has changed in the last 1 decade in India. Yes.
Well, that's really good to hear. And I know I come from my own personal experience thinking that maybe it's in my head. But when you finally find someone who understands the disease like you do, it helps a patient realize it's not in your head. This really is something that there is something going on in that pelvic area. How would you say that the availability of endometriosis specialists exists in the country of India today? Surgeons who can help patients with endometriosis. Is there a large and easily available group of physicians who are knowledgeable in the care of endometriosis?
I would actually like to address this in 2 ways. One is, yes, there are surgeons increasing by the day who are getting better and better in doing laparoscopic or robotic gynecological surgeries and including endometriosis, right? So there are a lot of surgeons getting an opportunity to observe and train both in India by their peers and seniors or people who do good work. Plus, they are getting a lot of chance to have some international exposure, say to Nizat's place or somebody in Europe or somewhere else where a lot of work is happening. So surgeons today are willing to update themselves. The second advantage has been the availability of a lot of things on the digital media. So today, if a surgeon wants to update, can actually update themselves in doing a better surgery by just watching somebody's surgery, right?
Mhm.
That's how we learn. And we have many more technologies coming in to help surgeons learn. So that is the beauty of it. The second is the availability of a technology to do the surgery. And I'm a real advocate of robotic surgery. And I feel that that has personally made me a better surgeon for endometriosis. I can do the surgery much better with the robotic instruments in my control than I would have been doing with laparoscopy. So I believe that all this has made a lot of surgeons in India well trained. Having said that, there are too many people, right? Everybody can't reach the specialist. So India is one place where I believe we have to focus to guide and train all our surgeons who are doing some part of gynecological surgery. Sometimes it happens, let me put it this way, we get an unexpected diagnosis of endometriosis if you had not thought about it. I may not be an endometriosis specialist. I may take up a patient for laparoscopic surgery for an ovarian cyst, but I end up, when I enter and I realize it's a deep endometriosis. So we need to again train these surgeons that, okay, don't do harm. At that point, just try to understand and then refer the patient to the right surgeons. So I think that is a one part which maybe it's worldwide as well. I think that is a point that needs to be noted worldwide. But I think they are increasing day by day in India. There is a lot of collaborative work that I can see happening in India. In my own institute, hospital where I work, we work collaboratively with the colorectal surgeon very often. We work with a urologist if needed. And then we have ancillary dietitian, pain medicine, counselors, everybody coming in and chipping in for that particular patient. So a collaborative group work is not uncommon in India anymore. A lot of people are joining hands to give a better clinical outcome to women.
That's excellent. Really great to hear. As far as your individual style of practice, I know you mentioned that you typically mostly do surgery, robotic surgery. Is there anything else as far as a holistic approach or other suggestions that you may make to a patient who is suffering from endometriosis that they can do to help themselves in addition to surgery?
I know. I don't see, surgery is a very small part of endometriosis management. I don't know whether you agree or not. And the more and more we are learning about the disease, we are also learning that we can, if we intervene early, can, medically manage the problem a little bit. And I think even if you have a surgery, you might have realized yourself, or you might have heard or discussed with others that some kind of medication is required for those women. So we have to be very, very pragmatic and very, very practical in choosing the time when to do the surgery. Because it is heartbreaking for you as a patient and we as a surgeon if we have to come in again and again. So the timing of the surgery and really understanding your problem is very important. And I would say, and I believe and practice, and I teach to my fellows as well, that if you come across a patient of endometriosis, the first thing, ask, what is she seeking treatment for? What is her age? Right? If you're seeking treatment for fertility, then coordinate with a fertility specialist and see what best we can do for her. Surgery may not have been the best answer at that point of time, or surgery is the better answer for her at that point of time. So every patient we have to look. If she has come for pain relief, will the medication help her? Is the disease so advanced at the moment that without surgery we cannot help with pain? Then we go ahead with with surgery. But if the surgery is not where there's an adolescent girl, we don't have much lesions on our imaging, but she's having severe pain, I wouldn't do a surgery at that point.
Sure.
She's just 17. She might require one at 27 as well. So if I can, because her problem is only pain, I can control it by medicine, I will give her a few years with medicine and then maybe intervene her. Then surgically, I can control her pain as well as fertility. So I think a lot goes in my mind when a woman with suspected endometriosis or already proven endometriosis comes to me. And at that point of time, once then we start talking to them and say, okay, we suspect this problem. It could be a long haul. Please, first of all, think there is no magic. We'll try and help you with a pain specialist. You can go for physiotherapy. You can go for yoga. We'll put you on this. So we put them on counselors. And I feel that many of them may sometimes even go up to the extent of requiring some, wouldn't say a psychiatric intervention, but some medicine for their, many of them are anxious and depressed.
Yes.
Right? So you have to understand what their mental status is. I believe and I understand that if you address that, then the medications we are giving for pain also helps them better.
Mm-hmm. Right.
Otherwise, you might be in denial that, like nothing is happening to me. This is the worst thing that happened to me. I can't help that one. So a lot of my time goes to make them first understand that, yes, and we really have to be on board with them and understand with a lot of empathy if we understand your pain, because that's what troubles them the most.
I think that's amazing to understand.
Yes, so we also, in this situation in India, have an Indian society called Endometriosis Society of India. Okay. It's doing its job in spreading awareness, doing regular medical programs. I'm the scientific chair there. We are also, again, having an international meeting on it in December this year. So a lot is happening on this in some way or the other. Maybe I should write to Dr. Nizat and see if we can collaborate with him for this meeting. Talking to you just gave me this idea. I'll do that. I'll probably write to him.
Fantastic. It sounds like to me the approach that you take is it's not a one size fits all or a cookie cutter. You look at each patient with endometriosis individually and where their pain is coming from, and maybe what other subspecialists can also help them. And I think that's great that you're actually listening to each person.
Absolutely. And now that you mentioned listening, I use a word called anamnesis.
Okay.
For women of endometriosis. And when they come to me with a file or papers so big because they've been to so many places, I just put it aside. And I said, start your story from the day you started your periods. And listening to them for 5 to 10 minutes, you get so much insight into them. We are not, as a physician, we should not just focus that, okay, the patient came with pain, the scan shows a cyst, and okay, that needs a surgery. No, we need to understand the woman completely. Let her tell a story from the time she started her periods, what happened, and why she is in my office today. So that's the anamnesis I really focus on when women with endometriosis walk into my office. And that's when a fellow will be standing next to me and listening. And I said, don't interrupt, just listen. You listen to 10 women, you will understand the disease better. You can't understand otherwise. They are the best people to tell you what happens.
Right, because they know their body and they know what they're felt, and that's amazing.
We have only studied, we have only read in the books or journals, but they are the living example to tell you how to deal with them and how to help them.
Oh, excellent information. One last question I have for you, Dr. Sina, is what do you think the future, you've talked about a lot of advances in your country and that each day in India you see progress being made with endometriosis. Where do you think the future of endometriosis care, what do you think that it looks like, so to speak, in the country of India and as we move forward?
I think the lacuna in India is a lack of, actual epidemiological data and statistics. Mm. I think the society I mentioned, we must focus on getting that information because, again, geographically things can change. Having that, we must do global collaboration because we can learn so much from each other, right? And I just mentioned something like yoga, and I've been using that for my patients for years together. And India is known for yoga. So, that can be a small secret weapon for women, and they can just practice at home. They don't even need no gym membership required, no money required. You just need to learn. So that's something. We need to have policy changes in India where money can come for research and more changes in awareness, education of everybody, including public and the physicians. So this policy change will happen only when policymakers understand what is endometriosis and how women suffer. Otherwise, women in India take the back seat They have some pain in periods, they'll survive 3 days and they say, okay, get on. They won't come forward and say, okay, I'm having so much pain, so look at me. That's just the social structure here. So
Sure.
empowering their voices, I think, is the thing we need to focus on India. The younger ones are better. They are so much social media and they are understanding better. But I think for years together, they have just suppressed their voice. We need to empower their voice in India. And I think I will work on that. So maybe with global collaboration, making more and more social media awareness, talking about it, removing the taboo that goes with painful periods. I think we are on path to make a difference in India. And thank you so much for having me on board here. I hope my voice is heard in other countries as well, because we do get a lot of endometriosis patients from neighboring countries, Africa, Middle East. Recently, we have been having a lot of patients coming in to us from even Europe and UK for endometriosis surgery, because they've realized we are a good team here, and they sometimes don't find their appointments for surgery for long, so they choose to come down. So we have been helping in India patients across board as well.
Well, this is all excellent information, and it sounds like you are leading an incredible movement in your country of India, and we're so happy to have you also collaborating globally to help individuals with endometriosis. And thank you once again for taking time out of your schedule to talk with us about this very important subject. So please continue to empower women to use their voices. Have a great day, Christina.
Absolutely. Thank you so much for having me. And I would like to thank Dr. Kaman Nizat for his this good initiative and having involved me since, I think, 2016. I'm the so-called India captain for his EndoMarch team. And we have been doing good work here. So thank you so much for involving me and all my colleagues and friends here in India. Thank you so much.
Oh, our pleasure. And thank you on behalf of the Worldwide Endometriosis. We are truly grateful for your efforts, and continue to do their work, Team India. Have a great day.
Bye.
Bye-bye.
Bye. Namaste.
Laparoscopic excision of type 1 and type 2 endometriomas. Endometriosis, defined as the presence of endometrial tissue outside the uterine cavity, is a common cause of pelvic pain and infertility. It frequently affects the ovaries, where it results in cysts called endometriomas, sometimes called chocolate cysts due to the appearance of the hemosiderin-laden fluid they contain. Endometriomas are subdivided into two types depending on their etiology and characteristics. Type 1 endometriomas, also called true endometriomas, arise from endometrial tissue deposited on the surface of the ovary with subsequent cortical invagination. Type 2 endometriomas are formed by colonization of previously existing follicular or luteal cysts. Laparoscopy allows simultaneous diagnosis and treatment of endometriomas. Laparoscopic scissors, graspers, and section irrigation are sufficient to complete the surgical procedure. In our practice, we use the CO2 laser to remove any endometriosis. The laser confers the advantage of precise excision of implants with minimal damage to surrounding tissue. The implant is held with graspers, while the laser is used to dissect the surrounding peritoneum until it can be safely excised. Almost all women with endometriomas have concurrent peritoneal endometriosis, so we thoroughly inspect the pelvis and excise any lesions. We begin with demonstration of a type 2 endometrioma, the more common of the two types. Because endometrial tissue may seed the pelvis, when possible, we aspirate the contents of the endometrioma to minimize spillage. We repeatedly flush and aspirate the contents of the endometrioma. We use the suction irrigator, laparoscopic scissors, or the laser to separate the ovary from adhesions to the uterus, side wall, and bowel, restoring normal anatomy. We separate the cyst wall of the endometrioma from the ovary. We use hydrodissection to create a plane from which the endometrioma can be stripped. Traction and countertraction are used with laparoscopic graspers to peel the cyst wall from the ovarian stroma. Complete removal of the cyst capsule is associated with a significantly lower rate of recurrence than simple aspiration or laser vaporization. Next, we remove the endometrioma from the abdomen. If there is a scant amount of tissue, we can attempt to pull it directly through the 5 or 10 millimeter trocar. We remove larger specimens through an endo bag. We evaluate for spontaneous hemostasis, and if there is not, we generally suture the ovary back together. We avoid bipolar energy on the ovary, as it has been shown to decrease ovarian reserve, whereas using sealant or suture has been shown to preserve ovarian function after surgery. Finally, we thoroughly inspect the pelvis for any cyst remnants and flush out any debris and endometrioma spillage that may have accumulated. In the next segment, we demonstrate excision of a type 1 endometrioma. In this case, the endometrioma was adherent to the uterus and ruptured spontaneously as it was lifted away. In contrast to the type 2 endometrioma, type 1 endometriomas are more difficult to remove because of associated fibrosis and adhesions. Recall that whereas type 2 endometriomas arise from invasion of endometrial tissue into previously existing functional cysts, type 1 endometriomas result from implantation directly on the surface of the ovary, with invagination and bleeding into ovarian stroma, resulting in a densely adherent cyst. As in the type 2, we use hydrodissection to facilitate stripping of the cyst wall from the ovary. Notice that due to its dense fibrosis, the cyst wall is removed in a piecemeal fashion. Excision should be precise to completely remove all endometrial tissue in order to reduce recurrence, while preserving as much of the ovary as possible, especially in patients desiring fertility. Hemostasis has been achieved, so there is no need for suture, electrocautery, or sealant. We evaluate for complete treatment of any endometriotic lesions and note restoration of the anatomy. As you see, the ovaries are returned to their normal position. This concludes our demonstration and comparison of the laparoscopic excision of type 1 and type 2 endometriomas. We hope it is helpful to you in your practice, and thank you for your attention.
Hello, everyone. My name is Eden Williams, and I am a worldwide EndoMarch headquarters volunteer. I am here today with Dr. Brooke Adams. Do you want to take a second to introduce yourself, Dr. Adams?
Sure. I am happy to be here as a participant, someone who's struggled with endometriosis, found treatment, and looking forward to continuing to get the word out as the Najat Institute has been doing.
Absolutely. Thank you so much for saying that. Once again, it is very nice to have you here with us today to take the time and answer some questions and just to be part of our mission. So we really thank you for that. To sort of just jump into this interview, do you want to talk about how you first became familiar with EndoMarch?
Yeah, I actually, upon Googling support and finally having found a specialist and surgeon in Dr. Najat, researched his extensive history, all that he's put forward to support the cause, and found the EndoMarch.
Oh, wow. Okay. Yeah. Well, you've definitely been led to the right place. So I'm really happy that you are here with us and that you felt compelled to um, just be part of our journey. So really thank you for that. So to go
Yeah.
a little bit more into that, do you want to talk about your experience and your personal journey with endometriosis and how that's shaped your life to this point?
Yeah, I would say starting with my first cycle, the beginning of my period around 11, it was
Oh, wow.
extremely painful from day one.
Mhm.
And it was about 3 to 4 years later that a gynecologist had said, "You may have endometriosis, but we can't do anything about it." And from then on, it was really never mentioned again. And I was put on the birth control pill for a certain amount of weeks through the month, which made me very sick. I would often get nauseous and sick the first few days, then kind of adjust, and the same thing would happen each month. It helped slightly, but not much. Progressively through my 20s, it reared its head and was quite challenging. And then I would say after 30 and every year thereafter, it progressed into worse until about a year ago when it became just untenable. So it has been 30 years since that first doctor casually mentioned, "You may have endometriosis, but we can't do anything about it." Up until the point where I was again in an ER room, went to an emergency department for care upon pain, and finally found through a CT scan some significant fibroids. And that's about all they mentioned, and sent me home with some ibuprofen that didn't do much. And so throughout the years, I would say the initial signs outside of a really painful monthly cycle indicated to me that something was awry was I started having food sensitivities and gastrointestinal issues. And probably a decade ago, saw a gastroenterologist who said perhaps I should take an anti-anxiety medication, that it was that. I indicated to her at the time, "There's no way it's that. I assure you, I'm a psychologist by training. I'm
Yeah.
very familiar with anxiety, including my own." And so that was discouraging. And of course, I continued for years to take supplements and try to right some of these additional challenges, all of which stem as these treacherous tentacles from endometriosis, untreated for years and years and years. So while the average diagnosis apparently currently is about 10 years, I literally waited 30. And so it's been a long go. That's not even launching into dialogue around fertility, and its possibility and how it impacts it. Just sticking with the topic of my own care, my own ability to live a viable life. In the past, probably 5 years, I started to tabulate how many days I've lost in the 30 years due to having to stay home. I've missed weddings and baby showers and job possibilities. About 3 years in 30 were totaled that I remained in bed,
Oh,
taking strong medications, making certain I was on multiple heating pads, one in the front, one in the back. Um, so I think it's been a really long go, to summarize it, with a lot of pain, a lot of unmet needs and diagnoses that have not gone attended to. And it progressively started filtering beyond intestinal challenges, where it moved into more kind of kidney health and other organs, where I was really sensing there was a problem. And various general practitioners would cite kind of each of the symptoms, to many of whom I noted 18 of the 20. And no one since I was 15 mentioned perhaps we should look into diagnosing or considering or ruling out endometriosis or its sister disorder, adenomyosis. So I feel like it's just been stunning how many healthcare practitioners I spoke with, right? And I was not someone who was particularly casual about it. I'm not someone who's quiet in regards to my own care. So that really got me thinking, if I'm not direct, right, and communicative, what about some of these women who perhaps are a little quieter or aren't suffering as extensively, but are suffering quietly nevertheless? And I realized I'd like to do all I can to be of support.
Thank you so much for sharing that. Really, I'm sure that was very difficult. All of that, I can't even begin to imagine. And I really just want to commend you for all of the work you've done and for staying on top of your own health and for all of the accomplishments you've made, even throughout all of that strife and just on your arduous journey, as it sounds like. So I appreciate you for sharing that. We all do on behalf of the Cameron Najat Institute. So I'm really intrigued. So you said your diagnostic delay would be around 20 to 30 years, in that range?
Yeah, 30 years. Yeah. So while my first cycle was extremely painful at 11, it wasn't until about 15 that I was told I could possibly have endometriosis from some of the symptoms. And I'm 45. So that is a precisely 30-year delay from someone contemplating that to me meeting many of the symptoms to them just rapidly progressing into untenable in the last 20 years.
And it sounds like you were kind of bounced from specialist to specialist, even going as far as to mental health specialists in that range. And I think that's really interesting, especially for you and in your line of work. So I really appreciated hearing your perspective on that. I think that's a really unique take. And I think that's something that we don't really talk about enough with endometriosis is the large majority almost of women who are underwritten and their pain is not taken seriously. They're told it's in their head and they're misdiagnosed with some sort of mental health ailment. So I really commend you for staying on top of that and just for being able to advocate for yourself. Because like you said, I think it's really important to note that a lot of people don't have that kind of inner strength because they want to trust these health professionals and these doctors, but we just really haven't standardized this enough and made enough awareness about it. So thank you for sharing.
Absolutely. Yeah, absolutely. And there were a lot of details, once I actually found care and a diagnosis and pursued treatment, the details I read were on an anonymous study of medical professionals that many of them acknowledge they are not adequate, at diagnosing endometriosis, that they had a small paragraph in their medical training on the topic. And that really says something. And that I saw just general practitioners who said, I don't know, try an anti-anxiety pill. A gastroenterologist said, try an anti-anxiety pill. And it's kind of stunning because it's so far off the mark. And of course, would just continue to sublimate these symptoms. And the only reason I really continued to pursue care was because it became utterly untenable not to. I could not function. I was starting to miss work. I was exceptionally nauseated, which just progressed over the course of probably the last decade into really unbearable. And all of these were symptoms of endometriosis.
Yeah. So is everything that we just talked about what really inspired you to become an advocate in this journey? I'm sure that had a large portion to do with it. Do you want to talk a little bit about how that got you involved with EndoMarch?
Yeah, I look forward to being involved here and in greater depth with your organization because it really robbed my ability to trust medical professionals. And being one myself, I certainly think that standard is essential, right? That we have integrity in what we offer so that people can trust what they're getting. And so that is one component. The other was the grief I felt that, years on end of trying to find answers. I joke, but I'm also serious that I would probably be able to purchase a home at this time had my endo been diagnosed because it has been years, 30 years of taking supplements, seeing naturopaths who are very supportive, many of them, but whether it's classically trained Western doctors or naturopathic care, there was no attunement to this rather obvious, in hindsight, disease that I was struggling with, this chronic inflammation. And so I think knowing that I was someone who was very active since I was a teen, I taught meditation, mindfulness, yoga, and that I ate well the last 20 years, I'd say, out of those 30. And if I'm doing all of these things right and suffering this extensively, what about the people who are not in the wellness field? What about the people who are trying to get by, raise their families? So I think that's what really pushed me to want to support the end of this being such a silent, torturous challenge that can result in organ death, loss of fertility, or worse. So yes.
Absolutely. Yeah. Thank you so much for talking about that. I think that's especially important for all of the things you said, like those who maybe are not and have not always had the opportunity to be very wellness concerned and things like that in their past. And I think it's things like this that really help push that forward and that help people get a voice for themselves and think, hey, maybe I can find help somewhere. Maybe this person will believe me. It's really unbelievable working in Dr. Najat's office and just seeing the amount of referrals from things that you'd think are silly, like TikTok or Instagram and random things like that. And it's these people came from all over the world to come and seek this care. So I really think that's something that's really important. And in your opinion, what changes do you think need to be made in terms of advocacy just to further public awareness about endometriosis?
I think we need to go to the heart of medical training. And I am happy to offer my time freely to the schools within Access here in Northern Bay Area. Because I think that clearly that's where it starts, where there's lack of awareness. I also think, obviously, in a larger scale, culturally, kind of more traditionally repressed experiences around female health. I think there's literally a war on women at present against basic care, in particular around specific female organs. And clearly they're far more complex due to kind of hormonal balance being necessary and the potential to deliver and create children. So I think that starting on a larger scale, kind of with our lack of education for young girls and women moving into their period around what is normal and what is not. So I think both kind of in the larger system and then individually empowering groups of women and dads and moms to communicate on these topics that otherwise are either somewhat taboo, which is really rather bizarre in this era where, there is more openness to, I guess, just a lot of other dialogue around healthcare or around, as the wellness industry has kind of brought up a lot of topics like gut health. It baffles me that women's health, half the population on this planet, continues to go undiscussed, underfunded in every way.
Yeah, absolutely. I think that became extremely clear to me, not only just from my time in the Cameron Najat Institute, but I just in the beginning of my college career, I remember writing a paper and I was discussing the differences between a woman's average wait time for ER care and a man's. And there was nearly a 15 to 20 minute average wait time difference between a woman and a man. And I think that makes it really clear that it is systemic and it begins on levels that you just would never even imagine to see it so obviously, so in plain sight. So
Absolutely.
I completely agree with you. I really do think it begins at a much smaller level. I think there are much bigger things we can do as well for the whole picture for women's health. So I appreciate hearing your perspective. Is there anything else you would like to share with us today? Anything you want to say to anyone else about your journey or anything of the likes?
Yeah, two things. One, just that I think it is a really long go, but essential that you companion yourself, that women get to know in detail their energy levels, what foods allow them to feel satiated, what friends allow them to feel their best self, and then continuing down that path. What is your cycle like? We only talk about, the menstrual cycle when there's 3 other weeks leading up to that. So how do you support your health in general? This additional vital sign of a period. So I think that that's really important. And I see in my practice, of a private practice, where I see a lot of young women of all ages, but young women who are just starting to notice their shift in kind of mental wellness around lack of sleep or how they eat or alcohol intake. And the same with their cycle. So I'd really like to up that education. The second thing I wanted to say was just the immense gratitude I feel for Dr. Najat and his staff and the support from people like you, keeping this moving forward, keeping it in the attention of people in the media. My life was becoming literally intolerable. I was starting to miss work. I was unable to get out of bed due to pain, and what was just becoming kind of a crushing experience with endometriosis vastly spread, essentially suffocating various organs to the point where they were no longer functioning properly. And having been to the ER multiple times, and then finally connecting with Dr. Najat, my second time in the office, pre-surgery and treatment, I was just brought to tears at how grateful I was at the possibility of being vaguely healthy. And post-surgery, now 10 weeks out, I feel, again, just immense gratitude to the Institute and everyone who supported me there in getting the treatment I needed to show up to life, to serve other people in my practice, and to return to being a functioning citizen and friend and partner. So I'm really immensely grateful.
Thank you. I definitely want to let you know that goes both ways on behalf of you. As one of our advocates, it really means so much to our mission, everything we believe in, what we're trying to accomplish. And we really want to thank you for your time today. So with that,
Absolutely.
we'll go ahead and conclude this interview. Thank you so much for your time, Dr. Adams, and I hope to see you.
Thank you.
Let's invite Dr. Minal Shah. I've had the pleasure of working with Dr. Minal Shah for more than a decade. And what I realized about Dr. Shah, the same thing that I mentioned, she looks at mind and body together, the whole body disease. Dr. Minal Shah is the founder of the DBT. When I was talking to some of my patients, referring them to Dr. Shah, I said, she's the founder of DBT in Atlanta. They said, what the heck is DBT? It's interesting. At the University of San Francisco, they actually have the DBT center also, and one of the therapists has put something online, exactly the same title. What the hell is DBT? So I would refer you to that. It's funny, but it explains everything for you. On that line, I'd like to invite Dr. Shah to share her knowledge, expertise with us. Minal?
Thank you. Thank you so much for having me, and good afternoon, everybody. One of the things that we've noticed in the last over 20 years of practicing various forms of DBT is that many females, more than not, have had an onset of psychological symptoms in the 12 to 18 months pre-menarche, and a lot of the females have a severe worsening of symptoms in the 7 to 10 days prior to their menses every month. So it came to mind that it couldn't possibly be that people were just developing severe psychological symptoms, at the onset of puberty for no reason whatsoever. And the type of patients that we see, generally speaking, have parasuicidal behavior. They're cutting, burning, binging, purging, drinking, using drugs. They're very severe behaviors that can often lead to active suicidal completion, inadvertently even. So we started sending most of our females to Dr. Najat, who I will absolutely say, beyond a shadow of a doubt, cured them. upon alleviating most of their reproductive and endocrine symptoms, our work was cut down by a good 50 to 75% with each of these patients. So all of the patients that we have sent to Dr. Najat that have completed a solid year of treatment with us have gone into remission, most definitely in the psychological arena, but for the most part, from what I'm hearing, with their reproductive endocrine difficulties as well. So we are just so thrilled that we have a resource like Dr. Najat in our city, where we can send everybody one after the other. The vast majority of our practice does go to him. And I dare say that we have one of the absolute highest rates of remission and cure for the patients that come to DBT than of anybody. And I think it's because of him and the work that he does.
Aminal, thank you very much. Can you elaborate a little bit more about what DBT is, what your center, and I mean, you give lectures everywhere I see it. So for the general knowledge, I think it would be helpful if you elaborate a little bit more about the focus of your work and how, in general, you deal with the individuals. Yes, I get involved with the female part, the patient part, but you deal with their families also. So please elaborate on that if possible.
So dialectical behavior therapy was developed for the emotionally dysregulated patient that wasn't responding to other treatments. Patients that are pervasively emotionally dysregulated and patients that are pervasively emotionally lonely and shut down and non-functioning. So we have two sides of the same coin. Those with very big behaviors that are creating chaos in their lives. And we have those patients that are extremely shut down and not living their lives. Two different sides of the same coin. The DBT and RODBT really treat the patient through a set of modules that are skills-based. These are disorders that we are treating that are due to a lack of skills in coping, in functioning, in relationships, in work, in academia, in all areas of their life. So the great thing about DBT and its counterpart, RODBT, is that we teach skills on a weekly level, a weekly basis, one skill after another, building from the ground up, bit by bit, and it's incredible as an outpatient therapy because they learn something each week that's very tangible, and then they go home and they practice that, and then they come back the next week. And the efficacy of DBT has been shown to be extremely effective at the 12-month mark, a solid year of shaping behavior in, a solid year of shaping unwanted behavior out. Most of our patients do extremely well at the 1-year mark, unless, of course, they are fighting their biology, which is where Dr. Najat has typically come in for us. Predominantly, most females, most of the patients that come to us are going to be female. Most males with the kind of difficulties that our females have, generally speaking, land in jail because anger for men is very explosive and anger for females is generally turned very much so inward, right, in terms of self-destruction. So the predominance of our population is going to be female. And what we've noticed is that psychiatry as a whole has been just treating the symptoms day after day, year after year, decade after decade, just putting people on antipsychotics, antidepressants, mood stabilizers, and not really looking for the causes of what's going wrong with them. What I really love that Dr. Najat just mentioned is the holistic approach. DBT addresses that. We have a skill called the please skills, or what we call the my seed skills, sowing the seeds of health. And it stands for SEEDS, sleeping, eating, exercise, drugs, illness, medications. These things are what we look at holistically for each and every patient. So it's beautiful that we have a treatment that does that and tracks people's emotions in regards to what they're doing every day, the skills they're practicing every day, as well as their nutrition every day, as well as their cycles every day. This is a very comprehensive, broad, all-inclusive treatment that has complete efficacy behind it. And I love that. I love that. Most of our folks are able to get off the vast majority of medications as well.
Thank you. Thank you very much, Dr. Shah. Dr. Shah brought up a great point out, which is very important. She mentioned the male, they have different type of behavior than the female. And the female, they become more internalizing it and they become more self-destructive. This is a great point. We have to look at it. She mentioned different manifestation of self-destructive behavior. One of them could be eating disorders, eating the wrong food, or other aspect. Dr. Shah, this is a great area, and I think we see it very often on our patients with reproductive disorder, mainly endometriosis, fibroids, the hormone imbalance, etc. Could you please elaborate on that?
Absolutely. One of the interesting things that we've really noticed as of late is with anorexia, which of course has the highest mortality rate in all psychiatric illnesses, with bulimia, with sleep disorders. Of course, sleep disorders are the #1 indicator of whether or not you will achieve remission in psychiatric illnesses. One of the things that we've noticed is obviously all of these things are driven by hormones across the board. I'm not just talking about reproductive, but hormones in general, correct? So, I mean, correct, right, Dr. Najat? The body is run by hormones.
That is correct. There is a direct relationship between the hormones and the physical conditions. So we know, for example, the pituitary controls the pancreas, the adrenal gland, the ovaries, the thyroid. We call it, these are all associated disorders, and one leads to the other. You are absolutely correct. Please elaborate.
And one of the things that we noticed is, and I'll give you a very, very benign example, is if somebody was drinking too much orange juice with vitamin D and they were not sleeping well at night, they might not know why they're not sleeping at night. And now we're giving them sleeping pills and nobody's taken a history as to why they're taking so much vitamin D into their body. And of course, vitamin D is activating, right? Not sedating. And we know that, but people don't know that in general. So one of the things that we'd really like to see is with every disorder that comes in our world, be it everything in eating disorders, be it anything in personality disorders, be it depression, we would like a full endocrine workup, not just reproductive, but a full endocrine workup, head to toe for every single individual, because we see that even in males. They often have an undiagnosed endocrine difficulty. I mean, I know we're here for endometriosis and PCOS and fibroids, but the fact of the matter is that this is all endocrine driven, hence these wonderful gentlemen are reproductive endocrinologists. But I would like to expand this awareness to all endocrinology, the greater umbrella under which most things are occurring. And most psychiatric diagnoses are diagnoses of inclusion and not diagnoses of exclusion. So once somebody sees 1 or 2 or 3 symptoms, they say, oh, she's got major depressive disorder, and starts throwing pills at it. And nobody really looks for the cause of what's going on. Nobody really looks to exclude any symptoms from a diagnosis. And I think that really very much needs to happen for both genders, to be very honest, in order to adequately treat patients.
It's a great point. And remember now, when we talk about gender, it has become more, I would say, common now that we have transgenders.
Yes.
And we just can't focus just on the female part. And that could affect the individual. So we have to validate, as you mentioned, the hormonal aspect, regardless of the chromosome. We have to look at the whole area. And that was a great point you brought up. And
we have watched several trans men, people born biologically as female, have many reproductive difficulties, from PCOS to PMDD to endometriosis, that have, through very significant emotional difficulties, made the decision to transition to being a male. And unfortunately, that doesn't get rid of the problem that is causing the emotional dysregulation in the first place. Okay. So I really think that a heightened awareness for individuals who are trans male is really warranted in the reproductive and reproductive endocrine communities.
yeah, and I believe you see quite a number of those, don't you?
We do, we do.
So this is a great message to send it across, that when we are talking about, again, going back, that endometriosis is a whole body disease. It not only it could affect the XX chromosome, it could affect, I mean, change regardless. And we have the opposite too, that if the male wants to convert to female and they give them high amount of estrogen, for example, to convert them, that could impact. And Dr. Shah, I know you had to cut your travel short to be here, and I'm really grateful for all you are doing for all these patients and for all you do everywhere. But we'd like to hear your take-home message.
Well, first of all, my gratitude goes both ways. My patients come crying to us with relief because they have finally met you and finally have a solution in sight. My take-home message really has two parts to it. One, to patients, we are the one field of medicine that is paid to listen. And if you don't find somebody that knows how to listen and put all the pieces of the puzzle together, don't spend years with that person just describing your woes week in, week out with no relief in sight. For the professionals, what I want to say is, again, we are the field that's paid to listen. And unfortunately, the field of psychology has not been educated well enough to know what to listen for. So I believe, and I've noticed this in my trainings across the state that I'm doing for all of the hospitals, that almost every clinician that graduates as a counselor or psychotherapist has no idea of what to look for any illness, much less reproductive illnesses, for all of their patients. And as I'm teaching them about medicine and endocrinology and sleep disorders, their eyes are opening up very wide, and they're like, we have never considered all of these things. And they start coming up with multitudes of patients that they realize could have been helped much more effectively, much sooner, had these things been addressed. So I would like the move to be made, the push to be made for clinicians to have a more well-rounded education, because being the field that is paid to listen, we need to know what we're listening for.
Great, thank you so much. And one thing you brought up, and I really want to take this message to all the therapists, that you said we have to get away from inclusion, diagnostic inclusion. We have to also focus on exclusion. And that's the key factor. Really, that was eloquently said, and I like to echo that. So I'm so grateful to all the panelists for taking the time for being with us. And I like to thank everybody around the world who is listening and taking this message forward.
Good morning. I am Dr. Kamran Nejad, founder and president of Worldwide EndoMarch. I would like to welcome you to this session of the endometriosis and involvement of endometriosis with the bowel. Worldwide EndoMarch, since its inception, the goal has been to increase awareness about endometriosis and help young women and their families who have endometriosis, and also as they progress towards their reproductive age, to guide them through the process of their reproduction and then menopause. Since in its inception, Worldwide EndoMarch has brought attention to endometriosis across the globe. Many, many countries are involved, and we would like to thank every one of you for all of your efforts to make this entity a known entity to everyone, as endometriosis is as common as blood pressure and diabetes, if not more. But the awareness has been poor. Still, we see women who go years undiagnosed and suffer with endometriosis. The session today is related to the bowel endometriosis. Endometriosis is a whole body disease. It doesn't only affect the reproductive organs. Actually, after the uterus, tubes, and the ovaries, bowel is the most common site of endometriosis. And many times, many years, and often the diagnosis is mixed with other conditions like irritable bowel syndrome, diverticulitis, colitis, etc. And there are many, many questions in this regard. The symptoms of the bowel endometriosis could be very variable, and thus the co-founders of EndoMarch, Dr. Farnejad, Dr. Sinan Nejad, Dr. Azad Nejad, and Barbara Page, and also all the staff of the headquarters of the Worldwide EndoMarch continuously are trying to find effective ways to increase the knowledge. Tiffany, Zoe, Elisa, and the other members of the Worldwide EndoMarch headquarters have been continuously in contact with you to try to find how we can answer your questions, educate you, and help you to achieve your goal. We have received many, many questions in respect to bowel endometriosis, and we have put together an outstanding panel, a colorectal surgeon with extensive experience dealing with endometriosis, Dr. Miriam Scherzer, that has been working with my brother, Dr. Sinan Nejad, and many years ago myself and my brother, Dr. Farnejad. She has extensive experience, one of the most experienced surgeons in endometriosis and colorectal surgery. We are very honored to have her to answer many of your questions, address them, despite having issues with her mom. Still, she has been so kind to accept and do this interview to help the question, answer them. Another esteemed guest of ours is Dr. Louise King from Harvard University. She is an outstanding physician, I know for sure, because she did her training with me. And she has extensive experience, knowledge in every aspect of the treating women. She has a young girl, so she is very interested in endometriosis, and she has been an outstanding an outspoken speaker for women's rights and how to promote the health of women. And it is a pleasure to have her to speak with us. And today also we have included two of our patients that over the years, their story would tell their story, how, what young girls, women, all through their life go through this process. They would share with you a little bit of their history, their journey with endometriosis. And one of them is Naomi Sadler. Naomi I have known her for many, many years. She is one of the brilliant women. She is the CEO of her own company, and she goes around the world, and she has established traditional medicinal with her husband, Drake, that they have been very supportive of Worldwide EndoMarch and promoting the causes of the women's health. She is, if I might say, she has been promoting women's causes across the world in many countries across the globe, like Kazakhstan, Rajasthan, and Guatemala. She travels around the world for philanthropic work and empowering women, also women wages to be equal to men. And she has had a difficult journey with endometriosis. I have known her for years. I thank her very much for being with us and trying to share her story with us. At the same time, there's another patient, Dr. Sinan Nejad, Gail Barker, that my brother would speak and he would introduce her later. And so we have a combination of stories for you to make this useful. We have received a lot of your questions, and you have sent many, many questions. We have tried to summarize them and select those who has been the most common for everybody. I have to mention at the outset that we are not going to specifically answer everybody's question in that regard. We are going to try to generalize it. We are not giving any of the physicians on the panel are not giving any kind of advice how you should be treated. We recommend, we are just general recommendations, general guidelines. We have also included one of our latest papers, which was published in the most prestigious journal of American Journal of Obstetrics and Gynecology. And these are guidelines how to treat endometriosis of the bowel. That we will share with you. We try to guide you some direction. Questions have come from across the globe. So we have selected some from different parts of the world as well. Saying all of that, once again, I'd like to thank all of you for your attention, for your interest in endometriosis of the bowel. And we start with the story of Naoma Sadler. She would give a short summary, and later, if there was any question coming up for all the observers, then we would address and ask her more. First Naoma, and then Dr. Sina Nejad would say something about Gail Barker, and then after that, we will start with questions from all the participants. Thank you very much, all of you again, and we appreciate it, and stay well. Go ahead, Naoma.
Thank you, Dr. Nejat. Hi, everyone. It's so wonderful to be here and to be able to share a bit of my story and the journey I've been through. I want to just start by thanking all the Nejat brothers and all of the many doctors and the team at EndoMarch for all the hard work and dedication to finding more answers and helping women like me to have a better life. So my husband and I are very happy to be staunch supporters of the EndoMarch, and anytime I can raise my voice for this cause, I'm very happy to. And yes, I've had a long journey. I'm 45 years old now, and when I started my cycle when I was 11, this journey began. I did not know what I was dealing with for a very long time. I went to many doctors, just similar story to the many women you've already heard from. There's nothing wrong with you. This is normal. Really challenging symptoms from the time I was a little girl, and no answers. So I was very blessed to actually get pregnant when I was 19. And, looking back, you never know really until you look back why things happen. But I was a single mom for 6 years. And if I hadn't gone through with the pregnancy, I would never have gotten pregnant. So my journey after being 19 and a single mom, it took me maybe till I was 27, I think, 26, to find my answers of what I was dealing with, and finding Dr. Nejat and having my first surgery. And I've had about 8 surgeries since 2003. And this disease is very invasive, and especially if it's, invading your body, where you have it growing on your bowel and your bladder and the cul-de-sac and all over. So an invasive disease that just took over these organs. And thanks to Dr. Nejat and his expert hands and tools and approach, the many surgeries I've had have really helped me to have a much better life. I'll never forget, after the first surgery, I could actually touch my toes when I did yoga. And all my life, was like I couldn't get close to my toes. And so being able to bend over and touch my toes was a huge accomplishment. And just getting all that toxic growth that just takes over your body. So I know I'm one of Dr. Najat's most extensive cases, and I also feel like I'm a very good success story. I not only utilize the technology of surgery and, you know, cleaning up all that mess and, you know, toxic growth, but also doing natural remedies and working with Dr. Osias, who, if you guys don't know who she is, she's also a part of this campaign for EndoMarch. Wonderful woman. She just helped me so much with hormone balance and, you know, supplements and diet and exercise. And I just can't say enough how much that helps to carry this disease. So you got to be really proactive and loving to your body and every way you can, not just the surgery and drugs, but everything you can, from what you eat to, you know, what you think even. So positive thought and, you know, really goes a long way. And for me, my work with women and helping women around the world really keeps me going, because I have a mission that's bigger than myself. So I deal with chronic pain every day. I just had surgery a little over a month ago. And luckily this time I put it off for 4 years. So before that, it was every 2 years. So there is, you know, hope in the horizon if you are dealing with chronic endo on the bowel and bladder and wherever it might be. As you go through this, you can start to, you know, have less need for surgery. And so I'm very grateful to Dr. Najat and your team for always being there for me and helping me find the answers and not telling me I'm crazy when I come to you, you know, last month and say, I'm having this really bad pain and, you know, I should be better, but I'm, you know, it doesn't, this is a very mysterious disease that has a mind of its own. And you just got to keep moving forward and finding the answers for each step. And so I'm just so excited that EndoMarch exists and that Dr. Najat, you and your brothers and all the many wonderful doctors are working so hard for women like me to find more answers. And so yeah, my condition was a very extensive. I ended up having severe adenomyosis. I did 2 in vitro sessions once I was older and married. Obviously didn't work. So some, you know, I was very blessed to have my son, who's now turning 25 this year. So when I was a 19-year-old single mom.
Thank you so much. I want to let you know the purpose of us asking Naoma to be one of the speakers, because we wanted to see that how a woman who is changing the world on her own right, her and her husband, as I said, they have one of the most successful companies in this country. That is the only company that actually, to my knowledge, the tea company, traditional medicinal, actually I advocated for all of our patients post-operatively that they go through FDA approval. So she is running a very successful company. Also, she has a philanthropist of having an organization and travels all over the world for that person, for that purpose and women's rights. And for years, she was telling, it was somebody with that acumen, that much work, and she is ready to do a lot of work. But earlier, for years, it was said that it is in her head, it is nothing important. They meant well, they had good intentions. The problem is what the eyes don't, what the mind doesn't know, the eyes don't see. That's why we are trying to increase the knowledge, the awareness about endometriosis. And example is one here that, again, with all of her acumen, had to go through all of that. One of the severe cases of bowel endometriosis. Thank you very much, Marianne. I will go to Dr. Sina Nejat to say what is the story of Gail Barker, and then we will go ahead with question and answers.
Good evening, good morning, and good afternoon to everyone. It is a pleasure to be with you today. I am honored, and it is with really pleasure that Mrs. Gail Barker accepted to our invitation to share her story with us. She is a true fighter in my eye from the beginning. Actually, she realized of her endometriosis. She's a true woman advocate about endometriosis, has been very, very active on sharing her story, talking with people, and even though many things like having children, she would tell you this, her story. She couldn't get it, but she wants to have other people know about it. So I'm not here to tell you who Gail is. I would let her speak, and you would tell by yourself that what a wonderful person is in all aspects. Mrs. Barker, you are muted.
All right. Hello, Dr. Najat and everyone. Thank you so much for the opportunity to share with you a small portion of my journey as I learned of my endometriosis. But I would like to say that I'm speaking to everyone from Atlanta, Georgia today, and it's been over 20 years. It's really been quite some time since I had my endometriosis bowel resection that Dr. Najat and his team performed on me. I would like to start also by saying that I'm so thankful that I had the experience that I did from Northside Hospital with Dr. Najat. You guys gave me what I consider a new lease on life. And as I think about it wholeheartedly, I could get emotional because I had struggled with endometriosis for most of my adult life. And actually, from the time I started my menstrual cycle at age 12. But I thought then the pain that I was suffering from was just normal, you know, that you have this pain once a month and it goes away, only to learn that after I got married, my now ex-husband and I had decided that we wanted to try to have children. At age 25, I went off birth control pills and learned that, oh my God, my body woke up with severe pain, and I went through 5 years of treatment trying to become pregnant, to have a baby. But just, you know, at a high level, I don't want to go into too much detail because it's been a long time and I had quite a journey. I wanted to also, you know, just to share that I had two goals in mind once I learned that I had the endometriosis, and the real reason for all of my pain was to relieve the chronic pain that was debilitating me. My whole life after a certain point, at the 5-year point, was miserable. I mean, all I wanted to do was to take drugs for the pain of the endometriosis. And it was just hard for me, and to try to have a baby. So I experienced a lot of surgeries and multiple procedures, just trying to get to the point of relief and hopefully become pregnant. I even at one point in time, I had issues with my ovaries and cysts, and I did get a topular pregnancy out of the whole treatment. And then I was eventually introduced to Dr. Najat because I was in North Carolina at the time. And at that point, I started having problems with my bowels. I was bleeding when I would have my menstrual cycle in my bowel, and I couldn't figure it out, but I had to plan and prepare for those unexpected times. And in doing so, my gynecologist at that time referred me to Dr. Najat, and because he felt he had done all that he could do for me. And once I got introduced to Dr. Najat, I came to Atlanta, and he performed a surgery. Then it was painful, but I consider it a wonderful surgery now. And I say painful only because when I woke up, I had only expected to be there like overnight trip. I didn't know I was going to be there for a week, because once they got in and performed the surgery, they realized that I had endometriosis everywhere, and including my bowel. And it explained all of my pain. And really, I become frustrated once I learned, because I thought about all the procedures prior to, and everyone had told me they had hopefully and thought they had fixed my problem, which in actuality they had not. But I went through the procedure, had the bowel resection, and again, it was, I felt great, full of energy at that point in time. And after that, I went through about a couple of years after and decided that, I was feeling good, but I was concerned that the endometriosis could potentially come back. And I was concerned that maybe something like cancer could grow in my body. And I ended up having a hysterectomy. But the great news is, once I relocated to Atlanta, I moved my medical records and started seeing Dr. Najat, and he's been treating me ever since. And I thank God for him and his family and what you're doing today to make everyone aware of this horrible disease called endometriosis. Because unless you really have experienced it, and especially the severity of it, you really don't have a clue as to what we go through. And it's because of you and your team that I can say that I feel like I'm a success story with you and all the assistance that you've given me. So thank you for that.
Thank you very much, Kate. You are very kind. We appreciate it. It was very kind of you to share your story. And that exactly brings us to the next step that Dr. Louise King from Harvard, he is going to address. There are many questions in respect to endometriosis, of how to diagnose it. Is it colonoscopy a good way to do it? How often colonoscopy shows that? If endometriosis involves the bowel, bladder, rectum, and how could we address it? Again, these are all in general. You have to always ask an expert, and one of those experts is Dr. Louise King. Go ahead, Dr. King.
Thank you so much for the invitation to participate today, and thank you to Naomi and Gail for sharing their experience. It's so important to hear from patients in these settings. The question generally is how best to diagnose bowel endometriosis. Colonoscopy is sometimes suggested as a way to diagnose it, but of course the endometriosis that develops on bowel will develop from the outside in. So the deposition of these lesions will occur on the outside of the bowel that's presenting in the abdomen first, and then eventually proceed through the different layers of the bowel and eventually arrive at the mucosal layer. Bowel endometriosis can present with symptoms even before it reaches the mucosal layer, including bleeding just from irritation and inflammation. So if you rely solely on colonoscopy to try to assess if a patient has endometriosis, you're likely to miss something. Not all endometriosis that is symptomatic a problem for patients and should be resected is going to proceed all the way through into the mucosa and be visible with the scope and colonoscopy that's coming up into the bowel lumen. Some imaging modalities can show endometriosis on the bowel, but it's dependent on the skill of the technicians who are doing those images for you, and also dependent on the radiology team and their experience in detecting endometriosis. So some really advanced ultrasound teams can detect endometriosis using a combination of transvaginal and transrectal ultrasound, but those are very few and far between. MRI can sometimes, again, show bowel endometriosis, but it depends on the radiology team and whether they're really well trained and well versed in identifying it to truly pick it up. So with any patient that is presenting to us at our clinics with any kind of GI symptoms whatsoever, and not just blood in their stool, but difficulty passing stool, IBS type picture, pain with passing the stool, or dyschezia, which is the fancy name we give it, we should be thinking about bowel endometriosis as a possibility, regardless of what we've seen on any imaging, whether that be ultrasound or MRI. and have a plan in place for what we want to do with it if we move forward with surgery and identify it at that time.
Thank you very much, Dr. King. And the next question is for Dr. Marianne Schutzer, the colorectal surgeon of esteemed reputation, who has been working with Dr. Sinan Nejat, Dr. Azad Nejat, and myself and Dr. Paul Nejat for years. And she has extensive experience about the endometriosis of the bowel. Would you please, Marianne, explain how many different kind of bowel endometriosis there are, and what are your approaches? Which kind of resections do you recommend, and where and how?
Of course, I think the answer to this question has already been partially touched upon, because we've talked about the fact that endometriosis of the bowel often begins at the outside of the colon wall or at the small bowel wall. Let's begin by saying that endometriosis can be anywhere in the abdomen. It can actually even be outside of the abdomen, but it can be on the mesentery of the small bowel, on the outside of the small bowel, and often on the colon. The outside of the bowel will usually be on the sigmoid colon, on the rectum, or in the space between the colon and the vagina, or the rectum and the vagina, called the rectovaginal septum. If we have implants that are only on the outside of the colon wall, then often we can shave those implants off. And if they're even just slightly deeper, then we can excise that lesion without going full thickness into the bowel wall or having to resect the entire bowel wall, doing a little disc excision, removing a layer of the bowel wall and then closing it. If, however, the involvement of the bowel is more extensive, i.e. it extends inside significantly in terms of more than a very small surface of the lumen, or actually obstructs the bowel wall, which can happen in the sigmoid, in the small bowel, often even mimicking a cancer, then that lesion at that area will need to be resected. So I think it requires expertise, experience, and understanding the depth of penetration to understand how we can best relieve the symptom of the patient.
Thank you very much, Dr. Schutzer. The next question is for Dr. Farnejad, and in general, the question is, if a patient, like in this specific patient, that some of the 2 or 3 patients, they were like this, so we have mixed it up. Again, you have to have obviously be examined by a physician before they can give opinion for sure. But in this case, this patient has had surgery in 2011. She had the endometriosis has been excised, and also she had a hysterectomy. Then she had in 2014 an MRI that showed that she had endometriosis of the bowel, and she had surgery, and she has had some symptom relief, but now she has had severe constipation, diarrhea, distended abdomen, rectal pain, pain with bowel movement. Symptoms are getting worse. Patients like that, she says she has had bowel surgery before. Is it possible that she has had recurrence? How would you approach that? And the question would be answered by Dr. Parmesan.
Hello, it is a pleasure to be here. I just want to quickly clarify a few things as a general things. One is that when we talk about bowel endometriosis, the bowel could be large bowel or a small bowel. And the most common area of the endometriosis is the large bowel in the lower portion, which is called rectum. Then goes higher up, called sigmoid colon. Then appendix also is part of the bowel, and ileocecum, and a small bowel. So symptoms of the bowel endometriosis depends to which part of the bowel. That is one thing I want to clarify for all the audiences. The second thing is if patient comes to me and says, I have had excisional endometriosis, I just want to clarify this one. Excision could be complete or could be incomplete. Sometimes it is safe to completely excise the endometriosis because the tissue under the lesion, it is safe to remove it, like pelvic sidewall, not close to ureter or other areas. And when it comes to the bowel, as Dr. Schultz says, you have to individualize the person. Unfortunately, the bowel endometriosis is very difficult to manage. Overall, endometriosis surgery is difficult to manage. That is the reason that a lot of gynecologists will not touch it. I am an oncologist, I'm a cancer specialist, and sometimes endometriosis surgery is more difficult than cancer surgery. So the role of the expert in endometriosis, especially when it comes to the bowel endometriosis, and have a multidisciplinary group like Dr. Sinan Najat, Dr. Kamran Najat, that they have teams of colorectal surgeon with them, or even myself, in spite of being oncologist, in our team, we have colorectal people to work with the team to evaluate the patient properly. To answer your question, that particular person, as a general, yes, you may still have endometriosis of the bowel, especially if the MRI has shown it. However, that person has to be evaluated, her record has to be evaluated, patient has to be examined to be sure she doesn't have other condition and that mimics the bowel endometriosis. Because you see a lot of patients that they have these symptoms, and when we do a thorough laparoscopy evaluation and they don't have bowel endometriosis, then you have to address the condition different ways. Thank you.
Thank you very much, Dr. Parnejad. Now, Dr. Sinanejad, some questions that have been in respect to all the symptoms of bowel. Is there anything specific? Some patients that I've had, is there anything related to the pain in the vagina or prolapse of the system? Could it be bowel endometriosis? How would a patient know that she may have bowel endometriosis with the symptom? If you could address that.
In general, if a person listens to the body language and you don't feel right, it is not right. It is not in the head. So if a person has pain with bowel movement, indigestion, feeling pressure in the vagina, changing of the bowel habit at the time of menstruation, ovulation, pain with intercourse, none of these are normal. All need to be evaluated. So bowel endometriosis could be silent to the point that a person, I have had person who came to the emergency room with bowel obstruction, or they had to put a stent on it, and she had no symptom until she had bowel obstruction. Or there are patients who have superficial lesions on the nerve pathway of the pelvis. So feeling rectal pressure similar to the prolapse, it is not uncommon with endometriosis of the pelvis. Pelvis is an area like a cul-de-sac, like a neighborhood. It has all the nerve pathway coming to the bladder, to the vagina, to the cervix, and to the bowel. So it is better to be evaluated.
Thank you, Dr. Sinanejad. The next question is for Dr. Louise King, and the question is, how often this endometriosis could get, like, not only the bowel, could it be bowel and the bladder at the same time, or the symptoms if the endometriosis, as Dr. Farnejad says, endometriosis of the rectum could be near the rectum. It could be on the rectal bulb. It could be higher on the rectosigmoid colon, goes to a ileocecal and appendix. So, Dr. King, would you differentiate any of these symptoms, or I appreciate if you address that question.
Well, in terms of the actual incidence of each different type of endometriosis, I know that that's been published on, and endometriosis can be present in anywhere between 12 and 40% of female population, depending on what you look at. And similarly, the incidences for each different type can range so widely that sometimes it's not that relevant to think about. But I'd like to pick up on comments made by Dr. Far Najat and Dr. Sina Najat about how bowel endometriosis can be silent and it can present in a variety of different ways, as can endometriosis of all the different aspects of the pelvis and the abdomen. And again, picking up on Dr. Scherzer's comments earlier, it can be found anywhere in the abdominal pelvic cavity or in other areas of the body. The second most common place after abdomen and pelvis would probably be the lung. So again, building on what's been said before, if somebody is feeling poorly and can identify their symptoms specifically, there is something wrong. Pinpointing exactly what is going on based solely on symptoms can be exceedingly difficult. Our neural pathways and neural systems are not set up to provide the exact notice of exactly where the problem is. And as I learned in fellowship with you, we had patients who came in with right-sided pain and left-sided pathology. So it's not exactly easy to tell just in the clinic by going through a careful history. The careful history is so important, but I probably won't be able to tell patients exactly where the problem is until I have extensive imaging and have performed the laparoscopy. And even then, the diagnostics can become difficult, as Dr. Farnajat was just elaborating on, because there can be many contributing factors, musculoskeletal issues that then contribute to the pain, etc. I hope I've answered your question, but if you need further elaboration, just tell me.
Thank you very much, Dr. King. Exactly, you are correct. For the benefit of the audience, we have tried to, again, condense the question, but make sure everybody who has written the question somehow they are being answered. So there might be repetition, but I think actually that's as a benefit, because it would, they would learn more, and as people join, as we are speaking on the line, and more people are joining, so they would hear it again. And the next question is for Dr. Schertzer. There are some patients, like this patient, who has had bowel endometriosis. She has had surgery by open abdominal surgery by laparotomy. And her symptoms at the very beginning has decreased in general of her pain, but her bowel symptoms have gradually increased. Dr. Schertzer, how would you approach patients like that?
I think it's important for us to realize again that, as Dr. Farnajat had said, often surgeries are incomplete for several reasons. The main reason being that the area in which the endometriosis was involved in abuts things that are difficult to address, i.e. the ureter, iliac veins, arteries, things that we really cannot sacrifice during surgery, and so we're careful not to. I think most important, we need to make sure that there are not other things going on. Because someone has endometriosis, remembering that endometriosis can mimic almost anything: cancer, irritable bowel syndrome, diverticular disease, colitis. We need to be sure that although they have endometriosis, they don't in fact have another problem. And that certainly can be the case. So we need to evaluate, I think, the rest of the GI tract. What I would generally do is be sure that the small bowel is not causing some of those symptoms with perhaps a CT angiography, and be sure that we rule out the other causes of symptoms that are so similar to endometrial disease. Again, like colitis or diverticular disease or even cancer. These things cannot be simply not thought about because someone carries the diagnosis of endometriosis and has been operated on for it.
Thank you very much, Dr. Schertzer. The next question is for Dr. Azadeh that we have been working together on our niece for the past decades, and then she would address and answer the question of several patients, including this specific one that she says she has so much pain with her bowel movement, especially when she has her periods, that she feels she is passing out, and she has to occasionally go, some of them, to the emergency room, or the pain is significant. Can that much pain around the time of menstruation with bowel movement that sometimes is associated with constipation or diarrhea be a sign of endometriosis?
Good morning, everyone. To answer this participant's question, these are the symptoms that are called vasovagal response that could be associated with endometriosis. But the most important thing is it needs to be evaluated. It is a multifactorial, many other things could cause this vasovagal response, but the severe pain caused by endometriosis, especially during the menses, could point out to bowel endometriosis. But it most definitely needs to be evaluated by someone who's familiar with endometriosis and is experienced in treating endometriosis in the bowel and anywhere else.
Thank you very much, Dr. Azadeh. The next question is for Dr. Louise King again, and the question is it possible that you have significant amount of bowel symptoms, like bowel pain, all the symptoms of bloating, indigestion, pain with bowel movement, and have no endometriosis of the bowel and have endometriosis somewhere else?
Yes, that's possible, and I'm sure exceedingly frustrating for patients. It's much easier to have one diagnosis, but as Dr. Schertzer was alluding to earlier, and Dr. Farnajat also alluded to, there can be other diagnoses at work, and then they can all be playing off of one another. One of the symptoms that you just mentioned was severe bloating, and of course, bloating can occur for a number of different reasons related to prostaglandin release in terms or other inflammatory processes that either originate in the pelvic organs or originate spontaneously within the bowel itself for various reasons. I think celiac's been mentioned, severe IBS has been mentioned, bacterial overgrowth, which we haven't mentioned yet, but can sometimes play a role. And then one of the questions we received when I was reviewing them talked about severe pain with defecation, but no endometriosis seen during surgery or on imaging, and but endometriosis in other spaces. So without knowing every detail about that particular presentation, one hypothesis could be that there's muscular dysfunction within the rectal muscles, not allowing for easy passage of stooling, either as a consequence of or completely spontaneous to the endometriosis. In the same way that a lot of our patients develop pelvic muscle dyssynergia or dysfunction and severe pain in pelvic musculature. So these pictures these clinical pictures become exceedingly complex. The important thing is to form a team between the physician and the patient so that we're working through all the different symptoms and possibilities to get to the answer, but also so it doesn't become overwhelming for our patients, because this can be exceptionally overwhelming where there's not one answer and it gets very confusing.
Thank you, Dr. King. The next question is for Dr. Schertzer. Dr. Marian Schertzer, what is the relationship between indigestion and other symptoms of the GI system in patients who have endometriosis? And how does endometriosis cause problems like bloating and indigestion?
Remembering again, that's a good question. And I think remembering again that endometriosis of the bowel can affect the bowel in many ways and can affect many portions of the bowel. Mostly, let's remember also that Just because endometriosis might be on the sigmoid colon doesn't necessarily mean that that pain is going to be in the left lower quadrant. How many times do we go in to operate on the sigmoid colon, and the sigmoid colon is sitting on the right side of the abdomen? We're sitting higher on the right side of the abdomen. So remembering that specifically where the endometrial disease might be may not be where the patient feels the pain, because the pathways cross over and because the bowel is mobile. Often, as well, endometriosis will involve the small bowel, particularly the mesentery of the small bowel, causing symptoms of partial bowel obstruction and therefore pain after eating, which is quite a common thing to happen. So while we might usually think of as endometrial pain as being pain in the pelvis, it could be pain anywhere throughout the entire abdominal cavity, and particularly after eating.
Thank you very much, Dr. Schertzer. There are many questions again regarding repeat surgery, how to do the surgery, and as we have said it over during the demonstration, every patient needs to be individualized and treated after the examination by a specialist. So we don't give a specific recommendation. But in this, for example, in a case like this, who Dr. Farnage would answer, she has had a stage 4 endometriosis, including bowel endometriosis, and in 2015 she has had surgery, and her symptoms was back, and now her physician doesn't want to do any more surgery. Dr. Farnage, when should a patient with endometriosis of the bowel have repeat surgery? What are the other options? When should she have resection or not resection? Thank you.
Again, the expert panel explained everything. If you pay attention to what they say, is that the bottom line is that you have to individualize the person. One more thing I want to mention is that, unfortunately, endometriosis, in spite of doing the best surgery, the best surgeon does it, and do excisional endometriosis and eradicate the disease, endometriosis could come back. However, when you deal with endometriosis, because fortunately it is not a cancer disease, it is a quality of life. And then to see what you could do, tailor your treatment that is the most effective one and causes the least side effects and complication. This is a general thing that when I discuss with my patient or when I teach to my fellows. So if the patient has had endometriosis and her physician said, I have done excisional endometriosis and now she has symptoms back. As I said earlier, excision doesn't mean that endometriosis doesn't come back. So we have to evaluate the symptoms. And then, if you are highly suspicious that endometriosis of the bowel has come back, my first approach to see if I could manage it medically. Because if you want to do a complete excision of the bowel endometriosis, you have to do bowel resection. And the bowel resection, unfortunately, could be associated with some complication like infection, bleeding, even nerve damage. So hopefully one day we could find some medication could take care of it, like the same way we are finding new medication for cancer, we could find medication for endometriosis. Right now, we have some medication like GnRH agonists, antagonists, progesterone. I know all of them, they have some side effects, but we have to, in our treatment planning, having this medical treatment available. And if you have symptoms, my first option is to offer them medical treatment and watch the person to see if she responds. If she doesn't, and I'm highly suspicious after all we said, thorough evaluation, colonoscopy, imaging, If I still am suspicious of a persistent endometriosis, discuss it with the patient about the goal, what do I want to achieve, and what is the possible complication, and we make a joint decision to proceed. Thank you.
Thank you, Dr. Farnisha. Yeah, and that leads me to the next question for Dr. King, that it is almost the same. Again, as I said, a lot of them are repetition, but it is very helpful as people are joining the, and this live stream is going to be online and people would hear it again. Dr. King, there are patients who have had surgery, including bowel resection for endometriosis of the bowel, but their symptoms continue. This patient wants to know if there are any other treatments, including alternatives, herbs, or, for example, physical therapy, or do you recommend anything else?
It'd be difficult to give a recommendation without knowing more specifics, but in general, there are a lot of things we can do. So let's presume, for the sake of argument, that the excisions were adequate and there's no residual endometriosis. I mean, you really do need to know that that's true. You need to have either done the surgery yourself or know the surgeon who's done it, and really feel confident that there's no reason to be going back for another surgery. But assuming that's true, there are still patients with extensive symptoms. And I agree, it's really important that we're repeating all of these topics over and over again, because it is worth saying again that there can be many different processes that are going on. So really sitting down with a patient, thinking really broadly about what different things could be affecting the gastrointestinal system or the urinary tract system, and approaching it from a multitude of different angles. So in my practice, we have a lot of, and I know in many practices, especially in yours, Dr. Najat, there are collaborators within Boston and within Palo Alto area, and I'm sure around the country, who know a lot about alternative and complementary medicines. Acupuncture is fantastic. Different really talented pelvic floor therapists can be exceptionally helpful. I know many patients have found pelvic floor therapy frustrating, and like anything, it depends on the talent and skill set of the person that you're working with. But I've seen many patients have great success with that. Changing your diet, being very conscious of your diet and what are your triggers and what inflammatory triggers you might have is very important. And then even we work with some of our patients on mindfulness training. There are many different avenues to pursue. It may be that Naoma has something to add to this as well, given her work in herbal therapeutics, which I don't know as much about, but I partner with people who know quite a great amount about that, both from the Ayurvedic or Indian tradition and then the Chinese tradition. So as far as I'm concerned, when I work with patients, if we find something that's helpful, let's pursue it. And I'm always willing to think very broadly. But I do want to be sure that that initial surgery, that I'm not relying on it incorrectly. I want to know, read the op report, know that something's been done that is adequate treatment surgically first.
Thank you, Dr. King. And you are correct. Herbal medicine, they indeed are very helpful at times. We have seen it in some patients. And that is why we have Mary and Naoma Sadler on the line. As I said, we are very lucky to have her because she is the founder of Traditional Medicinal that has been, that is the only herbal medicine, to my knowledge, and Marianne can correct me, that I think they have the teas that some of them for the digestive tracts, like a smooth move, etc., that has gone through FDA. And also, of course, with Dr. Joel Osias, one of our physicians here in Palo Alto, who does a lot of alternative treatments. So, Naoma, are you online? Would you like to address the question? You want to add anything?
Well, I think everybody's has a real individual, everybody is unique in what works and what doesn't. And so what works for me may not work for someone else. And, the smooth move tea, obviously you recommend after surgery, which is very helpful. and it is definitely a laxative medicine. There's so many other teas that traditional medicinals makes, and a lot of them are for digestion and cold and flu and women's health. So each formula it can be tried, and one of my favorite ones that I drink for relaxation when there's cramping and pain is chamomile lavender. It's a formula with the pharmaceutical grade chamomile and lavender. It's a really lovely tea. I make it very strong. I'll use even 4 bags and drink that down, and it really just calms the whole system and all the cramping for the bowel especially. So there's many different kinds of teas to try, and as far as just working with Dr. Osias, it's also a lot of supplements and just what you eat and don't eat. And so trying different things that may be more irritating to your bowel, eliminating foods and trying that and seeing if it helps is really essential. And like I said, everybody's different. So I find my pain is really well managed when I follow the keto anti-inflammatory diet, which obviously is recommended for cancer patients and people with inflammation. Endometriosis and inflammation is one of the things that's the hardest to deal with. And so if you are what you eat, they say. And so if you can manage what you put into your body, it can also have a significant effect on mitigating your symptoms. So for me, the keto diet, which is, no sugar, no carbs, and, anti-inflammatory is been a huge success for me personally. So,
thank you very much. Go
yeah,
ahead, please. Thank you very much, Naoma. And Dr. Schertzer, there are a lot of patients that they come to you and for years they say you have irritable bowel syndrome or diverticulitis and they end up having endometriosis. What is your experience in this regard, or how could it, or are there patients that they could have a combination of all of the above, or how do you differentiate between them and how could you manage them?
First, sorry, can you still hear me? Okay. I think it's important, as I touched on before, to recognize that none of these diagnoses are exclusive to each other. So patients who have endometriosis may very well have irritable bowel syndrome, may very well have diverticular disease. They may very well have all three. Endometriosis is the grand mimicker of everything. Often you go into the operating room thinking you're operating on a patient with a cancer because they have a mass that's completely obstructing the small bowel, and the final pathology is endometriosis. So one always must approach the patient with the idea that there may be more than one diagnosis and that you need to treat the patient and not a specific diagnosis. Treat them broadly because we may in fact have more than one thing we're dealing with. So it's always important to work up the possibilities, keep the other possibilities in mind, and never focus singly on any one diagnosis, even in a patient who already has and carries one of those diagnoses.
Thank you very much, Dr. Schertzer. There are several questions from England, and one of them was specifically that, again, Dr. King hopefully would address it, is about diverticular disease, the diagnosis of diverticular disease, endometriosis that Dr. Schertzer just addressed it, and the role of exercise and other remedies for this treatment. And I don't know if Dr. King has any experience in United Kingdom, but this specific patient is asking, is this something doctors in United Kingdom should know about? I don't know if we can address that or not.
Well, we as physicians who specialize in women's health, whether we're in the UK or the US or anywhere in the world, we should know as much as possible. And so, of course, they should know about alternatives. They should know what Dr. Schertzer has reiterated a few times, and I'll repeat again, which is that diagnoses can exist together. So you could, for example, be told that you have diverticular disease when you in fact have endometriosis, or you could have both at the same time. And getting to the bottom of that requires diligence and a multidisciplinary team typically, who is really going to take seriously what you are complaining of and is going to work you up in the appropriate fashion with both imaging and typically surgery. In terms of exercise, for any patient that is suffering from any chronic condition, and endometriosis is a chronic condition, exercise is beneficial. We know that it releases, if you exercise regularly, you release endorphins, which are natural painkillers, and natural anti-inflammatories. So a reasonable, regular exercise regimen will benefit you. And physicians, of course, around the world should know that recommending exercise that is appropriate to you and to your condition would definitely be of benefit. Sometimes patients, though, are in such pain that they can't even get there. And so again, as has been said before, but should be said again, these are all individualized conversations that have to be had with the patient in front of you, meeting them where they are and finding solutions moving forward for what they are currently facing. Sometimes exercise is not an option on the table at that moment, but hopefully something we can work up to.
Thank you very much, Dr. King. We are going to continue. We have some more questions and that we are going to answer them. And we have a lot of people even now joining the stream and they are listening. So we will, it has been already almost an hour that we have been online, but we will try to finish the questions and answers as soon as possible. So I am going to combine some of more of the questions together, and hopefully we can get to them again, because we appreciate you, all of you are watching and joining. Because of that, we will continue the session. Dr. Schultz, so this question for you, that could patients with bowel endometriosis at the time when they have bowel movement also have some discharge from the vagina, like bloody discharge? Is it possible? One, and the other one is also the patient that they have GI symptoms. What are the GI symptoms that they could have with the patient that have bowel endometriosis?
I think they're both good questions. First, they recognize that one of the major places in terms of anatomic position for endometrial disease is always going to be in the pelvis. Again, it could be anywhere, but in the pelvis and specifically in the rectovaginal septum. So if we have disease in the rectovaginal septum during defecation, when a patient is going to the bathroom, they may very well have some drainage and discharge into the vagina, usually blood, basically because of the position in which the endometrial disease is. Other GI symptoms can be, there are many, but specifically, because endometrial disease can just be deposits along the mesentery, or can actually completely constrict the lumen of the bowel, symptoms of obstruction can occur. Endometriosis often, just by its nature, is sort of like very fibrotic and very concrete in its nature. And so often patients will just have specific bowel wall pain just because of the pressure of the endometrial deposit on the bowel wall or in the pelvis. So pain, pain after eating, pain during bowel movements, bleeding during bowel movements, those are the usual GI symptoms of endometrial disease.
Thank you very much, Dr. Schultz. We have had a lot of questions that they have been coming in through the live stream, and I think most of them we have tried, and I have to thank our fellows, Dr. Anupama and Butler, that she has been trying to answer them, and Dr. Asari and Dr. Roman. But there is one that Dr. Sina Nejad, if you could address it, and has been about women who are trying to get pregnant and they have bowel endometriosis. How aggressive should be or should they be in treating the bowel endometriosis? Or what is the role of IVF, or when should it be done? When should the surgery should be done? Dr. Sinanajal, could you please address that one?
Yes, thank you. One thing we have to remember, endometriosis is not just a disease, it's a process. It's not it has different manifestations. It could be inflammatory endometriosis, it could be superficial, it could be fibrotic. So it is an enigmatic disease. A variety of endometriosis could exist and create variety of symptoms. So knowing the fact that we are talking about how to treat the endometriosis, we have to know what type of endometriosis it is, and definitely it could cause inflammation. Inflammation could be associated with inflammatory bowel symptoms, etc. As far as the infertility and fertility management endometriosis is concerned, dealing with bowel endometriosis in an infertility patient all depends on the invasion level of the disease. Sometimes during treating endometriosis at the time of surgery, less is more. It means if it comes to the point that we know this endometriosis does not cause bowel obstruction or ureter obstruction, or is not going to lead to the losing of the organ function, it is okay to leave some of it behind instead of going deep into the bowel and cause infection to damage the tubes, the ovaries, and compromise the fertility. So we published our experience, we call it fertility enhancing endometriosis surgery, and at that time it is better to stop at one level, letting the patient know that there are some diseases are behind. Some of them may regress. About 25% of the time it would regress and wouldn't need any more treatment. Or when they are done with the childbearing and reproduction, and if they have symptoms or if the disease is invasive, then it could be addressed at that time. Thank you.
Thank you, Dr. Sunanaja. There is another question that Dr. King could address it, that there are patients that have had bowel surgery or endometriosis surgery. The endometriosis has been thoroughly treated, but they continue to have bowel symptoms. How should they address it? Is there any food they can eat that it makes it easier? How should they address those continuous discomfort despite surgery, and how often surgery might not be successful?
So bowel endometriosis does frequently recur. The first step for anybody who is addressing this with a patient is going to be ensuring that the surgery was done adequately and that the whatever could be removed was removed. We've discussed in our conversation so far sometimes sometimes surgery for endometriosis might be incomplete. So making sure that we really don't have further lesions that ever could be removed is the first step. If we're really there and we have a patient who's undergone even multiple surgeries and we really haven't gotten to the bottom of the problem, we might not have done a good enough job of elucidating all the different contributors to this patient's pain picture. And so as we've said a few times, multiple disease processes and painful diseases can exist at the same time. If somebody's still having significant bloating, for example, which is such a common complaint, but we really feel like we've addressed all the endometriosis lesions that can be addressed, we need to start looking at diet. We need to start looking for potentially small bacteria, small SIBO, I never get the name right, but bacterial overgrowth in the bowel. Celiac disease, controversial, but potentially needs to be ruled out. All of these different things can contribute to bowel disease. And so ensuring that you're part of a team of physicians who are working collaboratively and in trying to come to the end result of a constellation of different conditions that might be contributing to your pain is really important.
Thank you very much, Dr. King. I appreciate it if all the panel, all the physicians on the panel, and also Ms. Barker and also Ms. Sadler all of them, if they like to give any comments, I appreciate it if you prepare or you go ahead and give your comments. At the same time, there are some other questions that question number 22 that Dr. King, I think you are looking at it. This is from England, and 23 from Dr. Schutz. If you, and there are a couple of other questions, if you could read it yourself and combine the answers, and we would start with anybody who has to give any comments, would like to give any comment. Dr. Schutz, would you like to give a comment or read some of those other questions that you think you can address it yourself, or you want anything that you would like to add? We appreciate all the participants that are still online, that are not leaving because they are interested to listen. Thus, we have continued the session. We truly appreciate all the audience. Also, we appreciate all of the panel that they have given outstanding information for our patient. Why don't we start with Dr. Schutz, if you would like to add and answer some of those questions that it is addressed to you.
All right. I think perhaps maybe not in summary, but to reiterate particularly everything that has been said earlier, and specifically what Dr. Sinanajat has touched upon. Surgery, specifically bowel surgery for endometrial processes, is complicated. It's probably more difficult than cancer operations. It's probably the most complicated and difficult surgical procedures that I do for several reasons. The main reason is that in a lot of cases, when this is not a complete bowel obstruction, we're talking about quality of life. And for quality of life, we need to think about we cannot do more than we should. If we do more than we should, we're probably going to decrease the quality of life for the patients. So prudence on the part of the surgeon, experience on the part of the surgeon is so important if we wish to enhance the quality of the patient's life and not detract from it, meaning do enough and not too much. That's probably number one. Number two, recognizing that bowel symptoms can always be due to a constellation of problems, endometrial processes being one of them. So whenever we're dealing with bowel symptoms, we always have to keep in mind the constellation of problems that bowel diseases in general will provide. And one needs to keep an open mind every time for every patient.
Thank you very much, Dr. Schutz, for an outstanding opinion. We are very grateful to you. Dr. King, how about yourself?
I also want to thank Dr. Schutz because that is such important points to bring up, that this is difficult surgery and we don't have any definitive research that proves the exact way forward. So it has to be expert opinion, and it has to be so somebody who really knows what they're doing, and then also working with a patient to determine how their quality of life is affected and how far to go. I read all the questions that were submitted, and one topic that we haven't touched on is a couple of people have mentioned that after hysterectomy, they experienced severe constipation, which I've seen as a complaint of a lot of hysterectomy patients. There are a few things that I do typically when that's the primary complaint in presentation. I like to review the operative report, make sure that the surgeon who did the hysterectomy was looking for endometriosis in the event that it was missed and that's contributing, and perhaps we need to go back and take a look and really establish whether there was a full treatment at the time of hysterectomy. But in addition, a lot of women with endometriosis who undergo hysterectomy, even if they've had good treatment, end up with different bowel patterns afterwards, because many women have prostaglandin release at the time of their menses. And so they have constipation ahead of menses, and then this release or loosened stool with the prostaglandin release at the time of menses. And when that disappears, the constipation gets worse. Understanding that can really help women get control of post-hysterectomy constipation that might occur. So that was just the only thing I think we didn't neglect in the questions that were raised.
Thank you very much, Dr. King, for your wonderful contribution. For all the participants, Dr. Schutz is in Atlanta, Georgia. Dr. King is in Harvard University in Boston. And then we have next the question that came up today in the live stream, and this is for Dr. Azadeh Nejad. And Dr. Ozan has a lot of experience dealing with teenagers and young women with endometriosis. And one question is for you, Dr. Ozan, that how do you deal with teenager young women when they have severe pain and some of them have endometriosis? What is the best approach for them if they have bowel symptoms?
I think just like any other patients, we would we try conservative management mainly to try to see if that helps. It's anywhere from 12, 13-year-olds to the age that they could try other things to see if that relieves their pain, and a lot of these things are specific to their symptoms. So we treat that way. Ultimately, if none of these works, obviously the surgery to treat or exactly diagnose where the symptoms is it related to endometriosis or to rule out any other cause of their pain should be done. And I think that's usually has been our approach. So with any other patients, we do similar things.
Thank you very much. I just mentioned this specifically because this question comes up, and this past week alone, we had, and this is why we have to have an open mind about endometriosis. And endometriosis is an enigmatic disease. This is why, as Dr. Farnejad has said for many years, hopefully we find a medical treatment for it because it is spread. It is not cancer endometriosis, but sometimes some of the behavior of it, like metastasizing, is like cancer. So we have open mind. We have had recently a very young girl, only 12 years old, that had all over physicians everywhere, and unfortunately has had all kind of workup, and parents were desperate, everybody, and very, very rightfully, all the physicians who had seen her had tried all the conservative approaches, and nobody didn't know, and they finally was referred to us and to our own, not, of course, we haven't been very surprised ourselves, but we found endometriosis, we treated it, and she is a different woman. So what I'm trying to say, we have to have an open mind, and as Dr. King said many times, individualize the care of each patient. Every patient should be properly treated, evaluated by a physician. Dr. Farnejad, do you have any additional approach advice?
Just want to add one important point for our patients that they have been dealing with this issue for years. When you decide to choose your physician, first do your homework. You should evaluate that physician experience with endometriosis, write down your questions. And when you see that physician and you are concerned about bowel endometriosis, bladder endometriosis, and if she or he is capable to address your questions and your desire, let her or him to operate on you. However, when he operates and he has credential and says you do not have bowel endometriosis, do not pursue it anymore. Because as Dr. Cameron just said, endometriosis, and other people said the same thing, endometriosis is the disease of the body and mind. And the women that they have gone through a long time of the suffering and reading the Google, talking to the neighbors, they have all kinds of ideas in their mind. At the end, you have to come to conclusion with yourself that you do not have bowel endometriosis, or you do not have bladder endometriosis, and then focus your issue to something else. Otherwise, you are going to find somebody else to operate on you, or sometimes they remove your ovaries, sometimes they remove your uterus and cause more problems. Thank you.
Thank you very much, Dr. Parnajat. Dr. Sinanajat, do you have any comments?
No, I really have enjoyed being part of this. I would like to thank our patients who volunteered their time. I would like to thank all the panelists for their excellent contribution. It is so much said that I just like to sit back and digest it because I learned a lot today. And I'd like to thank all of you for this opportunity.
Thank you also, Dr. Parnajat. Ms. Barker, do you have anything you would like to add? Any comments you would like to say? Gail, are you online? Would you like to add anything?
Yes, hi. I just want to say that it has been a pleasure to sit in on the seminar today, and thank you so much for the invitation and all that I've heard. I could relate to in some way, shape, or form, and including the recommendations for post-bowel resection and what you should take when you want to avoid having constipation. And I would like to just add that for me, probiotics have worked well for me, and it may be something that someone else could use as well. Just a more natural approach for me. But thank you very much. I don't have anything else to add, but it's been a great experience.
We thank you very, very much immensely for your participation, Ms. Barker. Thank you. Naoma Sadler, do you have any comments, recommendations?
Well, again, I'm just really honored to be a part of this and to be able to, share my story and have the support of all of your team, Dr. Najat. And I echo Gail on the probiotics. It's a very important part of the supplements and things that you can take. Our gut is, a big part of our immune system. And so treating this as an autoimmune disease and giving yourself all that autoimmune support is really key. And probiotics is a really big part of that. Thanks for saying that, Gail. I don't think a lot of people realize that. So just got to keep on keeping on and putting one foot in front of the other. And one of my biggest tools I use is trying to have a positive outlook and not let the heaviness of this disease get me down. Just one day at a time kind of approach. And, just hope that there's more answers as we go forward. And, having 1 in 10 women carrying this disease. And we know it's probably more than that because of the limited testing that is available. So I imagine it's more like 1 in 5. But that's obviously not mine to say, but I just hope and pray that we continue to do this work together. All the Najat brothers, you guys are all just so amazing. My hat's off to you. I'm just so happy I found you guys, and all the work you do for us women is just extraordinary, and I'm just so grateful.
Thank you very much. You are very, very kind. In general, I wanted to thank all the panel one by one for their immense contribution. I also thank all of you for listening. And please realize that when we started Worldwide EndoMarch, our goal was to raise awareness, find a method to diagnose it without surgery, and find a treatment without surgery and a method to prevent it. That is truly the goal of all these sessions. And we are gradually approaching that. By yard is hard, by inch is a cinch. We are moving little by little, and we already are making an impact. It is because you, as women, you are interested. There are at least 200 million women around the world that have endometriosis. It's very common. In America, at least there are 10 million women with endometriosis. But in America, in the US, we have subspecialists to treat gynecological cancers, and there is a specialty called GYN oncology. And there is only every year in America less than 100,000 GYN cancer. But there is 10 million women with endometriosis, but there is no specialist for endometriosis. Although Society of Laparoscopic Surgeons has started a fellowship for that area, and American Society of Reproductive Medicine and Society of Reproductive Surgeons have started that process, but it takes a long time. So that is why we get united, understand the problem, and then we hopefully can help women and young girls who are the foundation of each family. There are mothers, there are sisters, and there are wives. So these are the foundation of each family is a woman. So we have to make sure the endometriosis that is so common is treated, because it changes the quality of the life of people. Unfortunately, still people, they say it is in their head. They think it is in their head. Imagine that 12-year-old girl that we treated her, her life is totally different now, just even within a short period of time. So we need to listen to the patient and we help them. We thank you very, very much again for your attention, and we will see you next month with the next session. Have a great week and the month.
Thank you. Thank
Bye
you.
bye.
Bye-bye. Thank you, everybody.
Good morning. I am Michel Canis from Clermont-Ferrand, France. I first want to thank you very much for the invitation. I'm very honored to be involved in this exciting and interesting conference about endometriosis. And now I will move to my slide presentation. Today I would like to propose that endometriosis may not be a chronic disease. I have conflict of interest, I'm a surgeon, I'm convinced that we should change our view about this disease, and I want optimistic perspective for my patients. And I think that we need an alternative to endometriosis as a chronic, inflammatory, complex, and multifactorial disease. I was involved in the scientific program committee of the 1986 First World Congress on Endometriosis. Genetic, immunology, inflammation, prevention, early diagnosis, and markers were already discussed. Since we made significant clinical progress in surgery, assisted reproductive technology, and imaging, but our understanding of the disease is still limited in spite of multiple very interesting and fascinating research which have been performed. So we need to look for a different hypothesis to understand endometriosis. In 2017, I proposed that trauma could be a cause for the disease. Why such a proposal? Because I need a way to try to understand the various phenotypes that we may observe in these patients. Why did I propose trauma? Because we all know that trauma is a possible cause of endometriosis in C-section scars or in cone biopsy scars, because we also do know that trauma has a role in the natural history of posterior cul-de-sac disease. Indeed, if you look at this bleeding induced by a clinical examination performed by the surgeon who tried to assess the limit of a deep nodule, you see that trauma to the posterior cul-de-sac has a role in the natural history of this disease. Our proposal was very simple. The extent of the surgical phenotype is related to the extent of the initial trauma. If the trauma is over, the number of implants and the size of the lesions are not going to increase. If the trauma is not over, then the number of implants and the size of the lesions may increase. In this case of deep endometriosis, you see that the clinical examination performed during surgery induced a small bleeding, clearly showing again that trauma to this area may induce remodeling and increase in diameter of this nodule. Third, if the trauma is over, there is no risk of a possible recurrence. Recurrence should be related only to recurrent trauma, and ovulation is an obviously common recurrent trauma. The presence of endometrial cells which will grow and create the lesions may be the consequence of retrograde menstruation, metastasis, metaplasia, embryology, stem cells. Yes, but none of these hypotheses explain why the disease begins, why it starts, and when it starts. In the same way, is trauma more likely to induce the disease in patients with a familial history, with abnormal endometrium, with abnormal immunology, exposed to endocrine disruptors? Yes, probably. I have no problem with that. What are some possible trauma? The first, most obvious trauma is trauma to the ovary. Ovulation is a trauma to the ovarian cortex. And a long time ago, Samson already proposed that corpus luteum hemorrhage could be the cause of endometriotic cyst. This was rediscussed by Farnesat and Paolo Vercellini. And we do know that trauma to the ovarian surface facilitates the growth or the implantation of malignant cells on the ovarian surface. So yes, ovulation and trauma to the ovary is a possible mechanism. Infection was proposed by the team of Professor Kan in Japan, and recently Fusobacterium, a member of the microbiota family, was proposed as an associated cause of endometriosis. But what about trauma to the posterior shoulder sac? Well, do we have evidence for trauma in this area? Paolo Vercellini observed a long time ago that sexual attractiveness was more important in patients with deep disease of the posterior shoulder sac, and the team of Chapon in the same way observed that patients with deep nodule have a lower body mass index. Do we have evidence that trauma to the posterior shoulder sac is possible? And the answer is obviously yes, and this is very unfortunate. Indeed, if you look at the incidence of rape and sexual violence among French students, rape is 1 out of 10. Sexual violence is 1 out of 10. Rape is 1 out of 20. So it's very common. This study from Jurkovic, who followed patients using ultrasound after an hemoperitoneum diagnosed in the emergency room. And he observed in some patients that some of them, a few months after the trauma and after the clot, develop a deep nodule in the posterior shoulder sac. So hemoperitoneum and trauma to the posterior shoulder sac in this study was demonstrated to be a possible cause of deep disease. Unfortunately, yes, because we do know that early life abuse is more common in patients with endometriosis. Unfortunately, yes, because we do know that sexual abuse, and emotional neglect are all associated with endometriosis. We further, in the same way, know that all these mistreatment that are inflicted to young women, to young children, induce a risky sexual behavior. So if they have risky sexual behavior, they are more likely to undergo a trauma to the posterior shoulder sac. So all this trauma to children, or to young women, or to adolescents, may facilitate the growth of endometriosis. Incest, in France, it's about 10%. A few years ago, we thought that it was 5%. The society has not changed. But children are speaking more easily and are much more likely to be taken in account. The judge recently changed their management, assuming that the child has no reason to invent what he is speaking about, whereas the adult has obvious reason to lie. So incest is very common. In France, more than 150 women are killed by their husband or by their partner every year. And indeed, intimate partner violence was also found to be more common in patients who have endometriosis. So sociology could be more important than immunology or genetic to understand endometriosis. And when we look at the content and at the consequence of porn industry on internet, this becomes even more obvious. Most of the content are violent, and this violence does influence the behavior of young adolescents and young adults in their first intercourse. So this is looked by a lot of adolescents, and this does have a lot of influence on their behavior. So obviously the porn industry is changing the field here and may increase the risk of sexual violence. This is a place for rape culture, incest apology, racism, and so on. So violence is everywhere, and this may change our society. So many endometriotic lesions could be explained by a trauma, and I'm convinced that sociology and sociological studies could bring us a lot of insight in understanding endometriotic lesions. From this proposal, many dogma may be reconsidered. A very common dogma is common sense tells us that endometriosis must be a progressive disease beginning with menarche and menstrual bleeding. If so, a positive correlation between age and the severity of the disease should be found at the time of diagnosis. In the prospective ovarian cohort, which was collected a long time ago when the disease was diagnosed by laparoscopy because MRI was not as effective as today, these patients were only newly diagnosed patients with endometriosis. None of them have been treated before, and we found no correlation between the stage of the disease and the age of the patient. And we found no correlation between the diameter of the nodule and the age of the patient. As a matter of fact, older patients had smaller nodule. So these data do not confirm that the disease always begins at menarche. These data do not confirm that the disease is always progressive. So these results do not confirm that the cause of the disease is permanent, and the concept of a chronic disease may be challenged. And indeed, the data from prospective randomized study and the control groups of these prospective randomized studies clearly showed that peritoneal disease could be a self-limiting disease. So if the cause is not chronic, then recurrence is not unavoidable and surgical treatment does make sense. However, a multidisciplinary approach of pain is mandatory to adequately manage our patients, because pain is much more complex than just endometriosis. Could pain be proposed as a warning for prevention and/or early diagnosis? If we go back to the Djokovic study, obviously, a sexual intercourse which is painful may induce an hemoperitoneum and may induce a deep nodule in the posterior shoulder sac. So obviously anything which is painful should be considered as a warning by a woman, and they should not repeat what happened at that moment. They should refuse to do it again. They should ask to stop it immediately so that the disease will not get worse and that the disease will not get bigger in diameter. So from this paper, dyspareunia may be a warning suggesting an anatomical trauma to the posterior cul-de-sac, which may expose the woman to the risk of a deep lesion. So saying no to any painful sex may be proposed as a prevention of deep endometriosis and/or as a prevention of an increase in deep nodule diameter. This is so simple that we should try it anyway. So obviously we should think differently. We have very effective research tools. We have very attractive tools. But without new hypotheses, in my mind, these new tools will bring no improvement in our understanding of the disease. I do not care of being wrong. My goal is mainly to raise new questions, to change our approach, starting from a different hypothesis. We will propose different clinical approaches and basic research studies. An hypothesis cannot be summarized saying this is a chronic, inflammatory, complex, multifactorial disease. In my mind, this summary almost implies that we are very unlikely to find any explanation. We have had no improvement in treatments since 1986. We have been looking for prevention measures since 1986, and different hypotheses may bring in the future new ideas for treatment and new ideas for prevention. I thank you very much for your attention.
would you like to introduce yourself to the audience? And like, how did you get involved with Worldwide EndoMarch and something like that?
So my name is Dr. Bosev. I'm from Sofia, Bulgaria. I'm a specialist in minimally invasive gynecology. I'm OBGYN specialist. I do a lot of endo patients, a lot of infertility patients, all kind of procedures, open surgery as well, vaginal surgery, but especially minimally invasive surgery.
So what do you think about the awareness of the, like, on behalf of Bulgaria and the world?
Raising the awareness for endometriosis is a very noble and very important cause, because, you know, it's one of the most common, actually, chronic diseases.
Mm-hmm.
Every 10th woman is affected with endometriosis. And it is very important to raise the awareness, because, in my opinion, the patients with endometriosis, they deserve to live without pain. They deserve to have children. They deserve to live a normal life without suffering from endometriosis. And they have the right to be mothers. That's why I think it's very, very important to raise the awareness. Because as Cameron, as Professor Nijat says, sometimes it can take more than 10 years to put the right diagnosis, to diagnose endometriosis.
And
that's what we are doing in Bulgaria. We are raising the awareness for endometriosis.
And like in that point, what do you think about missing the diagnosis and collaborating with the other healthcare providers? Is it easy to find as an endometriosis specialist? Is it to find endometriosis surgeon in the Bulgaria, or like have you had any patients who had to like change the country for this before meeting you?
Well, I have a lot of patients with endometriosis.
Of course.
I treat a lot of patients with endometriosis. It is very, very important to provide the best way for diagnosis of endometriosis. And of course, afterwards, the best treatment for endometriosis. It is very important. As you know, endometriosis is a benign disease, benign but invasive.
Yeah.
Actually, if you don't treat the endometriosis, it can lead to severe damage of all over the body, because, as you know, there is no organ that is spared of endometriosis.
Yeah.
It can be anywhere. That's why it depends on the organ location, but it is very important to diagnose the endometriosis, because it can lead to severe damage of the organ, the bladder, the ureter, the bowel, everywhere.
Yeah. And what changes do you think are still necessary on behalf of Bulgaria and the world? Like, if you want to add something.
I think, yeah, you know, every country is different. In Bulgaria, what we do, how we raise the awareness. I'm working in the biggest university hospital in Sofia, Bulgaria. It's called Myomectomy. Every year we organize open doors for patients suffering from endometriosis. They can be consulted, they can be examined for free. The term is pro bono. Pro bono means without, it's Latin. It means without paying, okay? So they have the right to come and to discuss and to be treated from the best doctors in the field of endometriosis. And we're trying to organize every month, during March, we organize these open doors, not only for my Chindom hospital, which is the biggest one, but all the hospitals in Sofia and some hospitals in the country, in the countryside. We are trying to promote the healthcare in the healthcare system, talking about endometriosis. I had a speech in the Bulgarian parliament for endometriosis and for EndoMarch, and I'm trying to present to every congress in Bulgaria. I'm presenting the idea of EndoMarch, and I'm presenting the EndoMarch initiative. And about what about other countries? You know, I think that it is very important to join our efforts, especially with our neighbors like Turkey, for example. And you know, you asked me how we actually started EndoMarch. And the EndoMarch initiative was presented to me and my wife in Vienna by Professor Nejad. We met there. He was there for the EndoMarch initiative. It was almost 5 years ago. So we decided to help. We decided to talk on that matter because it is something that is very, very important.
Yeah. If you want to add something, you can talk about whatever you want. If you want to like give some messages to all the like audience,
the message is here, you know. Okay. So, you know, I want to say that all the women in the world, they deserve to live a better life.
Yeah.
Life without pain, without suffering, life with children. Nowadays, endometriosis is something that is very, very severe, because if we diagnose endometriosis on the spot, it will be perfect. But sometimes, as Cameron says, it takes more than 10 years to put the exact diagnosis. And that's why it is very important always to think about endometriosis. And by doing that, we have to remind all the specialists, all the OBGYN specialists that actually endometriosis exists and it can mimic all other illnesses, all other diseases. But we always have to think about endometriosis because it is possible. It's every 10th patient.
Yeah.
It's with endometriosis. That's why we always have to think about endometriosis. And we have to educate all the specialists, because we like to say a doctor actually sees what he knows.
Yes.
If we think about endometriosis, if we know the symptoms, we can treat better. Okay?
And I was about to say exactly the same things, like not just only the OBGYN specialists, but all the specialists, because it's really important. Like there are some countries that people just can't even get a chance to go to the MRI or something, ultrasound or something. So we have to think all the options that as a diagnose. So it's really important, educating all the specialists about that. Like just saying that, don't forget, this may be endometriosis.
Of course, I absolutely agree with you. And in Bulgaria, our system is like this. I'm OBGYN specialist, and I do the ultrasound. I do everything by myself. I'm not having an ultrasound technician to perform the exam. So that's why I maybe in Turkey is the same, correct?
Like, yeah, I can say that.
But I absolutely agree with you.
So I don't want to take your time so much. So
thank you very much.
Thank you so much. It was so nice to meet you.
The same applies to me. Thank you very much. Bye-bye.
endoscopic laser excision and vaporization of peritoneal endometriosis, Center for Minimally Invasive and Robotic Surgery. Video-assisted laparoscopy is being used with increasing frequency in the treatment of endometriosis. However, endometriosis of sensitive areas such as bowel, bladder, ureter, and major vessels are often excluded from surgical intervention due to the risk of injury. This is detrimental to the patient, as endometriosis should be treated thoroughly wherever encountered if possible. The use of CO2 laser along with hydrodissection allows for safe surgical treatment of endometriosis over sensitive areas. CO2 laser has several advantages, including precise application, minimal tissue damage, minimal risk of thermal damage to the adjacent structures, and excellent hemostatic properties. Hydrodissection allows for separation of peritoneum from underlying structures and protecting underlying structures from penetration and consequent damage by CO2 laser beam. This is a video presentation of a safe laser excision and vaporization of peritoneal endometriosis. Endometriotic implants of the bladder serosa are identified, and an incision is made in the avascular space of the bladder serosa. The tip of the suction irrigator is then used to hydrodissect this area, which provides a waterbed between the serosa and bladder to protect the bladder from CO2 laser beam since it cannot penetrate water. For the excision of the bladder serosa, a circular line with 1 to 2 cm margin is made around the lesion. The peritoneum is then grasped and peeled away with the help of CO2 laser beam and the tip of suction irrigator probe. The advantage of excision compared to vaporization is that the tissue can be sent to pathology for evaluation. Here, the endometriotic lesion over the serosa of right ureter is grasped and retracted medially and away from the ureter. CO2 laser is then used to carefully excise the lesion. The tip of the suction irrigator is used as backstop to the laser beam. The right ureter is visualized here. Vaporization is referred to cellular rupture from radiation as a result of conversion of cellular water to vapor. This causes the cell wall to explode. Vaporization is then continued until normal underlying tissue is visualized. Endometriosis of the left ureter is visualized here. The peritoneum is grasped and the lesion is excised with CO2 laser. Here we can see the left ureter after excision. Several endometriotic lesions over sacral promontory and bifurcation of aorta are seen here. This area is the intrailiac triangle, also known as triangle of Koch, bordered by sacral promontory inferiorly and right and left common iliac artery bilaterally. Here, the peritoneum over the bifurcation of aorta is grasped and elevated. The precision of CO2 laser allows for safe excision of endometriotic lesions over these major blood vessels. Also, the heat from CO2 laser seals off small capillaries less than 0.5 mm in diameter, allowing for bloodless excision. Left common iliac vein is seen here. The endometriotic lesion over sacral promontory is excised. The remaining lesions are vaporized using CO2 laser and hydrodissection. Endometriotic lesion over the surface of right external iliac artery is seen here. Using hydrodissection and CO2 laser, this lesion is safely excised. The remainder of endometriotic lesions are then vaporized using combination of hydrodissection and CO2 laser until underlying normal tissue is visualized. Several endometriotic lesions over rectosigmoid colon are visualized here. Hydrodissection using dilute solution of vasopressin is used here to minimize bleeding. The endometriotic lesions over the rectosigmoid colon are then excised. Of note, the energy of CO2 laser is focused precisely, and also, due to minimal thermal damage, tissue beyond 100 micron is unaffected. Side-by-side comparison of vaporization versus excision look exactly the same. As you can see, the area that were excised and areas that were vaporized are exactly the same and provide the same result for the patient.
All right, good afternoon, and thank you so much for joining me. My name is Gerard Paulian, and I am a Worldwide EndoMarch Headquarters volunteer, and it is an absolute honor to meet the one and only Beth Kovacs, the state representative for Team Philadelphia EndoMarch, and a tireless endometriosis advocate. And once again, thank you so much for your time. We are all excited to say that we are celebrating Worldwide EndoMarch's 10-year anniversary, continuously fighting for endometriosis advocacy. And me and many others would love to know how you began your involvement with Worldwide EndoMarch.
Oh, thank you so much. Thank you so much for having me. I really appreciate it. And yeah, I would love to tell you about the journey. I kept seeing, I had joined on social media a lot of Facebook groups because I really wasn't getting any information from my doctors. And just following a few people who were very instrumental in the endometriosis community, they kept posting signs saying that the Philadelphia area, Pennsylvania state representative needed to be filled for the EndoMarch. And I held back, and I was new. I really didn't know much. I was still learning. And I just kept seeing it and no one was filling the position. And I'm like, there's just so much to say. And there's just, why is not one person stepping up and doing this? And that's when I decided, okay, because what had happened to me was very rare. And I really wanted to share that story with other people. So I joined them.
Do you mind telling us about your experiences with endometriosis? What made you aware of this condition?
Sure. So I had started developing lower back pain the year after my daughter was born, probably in 2007. And I started going to doctor's appointments saying, for whatever reason it was, I was sick or whatnot. And I would always mention the back pain. And they would like just ask me, well, does it hurt all month long? And I'm like, well, no, usually it's like 3 weeks out of the month. So since it's 3 weeks out of the month, they always ignored it because it went away. If it was debilitating and was all month long, then they would have taken it more seriously. So in 2015, I woke up with a pain in my side, and I went to the doctor and they said I had a urinary tract infection and gave me antibiotics and sent me on my way. Now, I had never had a urinary tract infection before, so I had no idea. I was like, wow, this is really painful. Like that's crazy that people go through this. And about 4 or 5 days later, I was not getting any better. In fact, it was getting worse. And the person who diagnosed me actually wasn't my normal doctor. It had happened on a weekend. So I had to go in and see another doctor. I had asked to see my normal doctor. I told him, I said, listen, I'm telling you, something is wrong. And that happened on a Thursday. And he said, all right, you know, to appease you, because I was young, healthy, nothing was wrong with me, we'll get you a CT scan. I said, okay. The next morning, I went and got a CT scan at 8 a.m. in the morning, and by 10 a.m., I was getting a phone call. They had said that I had a large mass over my bladder. And I was then, you know, test after test, like, let's see what's going on. We have to get you in. It was just very rushed. Everything was happening all so quickly. I was sent to a urologist who, in that first meeting with him, he said, worst case scenario, you're going to have your ureter cut and reimplanted into a different part of your bladder. Well, I had a friend with me and she was like, no, 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 that is the worst case scenario. Why would you even say that to her? And immediately I began to panic. It turns out that that is what happened to me. It was worst case scenario. And I did need to have a reimplantation surgery. My left ureter had stopped working completely. I had lost 28% left kidney function because of endometriosis.
Oh my God, and it's so sad to hear that the doctor originally got you a CT scan, because it seems like in the sense that it seems like they just wanted to just say like, fine, here's the CT scan, so you don't have to worry anymore. There's nothing wrong with you. And then
Yeah.
something was actually wrong. So even though that mentality by the doctor, it's hard to hear that they kind of gave you that mentality, but in the end, I'm very glad to hear that it worked out for the better.
Yeah, I mean, it's had a lot of challenges along the way. So during that process, we actually, prior to that, decided to have another baby. I mean, I'm so blessed to actually have a baby. And a year after she was born, all of my symptoms had started. And that's why I never had a baby after that. I never understood parents or, you know, who were continuously having children. I'm like, I can barely take care of myself. I'm in pain 3 weeks out of the month. I'm taking care of myself. I'm taking care of my daughter. Trying to take care of my family, my life, my responsibilities. How are people having more children? And then, although I still was not ready to have children, my daughter was at an age that I'm like, maybe she'll be helpful. She's in school now. I can take care of a baby. I'll be able to do it. And we were, you know, told we'll have a baby. And at that time, we had appointments already scheduled for the OBGYN to talk about having a baby. But instead, I was at the OBGYN talking about cervical cancer. So they thought I had cervical cancer. They thought, you know, I had kidney stones. Like I said, there was so many tests and everything just seemed to align. I did get pregnant, but unfortunately, I lost the baby. And then it was too late. The damage from endometriosis, because of the extensive surgeries and everything, it was just too late, and it wasn't going to happen for me again.
I'm so sorry about all of that. You know, it's in all of your right to be able to have children and experience that in life. And the fact that all of this was stripped away from you, it's hard to hear about that. So I'm sorry that you had to go. I'm sorry that you lost so much against your battle with endometriosis. And thank you so much for your just unwavering support to promote endometriosis awareness across all of the United States.
Yeah.
And so now I was wondering if you could give everybody a rundown as to how Team Pennsylvania's efforts have furthered endometriosis awareness in your own area.
Well, I'll say this past year, 2023, I was blown away. And forgive me,
No, it's okay. Take your time. There's no problem.
I had felt like this year was such a amazing year in endo research. You know, like, we were making a difference, and so many people had gone to Washington, and so many important movies had come out, and it was just like I had seen leaps and bounds here in the United States of endometriosis, and more people talking about it. And I went to Washington right on the entail of other people going to Washington, so it was just it was been a really, really exciting year. And I take from that, going to Washington, not just for myself and all of the other amazing people out there who experience what I'm experiencing, but my favorite part was I brought my daughter. And I wanted her to understand that she has a voice and, stand up for yourself no matter what's happening in your life. And she was able to sit in on our meetings and watch her mom. And then when she came home, she had posted a video of our experience. And a friend of hers who was a senior in high school was actually in the process of doing um, a an interview on women with a reproductive disease. So she had to do this whole documentation on it. She had never heard about endo. So she wound up doing it. And then that was able to go to her class. And it was just, that to me makes me so happy that, one story from one person can affect so many more people.
Definitely. And that's the goal, to have one person learn about it and then have them talk about it with other people, because people in general are so unaware of endometriosis in general. And we need to bring endometriosis to the forefront of people's minds. So could you tell me more about this Washington event and what specifically happened, the impacts that you felt it brought?
Yeah. So it was one of the congressional aides that I had met with. Her friend had actually experienced endometriosis, and she had just recently been diagnosed. So she was in all of our conversation. And then it opened up doors to, well, what about our veterans? Because obviously people in Congress are interested in, all of our veterans and the women and what's going on with them and how do they combat it. And honestly, I wasn't really sure. I know I have a friend who is in the Army Reserves. She has experienced and had to step back from certain detail because of it. So it affects us all across the board. So just knowing that, bringing that up about the veterans would then be thought about in the future, and how are we going to make it better for them? So I really enjoyed that. I really enjoyed just being in Washington in general. It just felt so empowering to be there. We did a news broadcast, met with a couple aides, and I've actually met locally with my representative back in 2020 when I had started with the EndoMarch.
No, that's great. You guys were even able to make it on the news, because platforms like that provide can give us at Worldwide EndoMarch and you guys such a big voice and reach out to a lot more people. So congratulations on such an amazing event. And I know your daughter was very proud to see you make such a big impact.
Yeah, that was really, really exciting to bring her.
I'm curious, in your situation, how long would you say that you personally suffered with endometriosis? Because as you're aware, there's a 7 to 10 year delay with endometriosis, and I was wondering if, from your situation to the situation of people right now, is that delay still going? Is that delay still as large in your area?
Yeah, I truly believe that. And it boggles my mind. So my symptoms started in 2007. I was diagnosed in 2016.
Oh, wow.
And that was after they had opened me up for the reimplantation surgery. Because prior to that reimplantation surgery, even though I was doing all the research and I was diagnosed with the UTI, I'm like, this doesn't sound right. And when I started researching, I'm like, this sounds like endometriosis. Like, I'm having these pains, and there's other women who are having these exact same pains as me. And my doctors, all of them, assured me that it was not endometriosis. They're like, no, like, it's not. And today and every day going forward, I feel that every single medical doctor needs to look at a woman and say 1 in 10 is diagnosed with endometriosis. Why is that not more thought about when they are diagnosing women with chronic illness that cannot be seen? Why? That should be one of the main things. Like, endometriosis, if it is a chronic fatigue, a chronic illness that cannot be seen. I was diagnosed with fibromyalgia. I had no test for fibromyalgia. There is no test for that. It was just like, no, I think you have that. But endometriosis actually damaged my organs, my internal organs. And another doctor actually rubbed her stomach and said to me, endometriosis only affects you here. But it crushed my internal organs, and I had tangible proof of that. So the medical community just really has to put that in their head. 1 in 10 women, like, let's start figuring out a way. Let's acknowledge that it's 1 in 10 women, and then let's figure out how to make it better to do that testing to figure it out non-invasively that they have it.
No, of course, endometriosis for all medical experts should be a checkbox. It's something everybody should have on their papers and consider and be educated about. And with our current situation, it's clear that many doctors are not educated on the symptoms and not educated on how bad it can become with thoracic endometriosis syndrome and silent kidney loss. There's a lot of impacts just beyond the uterus and the pelvis.
And I think it's important too to have access to specialists who do know how to work with women with endometriosis in severe cases. Like, I just recently found out. How could I just recently find out that in order for me to be helped, I need to see a gynecologic oncologist? You know, and then I had a woman reach out to me a couple days ago, and she was like, I just don't know where to turn. I don't know what to do. And she told me her case. And I said, I think you're going to need a gynecologic oncologist. And she said, forgive me if this is a silly question, but isn't that for cancer? And I was like, I said, yeah, you would think, but it's not just for cancer. It's for gynecological issues that are very severe, like endometriosis and what you've been through and what I've been through. Why our doctors are not giving out that information and having us suffer more years than what's needed, I'll never understand.
It's truly unfortunate that people such as yourself and the people who contact you have to go through so many hoops to find somebody to take care of them. So would you say throughout these 10 years that EndoMarch has been around, that it's become easier to find an endometriosis specialist, or it's still just as difficult?
I feel like it's still just as difficult because I think there's a lot of doctors out there who, I want to say that they claim to be experts. Endometriosis, you have endometriosis? Oh, we can take care of it. But there is a difference between ablation and excision. And I, when I questioned my oncologist, I'm like, well, are you going to ablate, do an ablation or an excision? And the way that he looked at me, like, he's the doctor, I don't really know what I'm talking about. And he's like, well, I do both. In my mind, that was an immediate turnoff, kind of like, no, you are going to excise it. There's no point on ablation. So I feel that I don't want to take away from the community. Obviously, the medical community, they're here to help us, but I just wish that they had more knowledge, and I wish that they got the experience to do. Instead of having us wait 10 years, why don't they just be able to be knowledgeable in the moment and fix us in the beginning instead of until it's too late, like someone like me and has organ damage, unrepairable organ damage. If they would have known in the beginning, if they would have said, this sounds like endometriosis, I could have been looked at. And at that time, I could have had excision surgery. I may have needed it a couple times, and that's okay. But I would not have had organ damage that had affected me for my whole life and changed the course of my life.
Oh my, it's with something such as endometriosis that has such a very, very strong impact on people all over the world, and how it's not on the forefront of medical professionals' minds. It's heartbreaking, and I know you of all people definitely understand that. And
I am happy. I'm sorry, I didn't mean to cut you off. I do want to say that I have heard about Dr. Nazat starting a school and teaching others about excision and becoming specialists just like him. And I think that that's amazing. And I hope that that just goes above and beyond and gets us to where we need to be.
Oh, definitely. Dr. Najat has taught many, many fellows, and his expertise being spread to other new medical professionals will definitely further advancements in awareness with endometriosis. Are there any last words you would like to add for those maybe going through the condition or that want to learn more?
I would just like to say, so during this journey, I have been able to really reflect on everything, and I have contributed to a book, and then that led me to want to contribute to my own book and write about it. And one of my main taglines will be forever, continue to be strong in your weakest moments.
Mm-hmm.
It is a journey, and every day you're going to get up and you're going to wonder how today is going to go. And I think that that's what's so important, is to not put an expectation on yourself of, I should be better now, or I'm doing these steps, how come I'm not better? Because it can flip on a switch. You know, you can try to do holistic practices, you can get the surgery, you can do all the things that are recommended, but you may not have a good day, and that's going to be okay. You just have to remain knowing that you have to remain strong in your weakest moments, because that's the only way you're going to get through.
Of course, of course. Well, thank you, Beth, for everything that you've done to spread awareness and help the future generation of people who will possibly suffer from endometriosis, and hopefully we can spread awareness to everybody. Thank you so
Thank
much.
you. Thank you so much for having me. It was so great talking to you. Thank you so much. And I look forward to hearing everybody's interviews and seeing what 2024 brings.
Of course. Thank you so much. Have a great day.
You too.
name is Roya Tagabi.
And I'm Rana Kalogli.
We are EndoMarch volunteer health reporters. We are here today with active members of the EndoMarch community, Chelsea Hardesty and Verity Kerr. Once again, it's very nice to meet you both. And thank you for taking the time to talk about your work and involvement with EndoMarch and your own campaigns regarding endometriosis.
So to start off, how did you both become involved with EndoMarch?
So I actually came across EndoMarch right around my diagnosis period when I was struggling to figure out what was going on with me. Once I got my diagnosis, I started messaging, and then I kind of became a representative and just started being more involved, you know, little things here and there. I then started messaging more with Barbara Page, and we started comparing, you know, notes, research papers, topics and discussions, and then she kind of offered me the title like a research assistant to kind of, since we've been discussing so much together and we're very fluid with our discussions, so that was very helpful as well. So that's kind of how I started, and then along the journey with them I stumbled upon Project 514-415, and I've kind of tagged her along with us. So
yeah, so you mentioned a little bit about prior to when we were messaging about getting the better of endometriosis, and that work along with your own individual work with towards I guess advocating for EndoMarch and endometriosis in general. So if you want to talk more about that, that would be great.
yeah, so along that journey as well, I also started getting the better of endometriosis. It began more of kind of like a blog, follow my journey aspect. But when I wanted to do more action and actual like advocacy, people weren't taking me seriously. So I kind of began the nonprofit starting. So last year in 2023, I kind of started finalizing that process. So here we are as a nonprofit today. Then teaming up with Worldwide EndoMarch last year in March, actually, I hosted a DC delegation, and I was joined with Holly with American End of Endo Project, and the founder of Emma Valentina, and then of course my husband, which is a board member for Getting the Better of Endometriosis. And we met with a handful of elected officials and basically not only gave them the rundown of updated awareness topics for endometriosis, but let them know like, hey, we need action. We're not just here to like let you know what this is. We are letting you know like we need action because we're not being helped properly. We are being delayed and held back from preventative care, and kind of basically laid it out because now we're having more of the awareness and everything up there, and now we just, what are we doing with this awareness? It's not going anywhere, and that action needs to go somewhere, and that is in the hands of the government at this point to be able to fulfill those actions. So we were requesting actions, and I let them know also of the petition that I developed to kind of call for a type of investigation with the Department of Justice, because there's definitely some things that can be held accountable by law if we run it that way as well. So I presented those petitions as well with all of those elected officials and basically let them know like this is like the last straw. Like if nothing else happens, then we're going into this investigation. So that's basically what we did in March of 2023. And since then, I've just kept up my communications, and then I discovered Project 514-415, and we're really pursuing that awareness at an international level. So in a very fun, unique way as well.
Yeah, I think it's wonderful and so important that you're trying to really make an effort so other women can get a diagnostic on time, and like exactly the government steps up and really like, what's the word? Just more people really need to know about endometriosis and to accept it because it truly is a thing, and more women need help.
Yeah, and the fact that we look at it as just like, oh, it's just this period and it's a bad period and it's normal. Like none of these things that have been labeled normal are normal, and we are prepared to break that down and show them just how misogynistic, if you will, the ideal behind endometriosis has become, which is causing that direct harm every day. And hopefully, like, doing this can like pave the way for other countries to request their government to take actions as well, you know. So that's kind of the goal with the worldwide aspect, international aspect, and teaming up with EndoMarch and Project 414 415 is to tackle that international aspect, to show it's not just in America, it's not just in the UK, it's
everywhere.
Everywhere.
Global.
Mhm.
So in terms of like action from the government and specifically endometriosis policy and our education, I know there are some countries who are pushing for the government to take action to make it a permanent part of education, you know, for young kids. What specific action or policy were you hoping that would be achieved?
So honestly, we are hoping to get all the way back into med schools and change what is being taught in med schools, because that's the root of the problem. We want to point all the eyes, not just on the doctors that are doing the work right now, but where are they getting this knowledge and that work, and that's right down in the med school. So if we can focus the government's attention onto the med schools that they are funneling money into as well, you know, then maybe we can begin that change and light a fire there to begin changing how we think about the disease, what we know about the disease that's not 100 years old, that is now, you know, based off of updated and proper research. So that's step one. There's so many other breakdowns below that, but I think that's the biggest thing. And also the recognition as a disability with the ADA. So that's I think huge as well.
Yeah, I didn't even think about that as it being a disability, but you're absolutely right. It should be. And yeah, I think targeting med schools is also such a good idea, because how are we supposed to get more endometriosis specialists if, you know, it's not
Who aren't aware about it and aren't taught.
Exactly.
typically.
They're being taught the same thing, being funneled out, not knowing, hey, you might need to take some extra education on that if that's really what you're interested in. It's not this 35 minutes that we learned on it in med school.
Yeah, and if they're not taught about it, if it's not significantly acknowledged, of course, patients are going to go to them and they're going to be like, no, it's just a painful period. There's nothing else to it.
Yeah, it took me over 15 years to figure out. I just turned 30 this year, so over half my life just to figure out what the heck was going on with me. And it's amazing to actually know now. So, and that's what I want. I don't want people to go most of their life not knowing and feeling basically insane. So it needs to change.
Yes, exactly. And I know you had mentioned a little bit about Project 514415. So I was hoping we could get a little bit of Verity's input on this project and learn more about it.
Yeah, so Project 514415 started up when I was basically diagnosed with endometriosis. So it took me nearly 20 years to get diagnosed. So my story, pretty much like before my period started, was that I had awful like stomach cramps and kind of like a flare up of like my bowel type thing. They kept saying it was appendicitis. And then I kept going in, they kept saying it wasn't appendicitis, kept coming out. And it's like, oh, you're just an anxious child and all of this. And then my period started and I'll be passing out, throwing up, wouldn't be able to move. And then that was from like the age of like 12, I think I started my period. And then all the time I kept going to A&E or going to the GP, it was always the same story. There's nothing wrong with you. You're just anxious. You don't know what period is. Just taking like painkillers. And then one GP actually scolded me and actually specifically said to me that I deal with sick people and you're wasting my time. And then I had a cyst, and then I was told it's just a tiny cyst. Like, don't worry about it. You can have it removed or don't have it removed. It's like clinically insignificant. Went to a private clinic in the end because I didn't trust this guy. I needed to remove the cyst for me, and I just wanted a second opinion. And then he then said that I had grade 4 endometriosis and that I would probably need a stoma, and that is going to be it could be life-changing basically. And I never even heard of endometriosis, didn't know what it was, and I literally just thought I was going in there for a cyst. And then so I was in London in the middle of lockdown, and then just literally just crying my eyes out because I was told I'd have to IVF, and so literally my whole future was taken away from me in front of my eyes. And I never wanted anyone to feel like that. And then when I got home, I started researching things. I realised that the information was there. So all the signs and symptoms I had were textbook, and they were all there, and it didn't have to get as bad as it got. And I just feel there's some way that this information has to get out there to people who aren't in the community. And then so it's very well that the information is being there when you're in a community or when you have a special interest in the condition. But the issue is that it's not being funneled through. And then so it needs to go to like basically the boys, and it needs to go to the girls who are in primary school or who are in secondary school, and it needs to go directly to society, because they are the policymakers. They're going to be the future doctors, they're going to be the future politicians, they're going to be your future bosses, they're your sons, they're going to be your husbands, and all this, your friends. And so that's where the information needs to go. And again, so that's why I kind of came up with Project 514415, in the sense that I wanted it that people can share their stories. So actually have it that they share artwork, share literature works, share short stories, and it can be anything about their journey. So it's been a massive variety of work that we've had about 160 people submitted into the project. And from that, the youngest person we've had is, I think she was 12 or 13 when she submitted, and she's been diagnosed with endometriosis, and she's the 6th generation person who's got endometriosis. And then the eldest is in their 80s, and she still has issues with endometriosis. So even though she's gone through menopause, she was also told, oh, you know, as soon as you go through menopause, you'll be fine, there'll be nothing wrong with you. But she still now has loads of issues with endometriosis, and her symptoms haven't eased up at all, and she struggles to get help. So it's been a massive variety. And then we've had a few friends. I've had a partner submit, and also we've had people up from the trans community submit as well who have endometriosis, and they've actually been denied care, which is awful. So there's one very heartbreaking story that I read from somebody from the trans community, and they were specifically told from their gynecologist that they don't operate on trans people, which is awful. And then they then said, we can give it a go. And then they was then basically discharged immediately after, because they was told they removed the endometriosis, where that on progesterone, there is never going to be a problem now. It's not going to be endometriosis, because they're on hormone blockers so the estrogen shouldn't be growing anymore. And then so they're now bouncing around the NHS and bouncing around to try to find help. But there's been a variety of stories, but then all the time it seems to be underlining that everybody's always getting ignored, everybody's always getting gaslighted, and everybody's always been told that there's nothing wrong with them. And then sometimes it becomes to the dangerous end that we're left for that 20-30 year period. And within all the stories I've had, everybody who's been left that long, who's been over like the 15-20 years, it does seem to be that it's gone into the bowel, it's gone into like the respiratory system. So there's one lady where she's got it in her heart and they can't remove it, so they're too scared to remove it. So she's says that she's concerned every single day that she's going to have a heart attack one day because of the endometriosis. So yeah, so it's a massive concern. And then so I wanted to do something about it, and I wanted to just do something different as well. So it's also these things that I wanted to have it that I think that if you have everyone as a collective and actually show everybody's story and actually show that everybody as a somebody and show everybody as a personality, it can sometimes draw you in or make you relate to somebody than it being that there's like this many people, if that makes sense, like in a research paper. And then one thing we have found though is that everybody who's submitted this project, it doesn't correlate with the research. So obviously the research is like 1 in 10, you're meant to be diagnosed for 8 years. The only people who are diagnosed 8 years are normally the people who get diagnosed quite young, and they're the people they normally have it that it's on their like on the ovaries or it's on the womb, and then so you can clearly see it. Mm-hmm. And then everybody else who it's been a lot longer, it tends to be that it's maybe starts on their bowel, they have like bowel issues or bowel symptoms beforehand, or it's more respiratory to begin with. And then they seem to be the people that it takes a lot longer for it to be diagnosed because it's not this reproductive thing, if that makes sense. So yeah, so then what we've had to do, because we wanted to have like kind of facts and figures of endometriosis, but everything we found, as I say, it's not correlating to the 160 people that we've had to submit and their stories. So we've done our own questionnaire, and then just ask them basically like, how long did it take you to get diagnosed, like what were your symptoms, where is your endometriosis, and then just so that we can say like, in this book, this is our summary of this, but it doesn't correlate with the research, which is, this is the current research. So yeah, and also coming from a medical background, because again, I come on this fence that I am very artistic, but at the same time I am a trained physiotherapist. I've worked in the NHS, and I've worked within pain management, or like pain patients within MSK, and so again with that, it was very interesting going through that journey, because when I was going through working with chronic pain patients, I had the same thing. I was diagnosed with endometriosis, and then there's a very miscommunication, or it's just fact, I think it's more the fact that we don't get taught about women's health. We don't, again, like all healthcare is healthcare for men. So when we're at university, all we get taught is like all the research is based on men only, which I know it's all coming through with heart attacks and strokes and things like that, that women are worse off, even with medication, that women are worse off with medication, because it's all been the research has all been conducted on men only. And then so that was very prominent again through when I was working with patients, in the sense that I'd have some females come in and I'd be very much like, you have endometriosis, I think you have endometriosis, these are signs and symptoms. And then some of these patients, they would have been through pain clinic, they would have been like bounced around A&E, bounced around like having injections and things like that for back pain or hip pain and things like this. And then they then come back around again, so it's kind of going around this loop constantly. And then when they come to me, I go, oh, like, you know, like, how are your periods? Does this pain get worse on your period, on your cycle? And then even bringing up like the Endo UK website or the NHS website, go, are any of these your symptoms? And then I had at least 6 patients who were like, yeah, they're my symptoms. And then they then go to their GP, like try to get in to see a specialist, and then a lot of them have actually been diagnosed with endometriosis when they came back to me, which is sad, because it's the fact that these things should be picked up at first contact, or if more healthcare providers like OTs, physiotherapists, even psychologists, where I know I've seen a few people who've stated that they've been wrongly accused of having mental health problems through when it wasn't endometriosis, and they've ended up seeing psychologists or being put on antipsychotic drugs, or kind of being put on mental health drugs. But if all healthcare providers were trained within women's health and actually understood signs and symptoms of what is healthy and what isn't healthy, then a lot of us wouldn't have gone through the journey, would have gone through, and would have been able to have help a lot quicker or a lot sooner. So yeah, it's been an interesting ride, and it's been heartbreaking as well, actually, reading every story. So it's a thing that you know that what the story is going to come, and it's, I think the heartbreaking thing is that every story is the same, and everybody's gone through a horrendous story. And then some of them who are quite young, who got diagnosed quite young. So there's one person who me and Chelsea knows that she got diagnosed when she was like 13 or 14, and then they decided that it would be a good idea to stop her period. So they've stopped her periods with like that menopausal drug, and then she now might not be able to have children, so she's now in her early 20s. And I was like, oh, this must be amazing being diagnosed quite young, because you know, you can plan now, like if you want children, you can like freeze your eggs now, you can get like embryos, frozen embryos, you know, so that's a good backup plan, so you never have to worry, you can have like a good like 30, 40 embryos like banked. And she's like, no, like they put me on these drugs at 13, 14, and I'm now, they don't know if my ovaries work, they're not functioning as they should, they didn't grow, which it's heartbreaking. It just means that so much more research has to be done. But I think we need research going back to the basics of actually understanding what it is and what we know about it. So even today, so I'm meant to go through respiratory surgery soon, because I'm having a lot of issues with my breathing, and they think that I've got endometriosis on my diaphragm and my lungs. And then so I'm having surgery for that soon. And I ended up speaking to my surgeon's like right hand man, like he's T1 doctor who's training with him. And then it's kind of obvious that he just read a journal just before he got on the phone to me, because he didn't realise that I don't think he didn't know anything about endometriosis that came across that way. And he then said to me that, or his belief to me was that endometriosis, because there's a hole in my womb, and then the cells are falling out my womb, and they've grown around my body, and they've gone into a hole in my diaphragm. And I was in disbelief. I think I got phoned to Chelsea, and I was like, this guy is ridiculous. And he's such a lovely guy as well. Like, he's very nice, professional, but he had no idea. It's obviously that he read this journal, and then he's just quoting off these facts to me, like, oh, 20% of patients, it never comes up in the MRI. Like, when you have these symptoms, though, it's really severe. So we want to get in there because, like, you're struggling with your breathing, you're really struggling with, you know, like with fatigue, and like I'm having like those nosebleeds. So he's like, he listened to all my symptoms, he did everything right. But then he's read this journal, he's had this information, then he's incorrect. So now his belief is that we've got endometriosis or endometrioma cells, like the womb lining cells, just floating around our body because they've fallen out of a hole. And it's then obviously he's saying this to other endometriosis patients, and this is his belief. And yeah, so it's quite stressful, the phone call, but at the same time, I guess I had that extra layer of education, but it's a layer that he should have had. But it's at the same time, it's not their fault, in the sense that they never taught these things in university. And again, every medical profession we see, all they've got taught is how to deal with a man, or how to deal with men's health or male's health. And so there's a massive change that needs to happen, with not just in endometriosis, but within the whole women's health. And then, but it's the fact that if we can keep pushing for change from each angle and all come together and collaborate, then hopefully be able to make a change across the board. But it's going to take decades, or if not centuries, to catch up with where men's health is, for women's and men's health to be equal. But I think it's just, if we more had understanding that if healthcare professionals can say, actually, we don't know, or actually we know there's this big gap in our knowledge, and I think they need to look at us more, that when they're treating us, they have to have the understanding that they don't know how to treat a woman, they don't have that knowledge, and science doesn't have that knowledge yet, and they're basing us on a man and not on a female. So I think there's a lot of lessons to be learned, a lot of understandings. I think a lot of egos, because sometimes it's more of an ego thing, isn't it, that they go, I've done all this university training, I've done all this knowledge, and I've just like dedicated my whole life to this set pathway, and I think it's very hard for them to then realize, say, well, you have, but it's biased knowledge, or you're running on without realizing it's sexist knowledge, because you're still running on like the whole thing of like hysteria, or the whole thing of like like the whole like, old age of how women were perceived centuries ago. It's still very much in society today.
Yeah, I completely agree. Reform does need to occur within women's health and within the medical industry. And I believe using art as an outlook for people to express their pain and similarities they've kind of gone through, or also differences, is a great way for people in the endometriosis community to speak out. And you said it's something unique. It's a different way to share your message. And if you would like me to share the art now, that has been submitted to project 415-514-415.
Yeah, so what we've given you is a selection. So it's not all our art pieces. We've got a selective, I think it's 14 or 15 pieces we've selected out, and we all voted within the team. We voted for pieces that we thought would be suitable for all audiences. There's pieces that we would assume would be suitable for like 3-4-year-olds up to like 19. They shouldn't offend anybody. And then alongside them all, they've got a fact of endometriosis. So again, so it's just try to debunk all the misconceptions of endometriosis, just try to get out real life information. So it's just even the fact that even if a teacher or a professor or a doctor even sees it, then hopefully that one fact might just stay in their heads. Then if they do see an endometriosis patient, or if they have a student who's got endometriosis, hopefully that one fact might stay in their head, and then they'll be a bit more aware of it, and then hopefully they'd even then look at the whole range of our posters. So with these posters, we've created them for them to be shared across the world, and it's just that anyone can download them from Buy Me a Coffee. So we can send you the link to share, and then they can just download the posters, and it's just for basically you to share them like around the community, around your college, work, wherever, basically, and just be free with them. And it's just to try to get like the message out there as much as possible to share the lived experiences. So it's also kind of like a little snapshot as well, what will be in the coffee table book. And then hopefully as time goes on, we raise more money and raise more funding that we can then have like an exhibition up and running. So I know Chelsea's working for one in DC, and then we want to run one in Scotland and in London. So yes, it's obviously all about funding as well, but it's just going to be a little snapshot of what you'll see there. And then obviously quite a lot of the work, some of it's quite graphic or some of it's quite dark, so we've had to keep that away. So we'd have to have that in set trigger point warnings in the book as well. We're going to have like each page is going to have like a profile for the person, and then on that profile it say whether it's a trigger warning piece or not. So people see if there's something with miscarriage, or if there's self-harm, like some things like this comes up, or being wrongly diagnosed with like mental health, or being like institutionalized with mental health when they didn't have these problems. That can be quite triggering if someone's going through that, just gone through it themselves. So it's the fact that we're making sure that everybody's trying to be as protected as possible. So on the profile, we can send you a link to the profile actually, so you can look at the profile, but it just shows the country they come from, and then it just has like their picture, and then we want to link everybody to their own story and their journey as well. So artists who have submitted, or writers and things like that, you can just go directly to the Instagram page of their website, so you can look more into them as well. So we try to have it that it's a collaborative affair. That's basically that it's the endometriosis story, I guess, from the community, and we're just the gatekeepers of this book, or we're the gatekeepers of this project that is open to the full community. So we try to have it that it's involving everybody in the community, so around the world.
I will screen share now. Those are definitely beautiful pieces of work, and it's a great cause. And I think, again, it's an amazing outlet for people to show their experiences and what they've gone through art.
I like how specifically in this campaign, there's a lot of campaigns, that try to raise awareness and share information about endometriosis, but I like that this artwork sort of elicits emotion, almost like you feel like you're in pain too, watching or looking at the photos. So I think that's really important as well.
Yeah, one of the main things I wanted that it caused a few heated discussions in our group is that I was like, I very much want it to be just the artwork, and then I was like, no, it has to be endometriosis as well. And so I know there's like lots of like kind of to and fro and things like that, and I think we managed to settle on a impact post last time. The first post I did was very much just all art, and everybody was like, no, it needs to be a bit less art. And so it's the fact that I really wanted to make sure that no one's work is changed, so that's their voice. I see that their artwork is their voice, but also the submission guidelines we have for project 514415, which is still open. So why we still got fundraising, and why we've still got pages left in our book. We want to get as many stories and journeys in as possible, but it's open to interpretation. So it means that you can do anything to do with your journey. So whether that's good, whether that's bad, whether it's something awful that's happened, whether it's a reflection, whether it's something you're going through now, it's it's open. So we did have a few emails of people being like, tell me what you want, or like, how do we start? It's like, you've got 5 pieces, maybe just pick a section, like just do anything you want. And it's been, every piece is so different. Because again, I think sometimes when you go to exhibitions and they ask for submissions of things, you can go around and you can pretty much see the same thing over and over and over again, or you can see very similar, you can see definitely what the brief was, but the brief is just endometriosis, like just what is it to you? And so that's the most important thing, and that's how it's just, I think it's just so magical. Like, I can't wait to share the whole collection with the world, basically, because every piece is just so different and every piece is so unique to the person. And it's also, it shows their culture, because again, we've got I think about 9 different countries at the moment, and then you can see like different cultures or their different cultural ties in with it, and like different ethnicities flying in throughout the work. So we've got one work and they've got Arabic writing in it, and then yeah, so it's beautiful. There's not on the Arabic writer's not on these posters. We've got it's I need to get better pictures of it, so I haven't been able to add it into this one. But it's a lady who she's reflecting on mindfulness. So her journey is very positive. And then so she said that how she overcame endometriosis was through her religion and through her culture and mindfulness, and all her artwork has been kind of like mindfulness collages and pictures and paintings and things like that, with like all hope and stuff, which is it's beautiful, and that's stunning. So I think it's just it's beautiful how Lorraine, how it's literally just exploded like fireworks, and they've all gone in different directions. So I can't wait to share it with everybody, and for Chelsea to get out to America. And yeah, we've got a lady in Australia who's going to be sharing in Australia, and then also in Norway, we're working on Norway as well. So it's exciting to hopefully can go worldwide.
So once this,
sorry,
I just had one question. Once this collection is complete and ready, how can people access it?
So we're going to have it's returned to a coffee table book. So we're still just need to raise a few more funds for that at the moment, because it's the copyright service costing quite a lot of money. So we want to do it properly and professionally. So yeah, so we just want to make sure that whoever buys it, it's done to a really high standard and everything's in the right place. So yeah, so it will be available on Amazon. So the copyright service, I'm going through who they'll spell check it, do all the like the graphics, and make sure everything's in the right place, and make sure that all the pictures will print out at really high quality, and they'll be able to change things that needs to be changed and things like that. They will put it on Amazon, and this the book will be available worldwide on Amazon. They also said that we can bulk buy the books. So then, say for example, if like an organization wants to sell the books, then they can like bulk buy them and then sell them and like raise profits for their own endometriosis charity. So that's another thing, is that we want it to be again like a gift to people, that also that it can be the gift that keeps on giving, that is sharing the lived experience of endometriosis, and then hopefully can be an educational tool towards university students, or like even just the up and coming generation, but also the fact that it can then also be used as a product to raise money and funds for endometriosis charities, or for like women's health charities and things like that.
We can't wait to hear what you both accomplish in the future and your efforts in raising awareness around such an important issue. Before we end, are there any last words that you both would like to share?
No, just thank you for having us.
Yes. Well, thank you for meeting with us. Thank you for your time, and we hope you have a great rest of your day.
Thank you.
Thank you, guys.
Thank you both.
Thank you.
Bye.
Bye.
Hello, everybody. I am Dr. Kamran Nejad. I would like to welcome all of you to this second webinar that we have. I am the founder of Worldwide EndoMarch on Endometriosis Day. And it is a pleasure and honor to have every one of you join us. The issue of coronavirus has changed the practice of almost every part of our lives, including the practice of medicine and surgery, and has forced us to find new ways to handle and take care of our patients. And this is one of those ways. We have a great faculty today to address some of your concerns of the issues related to endometriosis and coronavirus at the same time. And today specifically, we deal with pain and answering your questions. We have received many questions, and we will try to combine some of these questions at the same time. If you have more questions, please send them and email it to us. Tiffany is going to send it to us, and we will address them. For our faculty, we have an excellent group of surgeons and physicians that are going to address your concerns, including Dr. Paul Wetter, the founder of the Society of Laparoscopic and Robotic Surgeons, and Dr. Ray Lanzafam, who is the CEO of the Society of Laparoscopic Surgeons and also robotic surgeons. We have Dr. Chong, who is the past president of Society of Laparoscopic and Robotic Surgeons. And we have Dr. Bogdan Gresko, who is a urogynecologist and is going to address some of your concerns in respect to endometriosis and also interstitial cystitis. And we do have my brothers and niece, Dr. Farnejad, Dr. Sina Nejad, and Dr. Azad Nejad, who are the co-founders of the Worldwide EndoMarch and Endometriosis Day. We are all in it, and of course, we do have one important person who is also a patient, and also a person who has suffered significantly over the years because of the pain and has learned how to manage pain. Mrs. Janice Wetter, she would join us and she would address how to deal with pain when you have tried everything else and nothing is working. So I welcome all of them, and we will start with Dr. Paul Wetter and Lanzapam, and then each of them, they would address one area that when can we start seeing patients, and each faculty, because they are located in different areas and they practice in different cities, they will be able to tell you their opinion. When are we able to see regularly patients in our offices again? And when are we going to do surgery again? And what precautions do we have to start? Of the any of the faculty who wants to start, perhaps Paul, do you want to start?
Yes, thank you, Cameron. I want to thank Dr. Najat for arranging this important meeting, and also for the amazing work that he's done over the years for the Worldwide EndoMarch, which has attracted so much attention and done so much good to help people really understand about endometriosis and how it can best be diagnosed and handled. So thank you, Cameron, for that, and also Sena and Far. you know, we're in the middle of an international pandemic now in crisis, and we're getting all sorts of news. And the question really that Cameron raised is, when is it safe for us to start doing things again, and when can we return to normal? And more importantly, when can patients really expect to get their healthcare back to normal? Because the healthcare systems have been taken over by critically ill patients and patients with highly infectious diseases. And it's really put a halt on the use of elective surgery and taking care of other problems, even though those problems are still with us. And I think the answer to that really involves your own location. As we know, the coronavirus is really setting the pace for when we can get back to normal. We think that in most places now we're just past the peak, but a lot of what happens over the next couple of weeks really depends on each country and each state and how they handle us being sequestered at home and maintaining the rules that have been set. And if we all follow that, I would anticipate that within the next few weeks, we should see a dramatic decrease in the number of new infections, but that could vary from location to location. Certainly by the end of May, it's everyone's hope that things will start getting back to normal on a regular basis. But a lot of that depends on each person's location. So I think that's important to keep tracking that. There are two important things that need to take place. One is testing, and the other is tracking. And testing, of course, involves going somewhere, perhaps driving up to a hospital parking lot where someone can test you to see if you've been exposed. And the other one is tracking, knowing who's newly infected or who's been infected so other people can avoid them. And so those people can stay at home for a couple of weeks to be safe for everyone else. Ray, I know you have some other things to add to that.
Thanks, Paul. Thank you, Cameron and colleagues for inviting me to this panel. I'm probably the only general surgeon, so I'll tend to field some of those questions. But piggybacking on what Dr. Wetter just said, getting back to normal is probably normal in quotes, and is something that is indeed going to vary by location. In the state of New York, within the past few days, they've begun to do some random sampling of people who've gone to shopping centers or grocery stores. Now, what that means is they were well enough to be out and about. And looking at that particular data, on average, about 14% of the people they tested had antibodies to COVID-19, which means that they experienced COVID-19. And of those, about 80%, 80 to 88% of those, so in the neighborhood of 11 or 12% of that population on average had COVID and had no symptoms. And I think that's an extremely important point. There's a very large population of people in all likelihood who've contracted the disease or who are out in public places without symptoms and yet potentially could be infectious. And looking at within the state of New York, what the range is, so that percentage of people range from about 21%, almost 22% in the New York City area, to about 4% in the rural areas of New York State. And that probably stands to reason as well, because if you've got fewer people congregating together, the likelihood of disease spreading becomes smaller the less contact you have with others. So that explains the shelter in place and the various lockdowns that are going on within the various states. So bearing that in mind, and yes, indeed, one needs to have more testing. One needs to behave basically as if everyone is potentially infected, And on the medical side of that, that's what we refer to as universal precautions. Once we get to an opening up or a transition toward normal, in all likelihood, that will be something that will be driven by individual localities. It also is going to depend upon what's going on in those localities, and is there a spike in new infections and new cases as things begin to open up. And opening up, at least in my area and in terms of quote unquote elective surgery, is something that at least one of the outlying community hospitals is talking about beginning to schedule elective surgeries starting the 28th of April. Now, scheduling a surgery doesn't mean actually performing a surgery, and they haven't defined what they mean by elective procedures or how they're going to go about it. The entire state is basically on a lockdown until mid-May, and that may well continue. If COVID behaves like influenza and other pandemics, there tends to be the main spike in cases, which most people believe that's what we're in various phases of now. And then things kind of drift back to normal, but then there are secondary and perhaps third and fourth wave spikes that depend on how rapidly people get back to their normal activities and don't take as many precautions, whether the virus circulates around the globe, and so on. So putting all of that into perspective, what that means in terms of seeing patients, most of us who are seeing patients are doing it the way we're doing it now, basically by telehealth, either by video or by telephone. In fact, it's discouraged to see people face-to-face unless it's necessary. And if it is necessary to see patients, the office staff needs to have personal protective equipment, PPE. Patients need to call first and be screened, and then prior to entering the office, they need to again be screened and have their temperature monitored. Now remember, I said there's a large population that have had the disease and had no symptoms. That would mean that their temperature is normal. And the party being examined would still need to be masked and so on during the course of the evaluation. Clearly, urgent and emergent cases are still ongoing, and I would suspect that that will continue throughout. But I think what you're going to see is what people, at least in my part of the world, are starting to call a new normal, which is probably something that is going to be masks, some degree of social distancing, some degree of separation if you're in physical continuity with others. And we are probably going to be in that phase, I would guess, for at least the next 6 months and possibly longer.
Thank you very much, Ray. So do you see patients now, or any of the panel? Please jump in and see, how do you see patients, if any of you see patients, and what, and in what way?
It's Maurice Chung. I'm from Ohio, Cleveland Clinic, Ken Mercy Medical Center. I'm a urogynecologist and pelvic pain doctor. In my practice, ever since the lockdown, I've been seeing maybe 1 to 2 day, half a day patients, and most of them were for the pain, pelvic pain and endometriosis pain, done no surgery. And I follow the guideline when Dr. Lansafan mentioned patients have to get the temperature check at home before they come in, and then they'll check the temperature. We're going to give them a face mask, and of course, we all wear the face mask. So basically, I only allow the patient the type of those that if I don't treat the pain usually get worse, and it will go back to where we started to begin with. So it's like an ongoing process to control them.
Thank you, Maurice. So any of the other members of the faculty, are you planning to see patients? What we are going to do in our case is that we are planning to beginning this coming Monday. I live in California in the San Francisco Bay Area. So there has been some announcement that we should be able to do elective surgeries. And thus we are going to be following the following guidelines. First of all, if we are going to see patients, we ask them some questions in advance. We tell them if they have any temperature or any cough or any sign of coronavirus, or if they have been exposed to anybody who has had coronavirus. So if they have had any tests done, and if everything is negative, then and if they want to be seen, beginning Monday the 28th, we are going to see selective patients. They come, and while they are in the parking lot, they text us that they are here. Then all the limited number of the staff and physicians are going to be all wearing PPEs, personal protective equipment, and we encourage patients to wear masks also. As they come in, we are going to direct them to the examination room, and we will proceed with the examination. And when the patient has left, then if we need to see another patient, we will see it that way. That is how we are planning to do. Also, the surgeries we are going to do, we are planning to do it very carefully in a way that in the receptions, the amount of contact could be very, very little with other people, and mainly with the healthcare professionals. So I see Dr. Budgan Goresko also. Perhaps, Budgan, do you have any recommendation? Do you see? And he is a urogynecologist also. Please go ahead.
Thank you so much. Can you hear me?
Yes.
Oh, great. Excellent. Thank you, Dr. Najat, for inviting me. It's an honor to be here. Piggybacking on what the panel said, we are practicing in a very high prevalence of COVID in Long Island, New York. And we've been very careful with our elderly population because we see urogynecology patients who tend to be postmenopausal, but we do see a lot of premenopausal patients as well. We are practicing in an office that where we see pregnant patients as well. So our office was never closed throughout this pandemic. That being said, we try to avoid our elderly patients being potentially exposed, but we have seen occasional patients who have needed our help, either patients who had pessary, had vaginal infections, we needed treatment, we couldn't delay them, patients who had questions about surgeries or concerns. And what's important, what we've done in our practice, we have basically closed our waiting area. So when the patients come in, nobody sits in the waiting area. Everybody gets seen right away after being screened with temperature, vitals, and they go straight to the examining room and try to minimize contact with the patient in a sense of our examining room are quite small, so we brought our patients back to the office to discuss any questions they have, and then they're going outside, and their family or partners pick them up in the car. So no family is waiting in the waiting area to minimize contact between patients and keep social distancing.
Thank you very much. We're done. So I'd like to ask some questions now. I think this is already settled unless Dr. Farnejad and Dr. Sina Nejad, they want to say something. Then I will proceed with some other areas. There are a lot of questions has been sent in relationship to pain and also surgeries, number of surgeries, and also issues in relationship to pregnancies, IVF, etc. So I want to know if I see Dr. Sina Nejad or Farnejad, do you like to say anything? Would you like to start?
This is Dr. Farnejad. I add one more thing that whatever it was said. I'm a gynecologist, oncologist, and we have been conducting our visit via virtual consultation. And in our hospitals, occasionally some urgent cancer surgeries have been performed with all the cautions. So in our hospitals right now, all the patients before the elective surgery are going to be tested for coronavirus. And if the surgery is elective and the patient has coronavirus test positive, so the case is going to be postponed. And if the case is negative, if the test is negative, then we proceed with the procedures. Also, if there is an emergency surgery and the patient has positive coronavirus test, there is a specific sets of operating room that the surgery is going to be done in those operating room. That is the only thing I wanted to add.
Thank you very much, Dr. Farnejad. Dr. Sina Nejad, why don't you start addressing some of the issues of the pain? And there are a lot of questions that, for example, how many surgeries should you have for endometriosis? How many excision surgeries can you have? Would you like to address that?
Yes, thank you very much. I am Sina Nejad from Atlanta. Before I get to answer this question about how many surgeries you can have, I would like to invite Janice Weather to give us a prospect from a patient who has multiple medical conditions and she's had numerous surgeries. Tell us how her experience has been and what is her prospect about surviving in an environment like this.
Yes,
thank you, Sina. I come to this meeting as a patient who has lupus, which you're probably all hearing about with the Plaquenil and everything. I was undiagnosed for about 11 years. So like many of you out there, you didn't know what was wrong. You were struggling to find out. And what I can say is when you do get a diagnosis, that is your victory. That's the beginning of your plan to get better health. You need to mourn a little bit of some of the loss of your health, know everything you can, learn everything you can about, in your case, endometriosis. You need to be an advocate for your own health. And what I mean by that is when you do find the doctor that is going to be part of your team, you need to keep your own health diary. You're one of many, many patients that your doctor has and sees, and you need to keep track of all your surgeries, your medications, the trials and errors of them, the symptoms, what you can take, what you're now not able to take. It's critically important. When you go to see your doctor for a visit, when we're all back on track, have a list of things you want to talk to the doctor about. I know in my own experience, if I didn't have that list and I went to the doctor's office, it all went out the window. So have a list, tell them you have things you want to talk about. There is no one size fits all for your treatment, as you know. There are many options, many types of surgery, and you need to keep a list of what it is you're having done and the questions you have for your surgeon. One good thing, and this is something I've done for 40 years once I did get my diagnosis, is talk to other people who have problems like you have. Helping others help you learn and helps you help other people. Listen to your body. If your body says, I'm having a really tough day, I have to rest, you rest. You do what your body tells you. You're not copping out. You're doing what you need to do to stay as well as you can. Don't put off tasks. If you have something that you were supposed to do and you're feeling great today, well, I'll do it tomorrow. Don't, because you don't know what tomorrow is going to bring. You have no idea of what's going to be around the corner. And have faith and hope and courage, because this is a long road. And if you do these things, you are more in charge of your health than you realize just talking to me right now. And I thank you for letting me participate. If anybody wants to ask any questions or get in touch with me, that's fine. Just the victory is finding out what's wrong, finding the doctor, setting up a plan, being your own advocate, keeping your health diary, and all those kinds of things, and talking with other people in similar situations so we can all learn from each other. Thank you.
Thank you very much, Janice. How often do you, over the years, when you take pain medication, how do you balance them, and how do you change your medication? Or do you ever get resistant to one kind of pain medicine versus the other kind of pain medicine? How do you deal with that? How often do you change it? Do you use anything, alternative medications for pain? And what do you use?
Are you speaking to me? You were mute for a bit.
Yes, I was asking you, Janice.
Okay.
I was asking you that, what would you, for over the years, when you take pain medication, how do you deal with preventing getting addicted to pain medication? How do you deal with avoiding getting addicted to one kind versus the other kind?
Well, I've had, as you had mentioned, numerous surgeries related to taking massive steroids for pain over all these years. And I've had all kinds of things. And what I did with the last big surgery I had was I had my foot rebuilt because the bones were all, because of tendons and ligaments and everything, the foot collapsed. I kept a record of my goal, which was, okay, I have to be on this heavy medication and I want to be on it. I'll need to be on it for a certain amount of time, but I'm going to get off it sooner. And the one thing I learned was, don't let the pain get ahead of you. Before you start, if you're supposed to take something every 6 hours, start thinking about it 5 hours. How are you doing? Because if you let the pain get ahead of you, it's hard to come back from it with the pain medication. You wind up needing to take more than you would normally. So you really have to be aware when you are on medication for pain medicine for a particular event, really keep track of it and start trying to wean down when you can.
Thank you very much, Janice. We appreciate it. There are some more questions coming in. As we go on, we would address it. There are some questions that they have asked us, and I was wondering if the panel would like to address it. There are several questions that our patients, specifically some of the patients in California, that have been asking that, is it okay if they can use some of the marijuana products like CBD oil or THC that now they are almost everywhere approved in all the states in the US, not everywhere, but almost everywhere. How, can they use it, and how should they use it, and what is the recommendation of the panel? Does anybody have any experience with it? Would they like to answer that question?
Cameron, given my experience with light-based technologies and photobiomodulation, I get a lot of queries about that and various other complementary and alternative medicine approaches. CBD oil per se is pretty much marketable throughout the 50 states as far as I understand. It's not marketed, well, it's not supposed to be marketed as a drug, let's put it that way. But there are several ads that you can read in print or exist in other media that come very close to crossing that line, if not crossing that line. And those are things that the Food and Drug Administration in particular has landed on because none of these things have really been studied relative to their effect. So you can get CBD oil that you can put on topically. You can find it in food products. You can find it in food products for your pets. As some people have gotten some benefit from it, which I think kind of promotes the use in marketing. But I think the bottom line, whether you're using CBD oil, whether you're using THC or smoking marijuana, which is illegal in a bunch of states, you need to be careful with what you're doing, and you need to remember whether it's something that I'll call traditional Western medicine approved drug technology, whatever treatment, or whether it's something on the complementary or alternative side. If it sounds too good to be true, it probably is. You need to be telling your healthcare providers what agents you're using, not just CBD or marijuana, but all of the supplements and so on, because they can affect your treatment. So I would say, yes, I've had some patients who've used them and have sworn that they are helpful. I've had some others who haven't, and we've all heard horror stories of people who've gone too far.
Thank you very much, Ray. I appreciate it. Now, if I don't know if the other members of the panel, they would like to say anything in this regard. Maurice, do you want to say something? Anybody else wants? If not, then Tiffany is going to ask some more questions, because a lot of questions are coming in.
I think Dr. Maurice Chang has an extensive experience being involved with the Pelvic Pain Society, and his feedback and input would be very helpful to our audience. Maurice?
I do that message on the bottom right. You can choose who it goes to.
Hello, Dr. Chang.
Okay, I'm got it. I'm still very new to this chat. Well, I do not personally prescribe marijuana, and I don't object my patient to use CBD oil or marijuana. And in terms of, I have seen some of those questions I think Tiffany sent out about the pain medicine. I typically do not give out pain medication like any of the narcotics to my pelvic pain patients or endometriosis. And when they have the problem with pain, well, of course, that we know endometriosis causing a lot of pain and endometriosis causing infertility. So in the pain group, we talk about what are the reasons why you have the pain. Is it just endometriosis? There are too many organ systems in the pelvis, including the bladder, including the muscles, including the nerves, the ligament, and the bowel. And endometriosis could be one of them and could be part of them. So basically, for pain patient, before I even approach surgery, I pretty much can decrease the pain level within, I say, 2 months. 80% of the patient would have 50% or more of the pain reduced without any surgery yet. And some of those, the pain would be completely gone. Of course, that I cannot say that they did not have endometriosis because I have not looked into that yet. So in terms of pain, through this pandemic situation, they come into the office, they said, my pain get worse, so I just try to figure out which part of the problem. And for those, many of them already have endometriosis, although I don't trust them, surgeon, because of they do fulguration surgery. But then when they have pain, that's the time I do not want to do surgery. And that answers some of the question, why is it some patient after endometriosis surgery, the pain gets so much worse after the surgery before they get better? Because the pelvis is on fire. And I typically treat the muscle, treat the nerve, and treat the bladder. So,
thank you very much, Maurice. That is excellent. Maurice, what do you do for about patients with interstitial cystitis? What is your approach? And how do you diagnose them? Maurice, do you hear
me? Oh, okay.
Yeah.
Well, see, in the interstitial cystitis and in the urologist or gynecologist or the female pelvic medicine is a little bit different. The typical interstitial cystitis patient, they urinate a lot, they have the urgency, they go to urinate, and then shortly after they have the urgency. If they don't go, they have pain. So, and they have multiple times, like 10, 20 times, 30 times a day, they have to go urinate. Now, those are very much, it's an isolated group of interstitial cystitis patient. In the past, I see patient was diagnosed by cystoscopy, hydrodistension, basically put a lot of water in the bladder and looking for the changes. But then I think in about 10 years, 15 years, they change it into the definition of when you have bladder pain, when your bladder is filled up with urine. So that's the painful bladder syndrome. So in the group, I found that painful bladder syndrome actually happened to be in about 85% of the patient. And so that's a lot. And in about 2002, which, when I was still a resident, I was learning Dr. Cameron Najat and Farah Najat's laser surgery. That goes back to 1980s. So we do a lot of treatment of endometriosis, and I found those patients happen to have painful bladder syndrome almost at the ratio of 1:1. The more I look into it, endometriosis patient, if the lesion is on the bladder flap, if the lesion were to be on the pelvic plexus, the hypogastric nerve, and on many other areas, they'll set off the urinary urgency and frequency. And then when I look into more, patient with interstitial cystitis, i.e. painful bladder syndrome, they have pelvic myofascial pain syndrome. So the muscle in the vagina hurts a lot, but nobody knows exactly why the muscle hurt and really don't have an idea to treat them. But then I look into more and I found out that in the pelvic nerves, the sacral nerve, S2, 3, 4, 5, invariably affected by the pelvic floor muscles. Bladder goes through S2, 3, and 4. So then I isolated out in all these patients. I first go after the bladder in the office, giving them the instillation therapy for 4 weeks' time. And I did the test on the first time to see whether the pain level dropped or not. Amazing, you'll see the changes. And the residual type of patient, when the improvement is 50% or they still want to get a little bit more, and I give them bilateral pelvic block. So that happened within 3 months time, and the pelvic pain level will be much less than 50%. And that's the time I take them to do one good surgery and one good surgery. Whether there's endometriosis, I take them all apart, remove them. And if the pain comes back after surgery, we know that that's the bladder pain, part of it, the muscle pain, pudendal nerve pain. And some of these patients will go to physical therapy. Now that is the approach that I have. And I don't have people call me up at 2 in the morning and say, I hurt so much. Because those patients knows that even though they go to the emergency room, they cannot do anything for them. That's a nutshell in 5 minutes.
Thank you very much, Maurice. Bogdan, do you have anything to add? How do you approach this?
Yes, thank you. So for our interstitial cystitis patients or painful bladder syndrome, so you have to distinguish that a lot of patients with pelvic pain related to bladder, which is suprapubic pain related to a full bladder and relief of voiding, a lot of patients do not have cystoscopic findings of glomerulations or hemorrhagic cystitis associated with classical descriptions in textbooks. You know, it would be nice to diagnose all the patients just with cystoscopic findings, but unfortunately, some patients, a lot of patients with pelvic pain, you look in the bladder and the bladder looks perfectly fine, and they still have a lot of pelvic pain. First and foremost, what we do, we have to rule out UTIs. We have to rule out urinary tract infections in patients who have any kind of pelvic pain related to the bladder. Once we rule out a UTI, we give them a questionnaire. It's a pelvic urgency frequency questionnaire, which correlates with some cystoscopic findings from studies done more than 20 years ago by Sant, Dr. Sant. So these are classic studies. In the old days, what they used to do, there was a very painful test called potassium sensitivity test, where potassium got instilled in the bladder, and the patient basically screamed loud and clear that they have a lot of pain when that gets instilled in the bladder. So we don't do that test, but the pelvic urgency frequency questionnaire, if they score more than 15 on that questionnaire, that correlates well with the potassium sensitivity test. So we diagnose our patients with questionnaires and a thorough history and physical examination, and then we may do also cystoscopy in the office or in the operating room. We try to instill in the bladder to maximum capacity, which can be under anesthesia. The bladder can support up to 1 liter of sterile water. So if patient has a chronic interstitial cystitis, their bladder capacity will be reduced from scarring, and we often see the bladder capacity often half that size with patients with IC, with interstitial cystitis, and with glomerulations and petechia, which are consistent with the diagnosis of interstitial cystitis. That being said, a lot of patients don't have cystoscopic findings, but they still have the bladder pain. It is important, it is very important for patients with IC to start performing dietary modifications. So we give our patients a list of bladder irritants, which can include fruits and vegetables, meats, caffeine, alcohol, acidic foods, spicy foods that can irritate the bladder. So if they avoid those irritants, they can improve their symptoms to a great extent. At least 50% of patients can get improved just by dietary modifications alone. The patients who don't respond or who still have some pelvic pain, some bladder pain with IC, what we do is we do bladder installations. So patients who come in every week for 6 weeks, and we instill in a bladder a cocktail of substances that would soothe the inflammation in the bladder. In patients with IC, they have what's called a leaky bladder, where the substances from the bladder, with the urea and acidic components from that reach the bladder from their dietary intake, penetrate the bladder wall and get in touch with the nerves of the bladder, causing irritation and pain. So by giving them a cocktail of substances, which includes heparin, which is a bladder GAG analog, is a glycosamine glycan analog. Heparin combined with local anesthetic, with Solucortef, a mild steroid, and sodium bicarb mixed together by us in the office. We still it in the bladder through a small catheter for weekly for 6 weeks. And we noticed with these treatments, about 90% of our patients improve significantly. That coupled with dietary modifications can lead to even more success for our patients with IC.
Thank you very much, Bogdan. As you can see, we have a lot of interest, but a lot of time, and time is running short because we were planning to do this for 45 minutes. We will go for 10 more minutes, and we try to answer some of these questions very quick and fast. Please, everybody give short answers and to try to answer as many of them. Tiffany, please go ahead and ask some of the questions.
Sure. So we received a lot of questions, a lot of them very similar. So one of the primary questions that we get asked a lot is about birth control and how long is safe to be on it. So we've received several questions just in general, as we know that that's something that's used a lot, you know, to help treat some of the symptoms with endo. So is it okay to be on it for a lengthy period of time? Also, is it safe to stop your period for a long period of time? Should you, stop doing that at some point? And, how could that affect you if you're doing that for a long period of time?
I can answer this question and also combine to a few other questions. In general, if a medication, regardless, because I saw some other medication also is mentioned, if a medication can control the symptoms based on the individual who does not have associated risk factors and the risk of side effect is minimized by adding supplemental medication, the birth control pill or progesterones or any suppressive therapy is preferable over too many surgeries, aggressive surgeries. One of the audience said her diaphragmatic and lung symptoms have been controlled with medication. It's better to continue the medication. Birth control pill to suppress the periods is preferable if they can manage the breakthrough bleeding in betweens. Of course, birth control pill is hormones. It comes in the combination of estrogen and progesterone or progesterone only. It has to be individualized. Thank you.
People may experience less depth.
Okay, please go ahead. We have some more questions. And one of them I can actually address it quite fast. Some of the patients have had pain. Also, they have infertility. And the question is, should they have surgery or should they take care of their infertility? And that all depends. It depends what stage you are. Patients who are younger than 35, and they have a lot of pain and also infertility, and their husband's sperm count is normal. If they have surgery by an experienced surgeon who does thorough and good surgery without causing any problem, their chance of getting pregnant is excellent, even prior to surgery, prior to IVF. And there is good literature, good papers published in this regard, and Tiffany could send those of you who are interested. Even those of you who have pain and you have had infertility and you have undergone IVF, and because of sometimes IVF medication makes endometriosis worse and the pain worse, then you should not give up. Surgery by itself could treat the endometriosis significantly, not 100%, but you can have good results by proper surgery done, and you can have good results achieving getting pregnancy, even repeating your IVF after the treatment of endometriosis. And good data has been published in this regard also. So I let one other question that I saw, how many surgeries should you have for endometriosis? Endometriosis, unfortunately, is very enigmatic. We don't know much about it. We think we know, but the more we know, we know less. Sometimes severe endometriosis causes no pain at all, nothing. And sometimes a small amount of endometriosis causes pain. And there are pathways, there are issues to deal with, but we do not help 100% of our patients. Unfortunately, it seems some patients need to have surgery very often. And after you treat the surgery, after you treat the endometriosis, let's say a year later, 2 years later, they do well for a while, and then endometriosis in some groups of patients reoccurs. And we do not know why. Is it an autoimmune problem? Is it suppression? Is it the food? And we don't know that. And also, that is another issue that there were many questions about that. So Tiffany, please ask one more or two questions before we finish the time.
Sure, absolutely. Another question that's come through a lot is in regards to diet. What foods should we avoid if we have endometriosis? Are there certain foods that we should be avoiding to help our symptoms? As well as, is there any proof that the endometriosis diet works?
May I answer to you a little bit? When I believe endometriosis happened to be almost hand in hand with painful bladder syndrome. And many of these patients do have irritable bowel syndrome too. So just you can pick out the painful bladder syndrome, those patients who prefer hot and spicy Mexican, Sichuan, Chinese food with a lot of apple juice, pineapple, vinaigrette, tea, anything with high potassium and stimulant fluid can act up the bladder. So now you act up the bladder, which is invariably act up the bowel because they are all in the hypogastric plexus. And with IBS, some patients have gluten allergies, so they cannot have any type of food with gluten. I can only suggest my patient with component of interstitial cystitis or painful bladder syndrome to stay away from that type of food, because even patients with endometriosis only, but when they have pain for so long, they will flare up the pelvic nerves and then causing problem to the painful bladder syndrome and the painful bowel. So yes, if anything, you follow the IC diet, and patient with IBS, they know what to eat, and they know what not to. Yes, there's a diet for it.
So Cameron, I'd like to add one more thing about pain and endometriosis. We have to keep in mind that, as was mentioned, not every pain is in patient with endometriosis is because of endometriosis.
Right.
As Dr. Chung mentioned, and Dr. Gregorescu, bladder symptoms, pelvic floor, muscles, other issue has to be kept in mind. The other thing is very important for the patients to know. And as Dr. Cameron Najat mentioned, it is a very complex disease. And some people that claim that excisional endometriosis is going to cure the endometriosis, they have to be cautioned when they use the word of cure. Endometriosis lesion, unfortunately, a lot of times comes back. And we don't have any panacea for this treatment, for this disease. The most important thing is in mind that we have to individualize the patient, as Dr. Sina Nejat mentioned. The best surgery is no surgery, because in the best hand surgeon, in the best facilities, you may have side effects, complications. So we try to individualize the patient, find out the source of the pain, and try to implement appropriate treatment back for that particular person.
That's very true, Fa. You just mentioned something is very true, because even patient endometriosis, they also have other things going on. The recurrence or flare-up may not be endometriosis, may be a painful bladder. And sometimes the flare-up may not be painful bladder, it could be the muscles and the nerves. So we have to find out exactly what bothers the patient and would have an algorithm that to sort this thing out. And too bad this year the SLS didn't have the meeting. I actually have 2 abstracts to submit it to that for just this algorithm. So that's how I approach. Surgery is the last. And after that, we know whether there's endometriosis or not, but sometimes when the patient did not even have pain, I would go through surgery and I found endometriosis, but the pain level was 0. Or sometimes I go in, I did not see any endometriosis. So that is the puzzle, what we all talk about. And pain is the pain. I deal with pain differently. Menstrual cramp is menstrual cramp. Then you can use the birth control pill to stop the bleeding and stop those pains, so I can proceed with the muscle and the bladder evaluation before I go right into the surgery.
Well, I'd like to thank all the participants. This has been a most fantastic meeting. As you know, we were supposed to be online only 45 minutes, and people that have already scheduled other issues to do and work to do, and we have already more than an hour. So we will, because there is so much interest in all these virtual conferences and other, and I'd like to thank all the audiences first, and then I'd like to thank all members of the panel, Dr. Grisco, Dr. Chong, Dr. Wetter, Dr. Lanzapam, Janice Wetter, Dr. Sina, and Dr. Farnejad, and also Tiffany Letsky and Zoe Pennington that organized this session. And thank you very, very much. There are many, many more questions. We apologize. We were not able to answer all of you. We try to answer them as much as possible, by some of them by the email or call you. Thank you very much, and stay safe and have a fantastic weekend. Bye-bye.
Thank you. Thank you so much. Thank you.
Bye-bye.
Thank you. Have a nice weekend. Bye-bye.
Bye-bye. Thank you, everyone.
Bye-bye.
Good evening. On behalf of the Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists, I'd like to thank our guests this evening, Ms. Nidia Morales from Rio, Brazil, and her translator, Rio. They
Rui.
are, say again?
Rui.
Rui.
Yes.
Well, thank you for both being here with us to talk about a topic that's very important to Nidia as well as myself, and I'm sure many of our viewers today, endometriosis and advocating for this debilitating disease. Nidia, can you talk a little bit about your work with the organization that you've created in Brazil?
Fala sobre a organização que você tem no Brasil.
Fazemos todas as conscientizações nas comunidades mais carentes, levamos a endometriose, a conscientização da endometriose para pessoas que não entendem, não sabem e que acham que cólica é uma coisa normal.
So the ONG has 13 years, and so far they're educating people, sending the message to mainly to poor communities, for people who does not have access to the information that endometriosis is a serious disease. It's not just a pain in the stomach, like a colic. I don't know the word, but it's like a pain in the stomach. So that's the work that she has been doing so far.
And she mentioned that the organization has been around for 13 years now. That's excellent. In the 13 years that she's been working with this organization, how has she seen endometriosis awareness change in the Rio area or in Brazil?
Como é que você vê essas mudanças na conscientização da endometriose aqui na área do Rio, ou talvez no Brasil?
Aqui no Rio de Janeiro, né, com as conscientizações que estamos fazendo para pessoas que não conhecem endometriose, eu tenho visto que as pessoas têm recebido, aceitado, as famílias têm dado mais suporte às mulheres, e acredito eu que, né, esse trabalho de formiguinha ele vai crescer cada vez mais, e eu acredito que a gente consiga mais força e que essa doença ela consiga ser propagada por aí, que mais pessoas elas conheçam que cólica incapacitante ela não é normal.
Yeah, she said that the results are increasing once that she's spreading the message to the communities, and a lot of people doesn't know that some just pains that they are feeling can be endometriosis. So all the information that she's spreading out to the communities, especially the poor communities, is letting people to have access to a treatment, anticipated treatment, and avoid to the endometriosis moves to several let's say levels. So that's the results is getting increased about because of the spread of communication.
Excellent. She's doing great work there with her organization. Are there a large amount of endometriosis specialists or surgeons in the Rio area or throughout Brazil that are easily accessible for women that are suffering from this disease?
Tem muito profissional de endometriose no Brasil que são acessíveis para as mulheres. No.
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 It's very sad and disappointing, but the reality is not just in Brazil. It seems
Nós temos uma parceria grande com a Sociedade Brasileira de Endometriose, porém são médicos que atendem pagos. Os gratuitos, aonde nós vamos, em mulheres que não têm condição para nada, a gente não tem esses médicos totalmente disponíveis.
Yeah, they have a partnership with the Brazilian Endometriosis Society, but the problem is these doctors are very specialists on this topic, and they are not for free. So a very limited people can have access to this kind of professionals, and that limits a lot the access to solve this disease.
I see. And now, how many women are a part of your organization, Nydia?
Quantas mulheres tem na organização?
Na organização, trabalhando conosco?
Duas, assim.
Somos poucos.
There are few people, but very engaged, and because they don't have any, how can I say, any public resources from governments, so they invest their own money and their time Lydia's mother's help, Lydia's husband's helps, and I help as well. So yeah, here is.
And me. Nice to meet you.
So that's the main challenge now, because the resources are very limited. Once they have like I said, they're using their own resources to help people.
Well, that is truly dedication to your cause. So there's about 3 or 4 of you who are working diligently and so hard to get that message about endometriosis out. How many women though are in the organization or follow you, would you say?
Quantas mulheres
Over
seguem
the 13 years?
nesses 13 anos? Quantas pessoas foram atendidas, talvez? Quantas pessoas?
Nossa, é muita gente. Vamos dizer que
Countless, because
que 30.000.
about 100,000 people, because
wow.
It's difficult to measure that, right? Because she's spreading the message and.
É porque elas se sentem seguras e aí elas caminham sozinhas, né? Se sentem alguma coisa, elas voltam. Aí a gente acolhe novas e aí elas vêm e vão,
So
e assim.
when they start to feel confidence, the women run alone. But when they feel something, they run back to Nidia and asking for help.
Well,
so going back and forth is very common. Yeah, and yeah, that's right. And the social media is getting crazy because of the cause. And how many followers? Quantos seguidores você tem? They have around 50,000 followers.
50,000 followers.
So, social media, right?
Which social media outlets are you using, Nidia, to reach?
Qual é isso? É mídia social? Instagram?
Instagram, Facebook, tem um grupo fechado também no Facebook.
There is a group in Facebook.
É um movimento muito grande. Pergunta, gente da Angola dá contato com a gente.
A lot of people change info in this group, and people from another Portuguese speakers country like Angola and Mozambique, they are asking for help. 1 second.
Aproximadamente 50.000 somando ao todo.
Yes, that's it.
So what is the name of the Facebook page? As if there's someone out there who's listening and wants to check out your social media, what page would they go to on Facebook?
On the Facebook.
A Vida Como Ela É com Endometriose, o mesmo nome do Instagram.
Instagram and Facebook have the same name. A Vida, a Vida Como Ela É com Endometriose.
E o grupo fechado é outro nome, é Endometriose Brasil.
And there's another group called Endometriose Brasil.
You mentioned when we were chatting earlier about SUS, I think you were calling it.
SUS is the Brazilian National Health Program, which has some connection with with the work that Nidia does.
And so with that joint effort that you're doing with them, what kinds of services are available to women with endometriosis through your joint effort?
Esse é um trabalho que a gente desenvolve, né? Hoje nós conseguimos, em um município, criar uma equipe multidisciplinar, ginecologista, especialista, tudo no SUS, especialista, nutricionista, massagem e vários outros médicos ali que atendem elas. Isso num município, que é o município de Belford Roxo.
Yeah, there is one city here called Belford Roxo, where they developed together with SUS a kind of group, which is composed by gynecologists.
Gynecologists, yes.
What else?
Nutricionista.
Nutritionists.
Okay.
Tem acupuntura, massagem, psicólogo.
Psychologists and massage and what else?
Acupuntura.
Yeah, acupuntura.
Acupuncture.
Yeah.
E essa equipe, né, e outros médicos, eles ajudam elas, né, mas é uma região muito pequena.
Yeah, and another doctors help, but it's a very small city compared with all real state and all Brazil.
O que nós queremos é ampliar isso com outros governos, né, fechar parceria com eles para que a gente consiga ampliar em vários outros locais, outras cidades.
She's looking for some partnership with some other governors or mayors to spread it out to another cities and regions here in not only Rio, in Brazil.
Também é onde acabar fornecer isso também, né? Ter esses médicos para estar atendendo também.
Yeah, the idea, as they only have their own spaces, they have their own space. The idea is to have doctors, this group of doctors, from the owned by the ONG. They work for ONG as well.
Oh, okay. Okay.
ONG offers to women this pool of specialists.
So the services that you just mentioned, gynecologists, psychologists, nutritionists, massage therapists, these people are available to women with endometriosis. They can access those services, if I'm understanding you correctly, through the work that you've done in conjunction with SUS. Is that right?
But today only in one municipality here in Rio. So the idea is to replicate in other areas, not only Rio, like I said, in Brazil as well.
Throughout the country. I think that's great. Yes, you're starting with this framework and then you're going to try to have it expand.
It's a lot of work, not easy.
Not easy. It's not easy. Just like endometriosis, not easy, but you have to continue to power through. And my last question for you, Nidia, is where do you see endometriosis going within the next 5 years? How do you think, treatment and awareness, what will it look like 5 years from now? What are your
endometriose daqui a 5 anos em relação ao tratamento, ao cuidado?
Acredito que a gente está avançando muito, né?
Rápido,
né? Acho que sim. Há 13 anos atrás eu não tinha nada de informação. Eu comecei um movimento que pouco se falava. Então, trazia mais lá de fora, porque aqui dentro não tinha muita coisa. Então, acredito que daqui a 5 anos, as pesquisas estão tão avançadas, né? Cada hora uma coisa. Eu acredito que a gente consiga dar passos largos.
Comparing with from the past 13 years, especially when she started all this work, she's very confident that in the next 5 years we double the speed regarding the knowledge, information, and awareness about the endometriosis. So she's very confident about that.
Well, I love your confidence, and your work is clearly making a huge difference in Rio and throughout Brazil. And we want to thank you for that and look forward to hearing about the great things that you will continue, I'm sure, to do in your area and in your country. So thank you so much, all three of you, for taking time to chat with us today. And good luck to you as you continue on advocating for endometriosis awareness and policy changes in Brazil. Have a great day.
Likewise. Thank you. Bye-bye.
Yeah.
Diagnostic laparoscopy revealed the left ovary to be enlarged and had endometrioma type 2C, approximately 8 to 10 centimeters. There was deep endometriosis on the abdominal wall above the appendix. Both superficial and deep endometriosis was found on the surface of the diaphragm. The endometriosis, biopsied on previous colonoscopy, was found in the transverse colon. There were severe adhesions and endometriosis on the anterior cul-de-sac. All endometriosis and adhesions of anterior cul-de-sac were treated, resected, and sent to pathology. Large ovarian endometrioma was drained. Pelvic cavity was thoroughly irrigated and washed. Ovarian cystectomy was performed and sent to pathology. Hemostasis was achieved using low-power bipolar electrocoagulation and applying Surgiflow. The left fallopian tube, which was in form of hydrosalpinx, was removed by electrodesiccation and cutting of the mesosalpinx. The ovary was completely saved. Anterior abdominal wall endometriosis was resected and sent to pathology. Attention was made towards the posterior cul-de-sac while the assistant performed rectovaginal examination, and also by placing a rectal probe in the rectum. The boundary of the rectum was identified. Endometriosis of the posterior cul-de-sac and the rectosigmoid colon was completely treated. The involvement of the mid-abdomen, just superior to the appendix, was resected and sent to pathology. The appendix had signs of possible endometriosis. Therefore, the mesoappendix was electrodesiccated, cut, and vascular stapling was used to staple cut and remove the appendix. After all the pelvic endometriosis had been treated, the robotic apparatus position was changed towards the upper abdomen. The adhesions between the liver and diaphragm were lysed. Endometriosis of the diaphragm was completely treated. Some area was resected. Others were vaporized or coagulated. There was no perforation of the diaphragm. At this point in the surgery, the general surgeon took over the robotic console to treat the endometriosis of the transverse colon. It was resected with a primary anastomosis. Of note, the robotic apparatus position was not changed from its view of the upper abdomen. Using the robot, the lesion was completely excised with sharp dissection, using the scissors, until it was completely resected. Primary repair of the transverse colon after resection was performed robotically by using 2O silk sutures in a running fashion until the whole anastomosis was completed. The muscle was checked and appeared to be satisfactory. There was no evidence of leaks. There was no evidence of bleeding. There was no tension at the anastomosis. The abdominopelvic cavity was thoroughly irrigated and washed, and complete hemostasis was achieved.
Ok, buenos días. Mi nombre es Leslie. Estoy aquí con Eva y con Stephanie. Si gustan, las dos compartir un poco de ustedes, su nombre y de dónde son.
Hola, mi nombre es Eva Marina. Soy la presidenta fundadora de la Asociación Iberoamericana de Endometriosis. Soy paciente de endometriosis. Bueno, empecé a los 11 años mis síntomas y me diagnosticaron a los 24, 25 más o menos. Y actualmente tengo 49 años. Gracias.
Hola, mi nombre es Stephanie Contro. Pertenezco al comité de la Asociación Iberoamericana de Endometriosis. Padezco endometriosis aproximadamente hace 5 o 6 años y soy de la Ciudad de México.
Muchas gracias. Ahora voy a comenzar con las preguntas que les tenemos para el día de hoy. La primera es, ¿cómo creen que ha cambiado la concientización de endometriosis en sus países en estos últimos 10 años?
Fanny.
Ok. Creo que no ha cambiado como tal, más bien hace falta muchísimo trabajo por parte de las instituciones de salud, sobre todo, para saber qué es la endometriosis y cuál es el camino que debe de llevar una paciente diagnosticada. Lamentablemente es más las acciones altruistas en las que te ves y en las que incluso investigamos para que te puedas acercar tú como mujer diagnosticada a una asociación o estas asociaciones sin fines de lucro para que te puedan asesorar y que te puedan ayudar un poco sobre tratamiento, sobre especialistas, entre otras cosas.
Sí, también yo creo que ha aumentado muy poco. Sí ha aumentado un poco, pero por ejemplo, como dice Fanny, en instituciones de salud pública realmente no. O sea, no hay una educación de parte de los especialistas, no hay apoyos, no hay tratamientos ni cirugías especializadas. En el ramo, digamos, en el sector público, hay muy pocos especialistas. Digo, si hay en México, la verdad es que cada vez hay un poquito más. Y está esta parte de sensibilizada de parte de los mismos especialistas, pero sigue habiendo muy pocos para Se habla de que en México somos entre 7 y 10 millones de mujeres con endometriosis, entonces siguen siendo muy pocos para la gran cantidad de pacientes y sobre todo el mito de que el cólico menstrual es normal, pues viene de generación en generación y es un mito que nos ha costado muchísimo trabajo erradicar. Nosotros llevamos más de 14 años trabajando y aún así, la verdad es que ha sido muy difícil por las creencias que se tienen de, pues, desde las abuelas y de generación en generación. Entonces realmente ha sido muy, muy poca la evolución.
Muchas gracias. Y hablando de los especialistas igual, la próxima pregunta sería, ¿qué tan disponibles están estos especialistas y cirujanos de endometriosis en su país?
Bueno, actualmente contamos con muy pocos especialistas, como ya comenté. Son aproximadamente entre 9 y 12 especialistas. Están disponibles solamente dos de ellos están en sector público y privado, todos los demás en sector privado y bueno, realmente siguen siendo insuficientes y para algunas, bueno, para la mayoría de las mujeres por la situación económica de inclusive del país, a veces llega a ser inaccesible los tratamientos quirúrgicos sobre todo. ¿Tú, Fanny?
Sí, son inaccesibles, demasiado costoso e incluso este ya es un mensaje directamente para los especialistas e incluso la manera en que te dan este mensaje o transmitirte esta incertidumbre también causa un efecto emocional y psicológico del lado de la paciente. Entonces, además de especialistas, además de que hace falta más información sobre tratamientos, hace falta ese tacto para transmitir el mensaje de lo que es la endometriosis y lo que conlleva vivir con eso el resto de tu vida.
Y esto voy a completar un poquito lo que comenta Fanny, me parece muy importante, porque sobre todo los médicos de primer contacto o los ginecólogos que a lo mejor no tienen esta especialidad de endometriosis, llegan a ser justamente así muy toscos, le llamamos en México, para decirte que tienes endometriosis y te llegan a hacer comentarios que te afectan mucho emocionalmente, como que cuando te cases se te va a olvidar, cuando tengas hijos se te va a olvidar igual, o embarázate y se te cura la endometriosis, o el lado contrario de que sabes que esto va a ser para toda tu vida, va a venir en progreso y pues esperar lo peor, ¿no? O la otra parte de te tengo que hacer una histerectomía y ya con eso se te quita la endometriosis. Entonces siguen siendo médicos que no están actualizados y además que no tienen esta sensibilidad para darte la noticia y para darte un diagnóstico que además ellos lo manejan de manera incorrecta. Entonces, como dice Fanny, es un llamado para toda la comunidad médica para que se especialicen y tengan mucho más sensibilidad, porque inclusive nos ha tocado de chicas que van con el psicólogo, que van con el psiquiatra y que les dicen que sigue estando todo en su cabeza y que es una forma de llamar, que quieren nada más llamar la atención. Y no es así. Nosotros les decimos, a ver, nosotros sí te creemos porque sabemos que lo que te está pasando es real. Entonces los canalizamos justamente con los pocos especialistas que hay en México que sí están sensibilizados con esta parte y que cuentan con un equipo multidisciplinar donde también tienen psicólogos y terapeutas que ayudan a la mujer también a llevar este diagnóstico. Pero el resto de la comunidad médica, la verdad es que, como dice Fanny, llegan a ser muy agresivos para darte el diagnóstico, para explicarte lo que es y para darte el supuesto remedio.
Ok, muchas gracias. Y ya siguiendo el tema igual acerca de eso, queremos saber si ustedes creen que hay algún cambio en las pólizas o hasta en la educación acerca de endometriosis en su país, en México?
Hablando de pólizas, me imagino que son pólizas de seguro, no las hay, no las hay. Nosotros hemos estado trabajando el último año para ver si podemos ahí sensibilizar un poco. No hay ningún cambio, siguen sin cubrir justamente este rubro cuando son preexistentes. Ya cuando se compra el seguro antes, entonces sí lo llegan a cubrir, pero creo que hasta cierto, bueno, obviamente dependiendo del costo de la póliza, ¿no? De la capacidad de la póliza. Fanny.
Sí, por experiencia personal no hay unas cláusulas ante una enfermedad que es crónica. De hecho, si te cambias de seguro, realmente no te lo cubre. Si la primera cirugía o el primer tratamiento lo hiciste con un seguro, pues automáticamente en México no se puede canalizar ese histórico, ¿no? De tu padecimiento. Eso con todas las enfermedades, pero algo que es meramente que no es controlable, que no lo puedes predecir. Este mes me va a llegar tranquilo, el siguiente mes me va a llegar fuerte, entonces no lo puedes predecir y no te ayuda también, no tienes un amparo en las pólizas de seguro, ¿no? Entonces terminas justo ahorrando para poder pagar por tu propia cuenta, ya sea la cirugía, el tratamiento, entre otras cosas. Y también cabe señalar que los tratamientos no te dan un seguimiento, no te dan un reembolso por todos los medicamentos, siempre y cuando no sean estos ligados a una cirugía. Entonces, sí está, tanto en el sector privado como en el sector público, hace falta muchísimo fomento para la existencia tanto de la enfermedad como cómo manejar la situación en cuanto a cirugías, medicamentos, entre otras cosas.
Muchas gracias. Y ya la última pregunta para ustedes sería si hay o tienen algún proyecto en el que están trabajando en este momento como equipo.
Sí, de hecho tenemos varios. Uno de ellos somos parte de el nuevo colegio Mexicano Multidisciplinar de Endometriosis. Se acaba de hacer el colegio en el mes de julio. Y bueno, este es el primer colegio en Latinoamérica. En Brasil también hay un colegio similar a este. Y me gustaría compartir un poquito de lo que es la misión y quiénes conforma este colegio. Si me permiten, voy a leer. Dice, la misión del Colegio Mexicano Multidisciplinar de Endometriosis es mejorar la vida de las personas con endometriosis en México a través de la promoción de la colaboración multidisciplinaria, el desarrollo de las guías de práctica clínica basada en evidencia, la educación continua y la defensa de los derechos de las pacientes. Nuestro colegio se compromete a proporcionar un foro para la cooperación, la investigación y el intercambio de los conocimientos entre las diversas disciplinas involucradas en el cuidado de las personas con endometriosis. El colegio está conformado por la Federación Mexicana de Endoscopía Ginecológica, la Asociación Mexicana de Medicina Reproductiva, la Federación Mexicana de Radiología e Imagen, la Asociación Mexicana de Cirugía Endoscópica, la Sociedad Mexicana de Cirujanos de Recto, Colon y Ano, el Colegio Mexicano de Urología, Ginecología y representando a las pacientes, la Asociación Iberoamericana de Endometriosis para una vida plena, que somos nosotros. Eso es una parte de colegio y obviamente todo lo que se vaya trabajando en esto se va justamente para crear leyes de protección para las mujeres con endometriosis y para utilizar justamente estas guías que están trabajando los distintos colegios que la conforman. Y por otro lado, también estamos llevando una alianza estratégica para lo que es la educación menstrual. Dentro de la educación menstrual, obviamente también vamos a manejar el apartado de que el cólico menstrual no es normal y obviamente hablar a profundidad lo que es la endometriosis. Se va a hacer una campaña muy grande para el mes de noviembre y estamos justamente trabajando parte de esto. Fanny, no sé si quieras comentar un poco más.
Principal es el fomento, la difusión, sobre todo de los canales más allegados para generaciones que incluso están apenas informándose, o también ya a pacientes que ni siquiera tienen como esta idea de que tienen endometriosis. Entonces también estamos potencializando los canales digitales, que es una brecha muy importante, es un gap muy importante en México al menos, porque no es tan fácil encontrar la información. E incluso muchas mujeres estamos casadas de que el dolor menstrual, como dice Eva, es muy normal, ¿no? Que te tienes que aguantar, y esto viene de generaciones atrás y atrás. Entonces, para romper esos esquemas, se pretende también bombardear redes sociales a través de mensajes que puedan darse a conocer con las mujeres que ya a lo mejor no tienen un diagnóstico y ya son adultas o mayores, y a nuevas generaciones, por supuesto.
Y otra cosa también muy importante, derivado justamente de esto que comentó Fanny, cuando nos llegan pacientes, pues siempre una mujer que acaba de ser diagnosticada o que va pasando de médico en médico, lo que necesita es ser escuchada. Necesita que alguien la escuche y que alguien la guíe. Entonces, parte de nuestro trabajo es justamente eso, escucharlas una a una, platicar, conocer un poco de su historia, y ya sobre eso saber nosotros cómo irlas ayudando y cómo guiarlas. Creo que eso es algo muy importante y es algo que no debemos de perder, aunque tengamos una población muy grande. Debemos de darnos un pequeño espacio, por lo menos, para escuchar a estas mujeres y poderlas ayudar, porque cuando una mujer con endometriosis se encuentra justamente una ayuda como la que nosotros brindamos, en verdad que uno siente un respiro. Creo que es algo que, bueno, que nosotros tratamos de dar a la comunidad con endometriosis.
Bueno, muchas gracias, Eva y Fanny. Si gustan despedirse o decir otra cosa, pueden.
Pues muchísimas gracias, y los estaremos viendo seguramente ahí por alguno de los programas o acciones que estamos tomando de este lado.
Muchas gracias a EndoMarch. La verdad es que es un trabajo muy importante el que realizan, y sobre todo muchas gracias también por permitirnos nosotros ser parte y, bueno, ser representante en México de ustedes. Es un gran honor, y un abrazo a toda la comunidad de endometriosis a nivel internacional. Gracias por todo.
Hello, I am Dr. Cameron Nejad, the founder of the Worldwide EndoMarch. I would like to thank everyone around the world on behalf of more than 70 chapters of EndoMarch for the attention, for the assistance, for their care for patients with endometriosis, their families, and their communities all around the world. We are everyone in all the chapters of Worldwide EndoMarch around the world, the captains, the volunteers, the patients, their families, they thank you for what you are doing for the patients with endometriosis around the world, to raise awareness, to do more research, to help patients with endometriosis, their physicians, their researchers, their communities, their politicians to find ways that we put an end to the dynasty of such a very, very common disorder. Endometriosis, thanks to you, all of you, since you responded to our call 10 years ago to raise awareness, has made significant more improvement and progress than 10 years ago. And we are getting more and more, and hopefully getting to some places that, and some progress that we never had it for many years before. And that is all because of you and because of your interest. And I sincerely thank you on behalf of EndoMarch everywhere. With the holidays coming on us, and all of you in a position of hopefully celebrate and have a good time with your families around the world, around the time of the holidays, and at least have a break, we decided to share with you the journey of one of our endometriosis patients, Marketa, her husband Ryan, her baby Stella, and the second baby, and also answer some of the questions that comes along the way. But endometriosis, as I have said it for years and years, is a whole body disease. It is a systemic disease. It doesn't discriminate which organ, and it is far more common. Our research indicated that endometriosis is far more than 170 million that had been reported for years. Our research has indicated that the presence of endometriosis worldwide in the reproductive age people is at least around 1 billion. And that is our, we have published this data in the Journal of Fertility and Sterility, in the Journal of Society of Laparoscopic and Robotic Surgeons. Those data has been reported. And more data, and hopefully with more labs that are becoming available with researchers around the world, that is going to be confirmed further of that presence. And because of that, it's so common and unfortunately so misunderstood and underdiagnosed and unappreciated. Many patients around the world, even they suffer it from not only from pain and infertility and organ dysfunction. Many of these patients, because they don't know they have endometriosis, even when they get pregnant, they have complications, that those complications are related to endometriosis. So that is why we, Worldwide EndoMarch, pioneered with artificial intelligence, was developed an app that it is completely free and at least could guide the patients towards the diagnosis of endometriosis, and it is called Nejat Endometriosis Advisor. It's completely free. It is on Worldwide EndoMarch. It is on Apple and Android. You can use it anywhere around the world you want without the expense of undergoing surgery or any kind of lab test to see if your chances are and how much are for endometriosis. So you can use that app to also help you with endometriosis. And because of your interest, Worldwide EndoMarch has also started another initiative called American and Global Congress of Endometriosis Subspecialists, that beginning of next EndoMarch in its inaugural year, many experts, surgeons from around the world are going to start teaching endometriosis to the younger generation. And this society is going to be including the public, the patients, their families, and the surgeons. So all of them, they collaborate together. It's a mixture of both societies. It is not going to be separate, because patients with endometriosis are integral. They should be part of this education because this is for them. So these are all good news I give you for this holiday season. I know tonight is Christmas Eve for many of you who are celebrating Christmas. I wish you the most wonderful Christmas holiday season. And because again, it is Christmas Eve and also Christmas Day in some areas, Christmas Eve in some area. So to bring you the good news, I'd like to introduce you to Marketa and her husband Ryan and the little baby Stella, and also she gives you the good news about the next baby coming. Marketa, are you online? So let's see how I can get Marketa. When someone joins, anyone who can see the live video.
Yeah. Can you see us?
Okay. Request to join. So I don't. Oh, here we are. Perfect.
Yeah, you're good. You're good. Okay.
Yeah, perfect. Hello, Marketa. Hello, Ryan.
Hi, can you see us?
Hi.
Yes, yes. Happy holidays to you guys.
Happy holidays.
Thank you. You too.
Good to see you again.
Wonderful to see both of you. I'm sure your little beautiful, wonderful Stella is somewhere around.
Yes.
And I would like to thank you, and I want to congratulate you, and also wish you the most wonderful holidays. And I thank you very much for willing to share your wonderful story with our patients and also friends all around the world. So tell us a little bit, Marketa, how did you end up with your endometriosis, and tell us the story of your endometriosis. We would love to hear it.
Mm-hmm. So about in 2015, we decided wanting to start a family, and we were ready. And it wasn't happening for a while. It was about a year that we decided to go into a fertility clinic. We found an amazing doctor, Dr. Kelly Beck, and we did a few rounds of IUI, and then we did a round of IVF. And as we were ready to do a transfer, she asked me to do a couple of, if I wanted to do additional tests for my uterus, and I had some weird sensations in my uterus, like burning, and I just had this feeling in my intuition that I need to. There's probably something. I don't trust my uterus. So she ran an additional test and came back positive for endometriosis, and that was the first time I have actually ever even heard about it. I knew about endometriosis and PCOS from just reading about it, but I actually didn't think I had it. My periods were not too painful. They were painful. I had a lot of blood clots, and they were pretty heavy, very heavy actually. But the pain was not too of a concern for me. I guess I was told periods are painful, so that's why I didn't think twice about it. So yeah, after
that is a very good point that you are making, and you know exactly what you said. You know, Dr. Kelly Beck is one of the most outstanding infertility specialists in the country, and she has helped countless number of the patients. And
and I see her patients regularly, and it's amazing how she diagnoses endometriosis and in the patients. And tell us more how Dr. Beck didn't start right away doing IVF and many IVFs. And tell us, because previous time I thought you were being sort of, nobody was listening to it. Tell us more about how did it happen in your fertility journey and the story.
Yeah, I didn't. They have, each doctor has their process. I don't know. Like, her process was, first let's try IUI. I still kind of wonder why we should just test for endometriosis like right away. That's what I would do.
Because she was very, very smart. Because she was because exactly that is many infertility specialists, unfortunately, they don't believe that endometriosis interferes with infertility, and that is why she believed it. So tell me what happened next.
Well, next I had my surgery with you. I was lucky to schedule it pretty fast, a couple of months after my test, and I had surgery with you. It was very successful, and you told us you have a good chance to conceive, and we conceived the next month naturally, absolutely naturally. It was, I was shocked. I was very surprised, but it was right away we got pregnant naturally. And I can go back in time, but we had Estella in September 2019, and now she's 4 years old and a couple of 3 months, and we're expecting another baby that was also conceived naturally. And what's interesting is that I read about the estrogen dominance when you have endometriosis, how it grows back, and so I kept breastfeeding throughout the whole, like, until she was 3.5, and we were kind of trying to get pregnant, let's say maybe a year.
This year?
Yeah, with the second.
Yeah.
I would say a year, but very like just no, just if it happens, it happens. No pressure, like not just kind of see if it's in the cards. And it did happen, but I think I was at the end of the journey for the breastfeeding. I don't think there was like that much milk left, but still I felt like it was preventing me from maybe the growth of the endometriosis. I did it on purpose. I kept going. And sometimes they can prevent you from conceiving as well, breastfeeding, right? But it did happen to us because I was at the end of it. I probably didn't have that much milk, and also so was the breastfeeding. And what else is helping with just breastfeeding, I think. And I did it because I felt good protection for her because it was through COVID. So I just kept going. And that's what I give credit to the new conception, that I think the breastfeeding really helped me. But I'm not, not everybody's, I feel very fortunate to be able to have breastfed for that long. It's not usual, but I think it helped me. That's what I think. But you know better. You know better than I do. So so now we're due in about 2.5 weeks. And my pregnancy has been great, amazing. And I'm 42 years old, and I'm going to turn 43 in May.
Well, congratulations, Marketa. And you look only 32 years old. and very, very congratulations. Very happy for you. And you are exactly correct. Everything. When you breastfeed, because you do not usually ovulate, usually, not always, right. Because gradually, it doesn't always work that way. But when you breastfeed and usually you don't ovulate, you don't have a period, and that is a natural way of the contraception. That is how the nature made it. And although it is not 100%, that has several benefits. First of all, you can breastfeed the baby. Second, because it prevents the ovulation, you do not achieve pregnancy. And gradually, when you, like Estelle, you got older, then you started ovulating, then you get pregnant. Now, if Ryan is available, I'd like to ask Ryan also a question that how, yeah, when he,
okay, I'll be back.
no, I know you have to go ahead and take care of Stella and come back.
Yes.
So Ryan, it is a very wonderful to see you, and you look great. Would you please say your perspective from this journey with endometriosis, dealing with it as your wife Marketa had to go through this process, and what is your advice for the other patients and their families and their communities?
Yeah, that's a good question. I think ultimately I just had to be as supportive as possible. It was, it was frustrating every month, like month after month. And, we were doing a lot to be as healthy as possible. And so it really felt kind of it was very discouraging, kind of month over month. And then, after seeking the fertility treatment, we became more optimistic in general, but still we're not having success. And so, we after the IVF treatment, we had 2 embryos, and, ultimately we wanted to have 2 kids. And so we knew we didn't have many chances. So, when Dr. Beck offered the test for endometriosis, it felt like the safest thing to do, as opposed to like, no, let's just try to do it. It was like, we were almost out of options. And so you really want to try everything possible. And if anything, gives us more insight into what's going on, that we want that, right? So, so we went for it, and, thankfully, we were referred to you like right away. So there was no delay. It was not like, you have to wait 6 months to a year or something like that. It was like, I don't know, within like a month or 2. And then, you gave us a lot of optimism yourself when you said, you did have Marketa did have endometriosis, and the surgery was successful, and you have a good chance of becoming pregnant naturally. So I think you gave us some optimism there, which obviously helps. But yeah, literally the next month. So it was kind of amazing just to see that happen. And, we were so grateful. We literally found out on Christmas Day. I think it was Christmas Day, or it was on Christmas Day when she took the pregnancy test. And it was almost like, I don't know. It was beyond our wildest imaginations of what good news could possibly happen. So that was obviously a major success. And it was like, once it happened, it was like, we got to make sure this works, and so it was still a little bit nerve-wracking, having to kind of wait out the whole pregnancy and hoping everything went well. We had never gotten this far before. This was the first for us after 3 years. So, we were just like walking on eggshells, right? So, but once everything, happened, it was like as smooth could possibly be. And even with this last, we were only really trying for a year, and like she said, she was breastfeeding. So, again, really, really happy, and almost, I hate, I don't want to make this seem that, we certainly feel lucky, but, I feel like it is something of the past, and we'll see, obviously once, we'll see what happens if it comes back. And, I think now we're just going to, she's just going to be checking for it somewhat regularly. And, but it feels like it's really a thing of the past. And
how do you check for it?
I don't know. Anyway, yeah, that's.
You're good.
Yeah.
You're good. Oh, you're good. You can say.
Okay.
I don't know.
No, Ryan, thank you very much for touching important points. Thank you very much. And what Ryan said is exactly correct. Often we forget about the partners, patients who are with endometriosis, they go through a lot. And we often forget the people, the families of the patient with endometriosis. It is just like when there is a patient on the wheelchair, everybody pays attention to the patient on the wheelchair, but they don't pay attention to the person who is trying to push that wheelchair and has to go through the trouble. So
I definitely thought there was some part of it that was me as well. And you know, and Dr. Beck even said, like, you know, there's probably some things that could be improved. And so it wasn't just like, it definitely felt like we were both, you know, involved in it in some way. There were some, we were both kind of, it was happening to both of us, even though I wasn't the one experiencing, you know, the physical piece of it. So
exactly. I am just referring to the emotional, the heartbreaks that you had to go through because you love your wife, and every time when, and I have dealt with this for many years, many decades, I don't want to go over it, but I have seen it, how it could be, it's just heart-wrenching for the partner of the patient who tries to get pregnant. They don't get pregnant every time they are waiting. And thank goodness, I see the happiness very, very often, more often, the success and the happiness than the other side. So that is why I wanted to talk to Marketa and Ryan, that there is hope for people. And what Ryan was referring to about the test that Dr. Kelly Beck did, there are several tests that are at the present time available that could direct the patients towards the presence of inflammation, and because endometriosis is an inflammatory process, that is the test that patient could request their infertility specialist do, or once again the Najat Endometriosis Advisor app, that it is completely free and could be downloaded from the iPhone and also from the Android, and directs you at least to see if you may have endometriosis. And then if it says your chances are high, you can at least get a consultation. But again, or ask you, then they may want to run another test or so on and so forth, as long as you find the proper consulting physician. So the point that you are making, Ryan, is very, very appropriate and correct, that it is good to not lose hope and find the right person, just in your case, Dr. Beck, and there are several other good, there are some many infertility specialists that they do believe, or endometriosis specialists who do believe endometriosis could create that. So it is always good that patient research and find the right physician to direct them in the right physician, because unfortunately sometimes some of the surgeries are being done by all the physicians are good, they mean well, they have the best intention to do the right thing for their patient, but sometimes they are not aware, and what the mind doesn't know, the eyes don't see. Some physicians are not aware of this, and they are not able to, and because there is not enough knowledge, and that is why we are trying to raise awareness. So what is your advice of you, Ryan, and Marketa, for other patients? What do you recommend for them in their journey?
Yeah, I don't know if, you know, obviously we came from a place of where we were privileged enough to be able to do the fertility treatment, right? Like if we didn't, you know, we may, and some people I'm guessing don't have the opportunity to even check for it. You said that you can potentially check for it, so that's obviously great. I would do that, you know, especially if infertility is an issue and there's no other obvious reasons why. That was the hardest thing, was like, because the fertility doctor says the same thing when all the other, there's still a chance that we just don't know why, and so when you don't know an answer, it just really makes your.
For us, it was like unexplained or something,
unexplained,
right?
yeah.
For us, it was unexplained. We couldn't figure out why until the test, basically.
Mm-hmm.
Yeah, 3 years later. But the question was about what do you recommend?
I would say follow the. I mean, like I said, like if we had known about endometriosis before we needed to go to a fertility doctor, I would do that. Again, I don't know exactly how easy that is, but I would certainly want to have it looked into before going down a really long and expensive road.
I mean, I meet women all the time, and when I tell them my story, they say, "Oh, I have endometriosis. Oh, I have endometriosis." So many of them have it. It's like so common, and I don't know how they got diagnosed, but some of them early in life, some later. But when I share my story, it's amazing how many women say, "I have it." I mean, almost every, like seriously, everyone I talk to. It's incredible, and I'm sure things have improved in the last 4 or 5 years since we've done our test. You said you have your app, and then there's other ways to find out. Like things have progressed in the awareness and the test and everything, right? Like it's more talked about, more people know about it, so that's important because I didn't know, right? So I didn't know. So how am I supposed to research if I don't know what's it called? What is it? So it's important to raise awareness, yes, because that's very helpful.
Yeah.
And for couples, don't lose hope when they're going through fertility treatments. And we were determined.
Yeah.
This is wonderful that you are bringing up, and thank you very, very much. This is excellent point. Please tell us, what do you mean when you say unexplained infertility? Because this is a very, very important area, and that is, I appreciate it. Just would you elaborate more, both of you?
Yeah, I mean, obviously they do testing in terms of her eggs, and then they do testing in terms of sperm, and
everything seemed
like it was okay. I went to a renowned urologist to do my testing, and it was like, it was just it was just unexplained, and it never seemed like, and again, like I didn't know about it. No one told us about endometriosis, and so we are really glad that the awareness has become much more prevalent. I would just hope that there's enough medical professional surgeons like yourself that know how to be successful with this procedure. I don't know where that stands in the United States or worldwide. So I'm hoping that there's more opportunities for women who are going through this to get the medical procedure or the medical advice done well, and that so many other women out there can be successful with not only pain management, but
well, this is I thank you, Ryan, again, and Stella. What Ryan and Stella are referring, that we say unexplained infertility. For those of you who are joining us again, I am Dr. Cameron Nejad, the founder of the Worldwide EndoMarch. On behalf of all the EndoMarch around the world, we'd like to thank all of you for your devotion to the patients with endometriosis and their cause of pain, infertility, and organ dysfunction. So we are sharing the good news of happiness of Stella and Ryan, because I'd like to give you good news. Endometriosis, thank goodness, is a benign condition for the most part. The prognosis usually is very, very good if it is managed properly. It is important to diagnose it early, because if endometriosis is diagnosed early, it could be managed properly, because the earlier you diagnose endometriosis, and you know more about it, you know you can do a lot more about it. When Ryan was, and also Marketa, they were referring to unexplained infertility, means in the case of the female patient, or in case of the Marketa, in this case, all the labs, they were normal. All the x-rays, ovulation, everything was normal, and also Ryan, the sperm count, everything was normal. I have permission to say that because they said it is unexplained infertility, so I am with their permission. I say that because they were all normal, and 95% of the patients that I see, they are in the position that they don't come to me, a lot of these patients, because they have the husband, they are trying to have a child, the sperm count is normal, and the ovulation is normal, the HSG is normal, they have tried to get pregnant and they don't get pregnant. They have had, many of them have had IVF, that the IVF didn't work. So they have received, many of these patients, hormones, that the hormones didn't work and didn't help them. So this is called unexplained infertility for the patient with endometriosis, and many of these patients have no pain, because endometriosis doesn't always cause pain, and often many patients have no pain at all. And it is important for us to recognize, and we are hoping to find a method that diagnoses endometriosis early, in early life, because if we diagnose endometriosis in a patient when the patient is in teenage years, then we are aware there are methods that we can use to hopefully control the progression of endometriosis, because endometriosis is a progressive disease. And unfortunately, sometimes I see patients, teenagers, that they have had large endometriomas, that mean cysts on their ovaries, that are chocolate cysts or endometriosis cysts. And unfortunately, some of them have lost their ovaries or their reproductive function, and that is not fair. So if we know early, and we have a test to diagnose early the endometriosis, then we can, as Marketa was mentioning it, in her case, the breastfeeding was keeping endometriosis in check. And sometimes in the younger, when the patient who is in teenage years, and they are not ready to have a child, and we know they have endometriosis, there are many methods that we may use in the form of progesterones, in forms of perhaps, there are different kind of hormones that they are, the side effects are minimal, like progesterones in the arm, or in the form of IUD, or pills, or sometimes birth control pills. We can't control the progression of endometriosis. And because when we control the progression, then the endometriomas, the ovaries, the young patient, the teenage girl, and in her early 20s, the patient wouldn't lose, and the patient wouldn't lose the ovary that is the source of providing the egg for fertilization, because endometriosis is a progressive disease. Another issue is many patients with endometriosis get pregnant, and it doesn't always cause infertility. But many of these people, they miscarry. And one of the main reasons of early miscarriage in patients is endometriosis, you see. So endometriosis, when we diagnose it early, we know that it could cause miscarriage. So early miscarriage is one of the indications, and repeated miscarriage, it could be endometriosis, definitely could cause that. Endometriosis also could be associated with other complications associated with pregnancy. Sometimes endometriosis could cause bleeding or some placental abnormalities during pregnancy. So endometriosis could be a sneaky. The patient could get pregnant. She says, oh, I am getting pregnant. I have no endometriosis, but that's not the case. There are patients that have endometriosis, but they have miscarriage, sometimes bleeding, sometimes placental abnormalities, and even after they deliver a baby, in some cases, the endometriosis patient, they could have complications. So we are in an urgent need of finding a blood test. There are blood tests, saliva tests, etc., but these are coming to the market. But we need even more and more specific tests that are affordable for the whole world, that we know this endometriosis exists and we can help the patient. And the story of Marketa is that she says, look, she was okay, Ryan was okay, this unexplained infertility is so common. And I want to see if Marketa has any more explanation, and tell her a little bit more about the amount of cramping she had, but you thought this was normal or heavy bleeding. Can you elaborate on that, please?
My mom had the same thing. She said, I have cloths, my bleeding is heavy. I just went based on like her experience, but she probably has it too. So you think it's also inheritary, like from inherited? Yeah. And no, I really I didn't give it too much thought, really. I just never thought it was something to be concerned about too much. So yeah, I thought other things were wrong, but not my period. Yeah, I don't know.
Want me to stand here?
No, you don't have to. Just you can. So, and what else was I had something else I was going to share, but I forgot.
No, you remember. As you are going to remember it, I want to touch upon what Marketa said. You see, this is unfortunately the problem with endometriosis, is being gaslit
right.
by mother, by sister, by teacher, by doctor, everybody, because they think, oh, there are young patients in their teenagers that they cannot go, or in their early 20s, they have so much pain that they cannot go to school, they stay home. But and the mother or the sister tell them, oh, that's normal. I had the same thing. And you will grow out of it. When you get older, you will be okay. Excuse me, I just dropped my earphone. Sorry. So they say that when you complete, but that is not normal. Pain is not normal. If pain was normal, every single patient, when they get their menstruation, they would have pain. But not everybody else patient, not 10 out of the patient when they get their period have to stay home because they have so much pain that they cannot go to work, to college, to school. So pain is not normal. And because endometriosis is so common, the society has normalized it.
Yeah.
they have gaslit it, they have made it to be completely normal, and it is not the fault of the mother or the sister or the teacher or the doctor. It is just, it has ingrained that it is normal, but pain is not normal.
Yes, I remember my mom would, and this is very personal, and I hope she won't be, she probably wouldn't mind, but she would just go to the bathroom and be like, oh my God, there's so much. She would just, it would be very normalized in our household that every month she was going through like extreme bleeding, where she would like made it known in my household that I have to go to bathroom. I can't go anywhere right now because I have to go change my pants because it's so, I'm like leaking all over. And I was like, okay. And I was a teenager, and yeah, very normal in our household. So I don't want to say she gaslighted, but it was for her. That was normal, and then it became normal for me. So that's why I didn't think much of it, because I had the same thing, lots of bleeding. But I already said that. So
No, you are absolutely correct. And I have not publicly shared this story, but now that you say I should, I have had many people that have my own personal, in my family members, that they have had bad endometriosis, that we decided to, my brothers and I, two of them, and also my niece are devoted to endometriosis. Our own mother, she didn't, she had several children, but we remember when we were kids, we didn't know why every month she couldn't get out of bed, and we were, as a kid, we were crying, and we didn't tell her, but she had so much pain, we didn't know why. But of course, later, that is why we knew she had endometriosis, and that is why three of us have devoted our life to treat endometriosis. So you are absolutely correct. It is not always infertility. Endometriosis patients, they suffer, and unfortunately, the society over the generations have normalized it, and we published a big supplement in the Journal of Fertility and Sterility. It is called Endometriosis, Ancient Disease, Ancient Treatment. It is, if any of you want it, please let us know. We will send it to you, the whole, and it is very useful that you see this is not new. And I am hoping that now that we are raising, and somebody and somehow we make progress to find some at least a way to diagnose it early. Now, I have often said, if endometriosis was a man's disease, we have had an answer for it. And unfortunately, the society puts a blinder on as soon as they think, oh, it is has anything to do with the periods, or society doesn't want to listen to it. And we have to change that, because endometriosis is not only a disease of reproductive organs. It is a whole body disease.
Mm-hmm.
I see patients that have severe pain every month with bloating, rectal pain, butt pain. They have pain in their back.
Like their lungs collapse or something.
Exactly.
I had stage 4, and so mine was pretty severe as well. But yes, right. And I have a couple of other friends who had surgery with you, and I'm going to keep it private, but they also were successful with pregnancies within this next 6 months after your surgery. But I can't say, for the privacy, I'm not going to say their names, but 2 of my friends, they were successful with their pregnancies after your surgeries within 6 months.
That is a very good point. Thank you for telling me, Marketa, that the issue is important, that if, there are many options for the patient, and some of them they treat, unfortunately, hormones don't always work, and in many cases, they don't work. And surgery.
Go on that, what is it called? You go on like a heavy hormonal treatment and do the transfer, or she said the surgery, and I picked the surgery because I wanted to get cleaned up.
Yeah. Well, you are very smart, brilliant, and that is correct, because unfortunately the hormones often don't work. It is just like you are pouring water on a fire, but the fire doesn't really completely goes off. It is only ashes, and the fire continues to simmer under the ashes. So the issue of the being the whole body disease, sometimes back pain, leg pain, some patients, they lose a kidney and without knowing, because endometriosis is sneaky and could gradually progress. Or a lot of patients, they get a lot of the pain, butt pain, rectal pain, especially if they receive fertility medication, or pain gradually get worse. So, Marketa, any among your patients, what has been the most symptoms, if they have anybody, if they have pain? What has been, like, is it back pain, heavy periods, or leg pain, or?
For them, for my friends?
Yes.
Oh yeah, one couldn't even get out of bed, had to call emergency services, just really extreme pain, just couldn't get out of bed. And the other one, I think also just very, that was the difference between them and myself, that they had extreme pain. Like they had to take time off work, they couldn't function. In fact, there was extreme, and also they had fertility issues. But yeah, because I was always open and I share my story, they also got it checked, and then they went to you, and and then one of them got pregnant actually naturally afterwards as well. Yes, and now they have babies. So that was the difference, that I didn't have the pain so severe, but my bleeding was heavy, but they had severe pain. So
Marketa, tell us, how is Stella doing, and how is your next pregnancy coming along?
She's been such a distraction, I have to be honest. The timing, she had to go to the bathroom, and it's been the whole hour here. In the bath right now, but Ronnie's gonna take her outside, and she's gonna say hello, right, Ron? Okay, I'm gonna get her. Okay, I'll be back in a minute. And
when Ryan and Marketa, no problem, Marketa and Ryan. Thank you, Ryan. I didn't want to interrupt you guys, but the endometriosis patients, you don't. There is a question from on the line that I noticed. First of all, not every. It doesn't mean that every patient has to have surgery all the time. The majority of the patients that I operate on them don't need another surgery. The earlier you diagnose endometriosis and you suppress it, the risk of surgery is less. The recurrence of endometriosis is not the same on every single patient. Endometriosis behaves, in my experience, very differently on different patients. The more severe the endometriosis is, the more advanced the endometriosis is, and unfortunately the risk of recurrence is higher, especially if there is no suppression, if there is no pregnancy, if there is a lot more fertility medications, because they produce a lot more estrogen. The more estrogen, the risk of recurrence of endometriosis is worse. Unfortunately, the more pollution, the areas that are very, very polluted. Oh, look at the beautiful Stella. Hello, Stella. Look at it.
Last turn.
Hello, Stella. How are you doing?
This is Dr. Najat.
Oh, look at Stella. Hey, Stella. Stella looks like Miss America, Miss Universe. Hello.
You want to say hi? You want to wave to say hi?
Hello, Stella. Hello. Oh, look at tooth fairy has come and seen you.
You did hear your nails painted? Show them.
Oh, look at look at those. Oh, you look great. Wonderful. Look at the shots. Yes, perfect.
She is
So
very, very lucky. We're very lucky. They're beyond blessed.
how old are you, Sarah?
How old are you?
Oh, that's wonderful. That's great.
4. Can you say 4? 4. Yeah. 4.
Have you been what have you asked Santa to bring you?
A dolly. Yeah, you got a dolly. Yes. We did the European version of Christmas. We had it this morning because she has been sick last week, so we just wanted to make her happy. So we break all the rules.
That is great.
Christmas Eve in Europe, so we were opening presents this morning, and it was fun. Are you excited about having a baby sister? Yeah. Okay.
Yes. What are you going to call them? Tell us what is your baby sister's name is going to be? Do you know?
Celine.
Oh, she is Celine. Okay, can you say it louder?
Celine.
Oh, what? It's a beautiful name, Celine.
It means a moon, and yours is a star. When we see her face and it will fit, we'll keep that. So any day, in the next couple weeks.
Yes, so there is somebody is asking that please save this video. I like to watch this. So you are a star, Marketa, Ryan, and Stella, and of course Celine, because the people that already want to watch the video even later. So you have done a good job. You see, Stella, everybody loves you.
What you ask? What did you say? She's being. How old? She's 4. Stop with the tongue. Stop doing the tongue. You're just being so sweet. Yeah. What are you gonna do later? Play with toys? Yeah. You had your lunch?
We would love to devote the whole program to Marketa, Brian, and Stella, and hopefully we will visit with Celine also when he comes. So is the name for sure? Stella is this Marketa finished now? Stella has decided that is going to be the name.
It's got the name that sticks around that she's been saying, and we have a few more, two or three more, but this was the first name that we came up with. My husband came up with, and then he said he didn't like it anymore. But I said I'm too late. I already got attached to it, and I think it's great. So I don't know. We'll see what happens. We still have to be open, but yeah, I like that name. I love that name. We'll see.
Well, I am so happy that you're happy. I want to let you know you and Ryan have been a true pleasure and privilege to know you. I have to thank Dr. Beck sending you because you have been so helpful to many patients around the world in some of these sessions that we have done. And you have come and you have been encouraging because I like always to give good news. My philosophy is I like to give good news always to anybody who comes my way. And thank goodness you have been one that has been spreading good news. And I believe in positivity. And whenever I see, and I am, thank goodness, able to carry or deliver good news for the majority of the people. And you have been one of them that has been, your sequel have been all positive. So, and that was great that you accepted this invitation and with Ryan, and that, it has been very useful.
Thank you. Thank you so much. We feel the same way about you. We're so lucky to know you, and if we can help in any way, we'll just keep doing that. And yeah, we're very, very lucky. We got very lucky. So thank you for everything.
With your permission,
we are going to use this over, and also part of the worldwide EndoMarch next year, that this is going to be, this is 10 years when we started EndoMarch, and I know we will help patients for the future, patients like Stella and Celine, her sister, because endometriosis in about 50% of the time could be genetic. So this is why we are striving to find a way to do things to prevent this from coming from getting progress, to stop it, because knowledge is power. The more we know about endometriosis, the better, because endometriosis unfortunately has higher rate of complication, and in rare, thank goodness the amount of malignancy is very little. But when we know in advance and we suppress it, then the risk of ovarian cancer is less, because endometriosis unfortunately could be associated with almost twice, a little bit more than twice chance of cancer. But when you know more about it, you suppress it, and knowledge is power. So I know we are delivering all good news in every aspect, because we are making a lot of progress thanks to patients like yourself and your husband Ryan and your children, and physicians like your physician, Dr. Beck, that are leading the way, accepting that endometriosis is a fact. It does exist. You cannot simply gaslight it. And I'd like to thank you immensely and wish you the most wonderful holidays. And I let you finish with the last sentence.
Oh, I just want to also wish you all happy holidays, and also women who are going through the treatment, don't lose hope. There's a happy ending. Just keep going. Just keep going and advocate for yourself, do your research, and just keep going. If you want your family, you will have your family. You'll make your family. So lots of baby dust to all of women who are going through this. And they don't want the babies, but still, yeah, this is mainly the trying to conceive, which is extremely difficult time in their lives. And I hope they find compassionate friends and support, and they don't have to be in silence. And it's a hard thing to share with friends, but it helps when you have support and compassion and empathy from your friends and family. So it's worse when you go through it quietly. I think for me it would have been. So yes, good luck. And thank you.
I'd like to again thank you very much, Marketa and Ryan and Stella and the baby Celine.
Yeah, we'll send you pictures, and then when your baby is born, I'll send you pictures.
We would love to. We will put it on with your other pictures on one of our offices and we show it to your friends, and when you come by.
Also,
so
thank you.
And also we would like to thank all of you around the world, all the patients, all of the volunteers, and all of their families, communities, what you are doing to make life better for patients with endometriosis and their families. We know the future is much better, I promise you. Things are going to get better and better. And please use the app. The Jad Endometriosis Advisor app is completely free. It would help you. And also, if you can, for the next year, worldwide EndoMarch and American and Global Congress of Endometriosis Service Specialists, go to the website, and we are here to help you. And we wish all of you greatness. And I say goodbye. Bye-bye.
Thanks.
robotic-assisted laparoscopic cervical vaginal myomectomy, a demonstration of operative technique. A 39-year-old female with a history of severe abnormal uterine bleeding due to a cervical fibroid. The patient had a uterine artery embolization in the past and presented with recurrent bleeding. The patient desired to preserve fertility and all reproductive organs. MRI of the pelvis revealed a transmural posterior cervical fibroid measuring 5.5 by 3.6 by 4.5 centimeters. On laparoscopy, the grossly abnormal, enlarged, and bulky cervix is immediately apparent. It is important to have a strong knowledge of pelvic anatomy and the relationships of the cervix, uterosacral ligaments, bilateral ureters, uterine arteries, iliac vessels, and bladder anteriorly. To improve the operative field, a temporary bilateral oophoropexy is performed. The serosa overlying the leiomyoma is opened with a monopolar current, and then vasopressin is injected with the anticipated blanching effect via vasoconstriction. This helps prevent bleeding. Small endometriotic implants are noted and excised. A left ureterolysis is performed to identify the course of the ureter. Once it is known, the procedure can continue. It is important to minimize bleeding, as even a small amount of blood can obscure the loose areolar tissue. Ureterolysis is then performed on the contralateral side, identifying the course of the ureter. It is important to use blunt dissection, as electrocautery can injure the ureter. Once the course of the ureter is known, excision of the fibroid can continue. An assistant provides traction on the fibroid with a tenaculum, while the surgeon performs blunt and sharp dissection. This traction-countertraction technique helps the surgeon shell out the fibroid's capsule from the surrounding cervical tissue. As the dissection occurs in the correct plane, bleeding is minimal. Due to the fibroid's involvement of the distal vagina, with extraction of the fibroid, the vaginal canal is encountered. The assistant delivers the fibroid transvaginally. The cervicovaginal cuff, followed by the fibroid bed, are then reapproximated with a barbed locking suture. Thrombin gelatin hemostatic matrix is laid over the fibroid bed. And then reperitonealization is performed to decrease future adhesions. The oophoropexy is reversed. An examination of the operative field reveals excellent hemostasis.
Good afternoon. I'd like to thank the Endo Warriors of Minnesota for joining us this afternoon on behalf of the Worldwide EndoMarch and the American and Global Conference of Endometriosis Subspecialists. It is our honor to chat with you about the great things that you're doing in the state of Minnesota to increase awareness of endometriosis and to drive progress with regard to treatment, support, and therapy of this debilitating disease. How are you doing today, ladies?
Good.
Pretty good?
Thank you so much.
My first question goes to Kate. She is the Vice President of the Minnesota Endo Warriors. Kate, can you tell us a little about how has changed over the past 10 years, especially specific to your state of Minnesota and the area that you're residing in?
Yeah, absolutely. So our organization started in 2018. Before that, there really wasn't any sort of organization that talked about endometriosis at all. So the organization started and we really focused on support groups and how we could support people in the community. So we, in the past, have done a bunch of support groups. A couple of the specialists from the state have come and talked at our events and support groups. We've had pelvic floor physical therapists, nutritionists come and talk. Our founder and old president, Britt, also had a podcast with one of the specialists in the state, which was super helpful. And I know that has helped a lot of people in the community find us. It's also helped a lot of people in the community get the right information about endometriosis, and really help spearhead their journey down the right path with endometriosis. They talk about everything. It's called the EndoCast, if anyone wants to look it up. It's a great resource for people. We also have done surgical care packages in the past with the specialists, and they were filled with ice packs and water bottles with our branding on them, tea bags, socks, that kind of stuff. Everything that people would want post surgery. It also came with a letter from an endo warrior that they could open after surgery or before surgery, just to let them know they're not alone. We all are in this together. So yeah, that's kind of how it's changed in the past 10 years. We have a lot more support. We have a private Facebook group in the state of Minnesota that anyone's welcome to join. But it talks a lot about the surgeons in there. People get advice from other patients and what to do. And it's just really helpful to have such a great community in Minnesota that wasn't there 10 years ago or even before 2018. Like, it just was non-existent. So it's really great that we have this amazing community coming together and supporting each other. And we're really excited to get back up and running. We kind of went dark during COVID.
Sure. And sounds like you are really doing a lot in the state of Minnesota to empower patients and really create a community that builds support for individuals who are struggling with this disease. Yes. You mentioned that you were working together with some surgeons and other specialists. How is it, Carrie, with regard to the availability of specialists in the area of endometriosis in your state of Minnesota? Is it easy to find knowledgeable and skilled surgeons with regard to endometriosis?
Well, I think that we're really fortunate here in Minnesota compared to maybe some other states that we have 4 surgeons and we that specialize in endometriosis care. And for us, the specialists have to be excision surgery specialists. So it's not just any type of surgery that they can provide, but it's especially focused on excision surgery. And those surgeons are at 3 different facilities, which includes the Mayo Clinic. So we feel fortunate to have access to 4 surgeons, but that's still very minimal compared to the amount of women that need to be seen and the wait list that even with the surgeons that we have available, there's still more demand than supply in our state, unfortunately. But we also are focused on all the supportive specialties that are involved in the care. And that is where, as Kate mentioned, that we partner with just the full spectrum of services that are involved, and they're connected with those specialists as well, our surgeons. And so we're really fortunate to have that broad spectrum of care that's available. And but we do see that that's going to be part of our ongoing work is looking for those opportunities to expand the number of specialists in our state.
Excellent. You know, the state that I live in, I had difficulty finding a skilled and knowledgeable surgeon in the area of endometriosis. However, where I was initially treated, they did bring in the Mayo Clinic to come up with my diagnosis after a little while. So I know that they're doing great work there, and you're very fortunate to have such great, knowledgeable, skilled individuals in your state.
Can I just add one thing too?
Yes, please.
Another great thing about our 4 specialists is all of them take insurance, which I feel like is so rare to find in endo specialists nowadays. So that's also great.
Now, Megan, I know that Kate had mentioned that you have a closed Facebook page, but many people outside of Minnesota can also join that. A little bit about Facebook page and what resources, if individuals go to that Facebook page, they can find.
Absolutely.
To help give them support, someone that's just recently diagnosed or is looking for direction.
Yeah. So we have a community of almost 2,000 members now, which is really exciting to have watched it grown over the years. one of our focuses with that page is we partner closely with Nancy's Nook. So as Carrie and Kate both mentioned, we promote excision surgery. And so working with Nancy's Nook and her list helps us partner with the 4 excision specialists in our state, 2 at the Mayo Clinic, 1 at HCMC or kind of Penn Healthcare, and a 3rd at Maple Grove Hospital, which is catering a little more to some of the rural population. So we work alongside those 4 specialists and try to get as many people as possible referred to them as quickly as possible, trying to target that average diagnosis delay of 8 to 9 years. How can we start to disseminate this information to the wider Minnesota community more quickly and more effectively so that we don't have 4, 5, 6 ablation surgeries prior to excision? So the Facebook page was founded both to support people who already have a diagnosis and know things about the disease, help get them in touch with others who need more information so that they can move forward making the best choices for their care.
And what is the title of that Facebook page, if you don't mind sharing? I didn't catch that.
So that is the Minnesota Endo Warriors. If you look that up on Facebook, you'll find that group.
Fantastic.
The group,
so
yeah, and it actually is called the Minnesota Endo Warriors.
Sounds like this is a great resource.
Sorry,
Minnesota Endo Warriors.
Yeah, the Facebook group, I like the support group one, I think has group at the end of it too.
It does, yeah.
Over 2,000 members. That's innovative, and definitely you are all doing fantastic work. Katie, I know that you are one of the newest members of the Minnesota Endo Warriors. Can you tell us a little bit about how you found this group and your path with endometriosis and getting care in Minnesota?
Well, it's been a long journey. I grew up in a very small town and was diagnosed early on. So when I was 19, I was diagnosed, and it actually came through when I had my appendix removed. My general surgeon just went in and was looking for some other stuff and found the endo. So he just did the ablation. And then my path continues kind of down with working with an OB that would come from the metro to our community and see patients, because there was not a full-time OBGYN at that clinic and hospital. So came from the metro, and I did have, I can't even remember, 4 or 5 more ablation surgeries with that same clinic. And after the last one, I did some pelvic floor physical therapy, and my physical therapist actually told me about the Minnesota Endo Warriors, and also that I should reach out to one of the specialists, Dr. Hegard, just to go and see him. And I really didn't think anything of it, and was kind of nervous because it's like, well, I just had surgery 4 months ago. I'm not going to need anything else. And one of my first meetings with him, he's like, yep, you need surgery again. So we scheduled a surgery, and I had my first excision in December. So I'm very thankful that I was at the place I was for physical therapy, just to introduce me to this group and my surgeon too.
Wow, that's a story for sure. And I think you really demonstrated that endometriosis, it hits individuals from all over, whether you live in a metropolitan area, close to, or in a university area where you have a lot of physicians who are researching, or a rural area. It hits women from all over, and that's why the support and the community that you're building in your state is really dynamic. As we move forward, how do you see the treatments and the care and the continuing to create communities of individuals with endometriosis? How do you see that direction going, and what your chapter is going to continue to do to expand even beyond the 2,000 followers that you already have?
Kate, you want to answer that?
Yeah, I think Megan
or Megan,
you were going to touch on that, I think, a little bit.
I can talk about that. So the Minnesota Endo Warriors are focusing on 3 core principles: advocacy, education, and support. And everything we do falls under one of those three things. We have this wonderful Minnesota community of almost 2,000 members. We want to continue providing resources for them. Nancy's Nook is great at explaining excision is step one. How do we prepare patients and partner with them, moving past excision surgery, bringing in other disciplines, sending people into surgery ready for the lifestyle change that accompanies this disease. If we truly believe it is a systemic inflammatory disease affecting the entire body, we need to bring in other disciplines. And so one of the core principles of our organization moving forward is equipping people to do that, giving them the resources, creating local provider directories with excision specialists, but also dietitians and physical therapists, mental health professionals, fertility specialists. So that's a core priority moving forward for us. We also partner with our excision specialists and local providers to host events aimed at educating the general public. One of our upcoming events is actually hosting a booth at the Minnesota School Nurses Conference, working on building relationships with school nurses throughout the state of Minnesota, metropolitan and rural. How do we equip them to catch patients sooner so that we're diagnosing in early teens, not mid-30s, and getting to excision specialists right away? We live stream all of our events to try to reach as many people as possible. It's great if you can come see us in person, but also wanting to make sure that that education is available online to as many people as possible.
Wow. Now, in addition to your Facebook page, do you also have other social media outlets? And if you'd like, you can please share that with our audience, because these are great resources.
Right now, it is a Facebook page and a website. The website is getting redesigned, so if you go there, it'll say coming soon, but you can see local resources available and meet the new board as we start getting back up and running here. In the future, that website will be built out with as many resources as possible, that local providers link, so that you can help find an excision surgeon, but also everybody else that you need as you assemble your team to fight this disease for the long haul.
Well, big round of applause to all of you, because you are really doing incredible things in the state of Minnesota to empower patients, to provide that building and build that supportive community and network that is so crucial, as you all know from your personal experiences, when you're going through endometriosis and all of the things that come with it. It's a whole body disease, and your support is really tremendous. And thank you for sharing your social media resources. I encourage those who are watching to really reach out. I know I'm going to start following your social media, because it's definitely very informative. Thank you so much, and continue to do the great work that you're doing in Minnesota. We wish you a great day.
Thank you.
Thank you.
Thank you.
We present a case of robotic-assisted laparoscopic repair of vesico-utero-cervico-vaginal fistula, which occurred after emergency repeat cesarean section. This is a 36-year-old female, G3P3003, with no past medical history and prior history of one C-section, followed by a VBAC. She was pregnant and was scheduled for repeat cesarean section at 39 weeks for breech presentation. Unfortunately, the patient went into active labor at 38 and 6 weeks. The cervix was fully dilated when she went to the hospital. Stat cesarean section was performed. There were several upper vaginal lacerations that were repaired. On post-op day number 1, gross hematuria was noted and urology consultation was requested. A CT cystogram showed vesico-utero-cervico-vaginal fistula. Expected management in the form of insertion of Foley catheter was recommended, which didn't work, and the patient continued to have significant urinary leakage due to the size of the fistula. She was offered laparotomy and hysterectomy, which she refused. She was referred to our center for robotic-assisted laparoscopic repair. The surgery was performed at postpartum 8 weeks. This is the CT cystogram at postpartum day number 1, which showed vesico-utero-cervico-vaginal fistula. A Hume uterine manipulator was placed in the uterus. This is a picture from cystoscopy. We can see the fistula between the bladder and vagina. With this large fistula, the bladder cannot be distended. Transvaginally, a pediatric Foley catheter was placed through the fistula into the bladder to block the fistula. Then the bladder was able to be distended and bilateral ureteral catheters were placed. Laparoscopically first, omental flap was prepared to be used later. The robotic platform was docked, and lysis of adhesions from previous C-section between the omentum, anterior abdominal wall, and uterus was performed. Attention was then focused to the upper vagina and bladder flap. Upon developing the bladder flap and mobilizing the bladder, the lower uterine and cervical defect were noted. The bladder was mobilized laterally via paravesical spaces. Here is the right paravesical space being developed, and here is the left. The tissue is very vascular due to prolonged inflammation. The bladder was meticulously dissected posteriorly from the vagina entering the bladder using sharp and blunt dissection. Both transvaginal pediatric Foley and transurethral Foley can be seen and were removed. Bilateral ureteral catheters and ureteral orifices, which are about 1 centimeter away from the fistula, can also be seen. The large vesicovaginal fistula involving the trigone can be appreciated. Next, further meticulous dissection of the bladder from the vagina in the trigone area was performed. Attention was paid not to injure ureteral orifices and proximal urethra. Hemostasis was achieved. The edges of the fistula was trimmed. The entire large fistula can be seen here. The vaginal defect was closed with running barbed suture transversely. The bladder was closed longitudinally with barbed suture in one layer. Placement of ureteral catheters were very useful so as to not include the ureteral orifices in the repair. At this time, the bladder was distended and the repair was noted to be watertight. Necrotic tissue was excised and the cervix was closed longitudinally in one layer using barbed suture. The lower uterine segment defect can be better identified by injecting diluted methylene blue via the Hume uterine manipulator. The lower uterine segmental defect was closed transversely with barbed suture. Methylene blue was then injected through the Hume to test the integrity of the repair. Lastly, the omental flap was interposed between the bladder and upper vagina. The entire operating time was 4 hours, with an estimated blood loss of 100 cc's. Patient was discharged to home on postoperative day number 1 with prophylactic antibiotics and continuous OCP use to postpone her menstrual period for a few weeks. The Foley catheter was removed 3 weeks postoperatively, after a CT cystogram showed no contrast leakage. At 4 months follow-up, the patient is doing well, with no urine leakage, no stress urinary incontinence, no frequency, no dyspareunia, and regular menstrual period.